Шановні колеги, всім добрий день. Вітаємо вас на
Dear colleagues, good morning. We want to welcome you at the International Practical Conference with international participation that is called Lung Health Without Barriers, Clinical Solution, Interdisciplinary Strategies in Diagnostics and Treatment, and support for people with TB and other conditions, considering Lung Health. So we'll be working on this event for 2 days. And hopefully so that this event would be fully in line with your needs, requirements, and then your professional education, medical workers. We are also hopeful that our event will be a playground or platform for you where science, clinical practice meets and the modern medical education. As I mentioned before, the event will be going for 2 days, and during these 2 days, we're going to have 6 different sessions conducted dedicated to the widest challenges of physiology or pulmonology. We will start with a discussion with world trends, development of diagnostics, prevention and treatment of TB. But we will speak about also non-TB microbacterial and post-TB pathology of lungs. And then we will discuss an active detection of diseases, modern screening algorithms, IPC, and interdisciplinary cooperation. A separate session, in my opinion, which will be very interesting, dedicated to the modern diagnostics approaches. And we're not just going to be speaking about the TB diagnostics, but overall the differential diagnosis, the early diagnosis session, molecular diagnostic method, modern microbiological methods that exist in physiopulmonology, the CT, high definition CT bronchoscopy, endoscopy, and also the use of AI in diagnostics. The day 2 of the conference will be dedicated to the portion of work that would be opened by a Pandora box on the innovative approaches in treatment of TB, but not only in we will be speaking about the therapy of TB. We'll speak about the physiosurgery where there is still a place for that kind of treatment, and we will be speaking a lot of the differential diagnosis and treatment and quality of life as well. The next session will demonstrate the digital technology, which will happen tomorrow. This is why I urge all of you to join into that session as well, because digital technology in health are just picking up the momentum, and we will be speaking about the informational platforms that exist and for the support of the patient and for assistance to doctors and for education as well as for other.
Завершить конференцію сесія, присвячена сучасній діагностиці та лікуванню інших захворювань легень. Сесія дуже цікава, тому що ми всі з вами, як клініцисти, комплексно повинні підходити до здоров'я легень.
What we as clinicians can think is one disease is in reality can come up as something else. We can speak about the bronchoobstructive conditions, we can speak about the sarcoidosis, we can talk about interstitial pneumonia, and then bronchoectatic condition, and then thoracic oncopathology and aspergillosis. And those are the conditions that are the most likely that the clinicians are diagnosing and then putting the diagnosis, making differential diagnosis, and then prescribing the correct treatment. And then the leading future experts as for other events, and then physiatry, pulmonology, and allergology, but also our respected partners from public health centers, from international organizations. And together with that, we invited to our conference the representatives of the different departments, the Ukrainian universities, and then practicing physicians. We're also going to have sessions. And then our event, it's positioned as the event from the clinician to clinicians. This is why we wanted to mention that we also have another agenda and our international partners as well that will share the latest and the most active international developments, and then also in the managing patients after TB has been went through.
Так само те, що стосується організаційних питань,
And regarding the organizational matters, on what are the best ways for treatment of TB in ambulatory or outpatient settings before, as the provider of continuous professional education, national training centers of what we are aiming to do for this conference is not only be a source of new knowledge, but also for a professional dialogue of international cooperation and implementation of the evidence-based decision into modern practice. I wish you all nothing but the best. Have a calm so nothing would obstructing you to get new knowledge and skills. And hopefully that this event would not only be useful, but also interesting to you, and you will dedicate your time with pleasure to our conference, to our event, and have a wonderful day, all of you. This was the welcoming remarks for our national scientific centers that are the providers of continuing professional education from our Director General, from me personally as well, who is the head of the organization committee of the conference. But I would just like to give the floor for the welcoming remarks to our multi-year state partner, to Yana Terleva, who is representing Public Health Center, Ministry of Health of Ukraine, Department on TB Control and Prevention, for the welcoming remarks, please. Thank you so much, and good morning, dear friends, colleagues, and then leaders of health clinicians. And we are happy to welcome you on this wonderful, unique platform that traditionally is gathering us here so that we would form the future of lung health, to form trends on the global response for TB. And traditionally, this platform is one of the platforms that continues to unite sciences and practice, and then our general public, and then for us to form the only unified vision, what are the success stories that we are having, what kind of challenges we're facing, and also speaking of to date, and most likely we are meeting in the era of global transformation that any country and all the health systems in the world are facing, not just Ukraine. In Ukraine, the prolonged fighting the armed aggression to Russian Federation, and also in conditions that we are preparing to a new global challenges that are still present on the world's agenda. Together with that, our country, we have TB as one of the key challenges that are still staying for urgent for the public health system. And even though in our system that we are continuing to have the situation with TB under control, together with that the risks are profound, and this conference, this is also will help us to form sustainability for the future period.
And again, success of our actions will depend on our capacity to think in a global manner, to be patient-centered, evidence-based and science-based in implementing our medicine. On top of that, we also have some global successes, which have become possible thanks to our fruitful cooperation within the country with our partners, the leading public institutions, as well as practitioners who are doing all of that in practice. Also, I'd like to make a special note on the success of our country in evolutionary process of applying the modern techniques and technologies in the global scale. Also, we have measurable progress regarding the advanced diagnostic practices. Taking advantage of this platform, and many alike, we are also making a reference to the importance of the timeliness Because we do remember times when we, as clinicians and practitioners, had to wait for 6 weeks up to 2 months for results to come from the laboratory, having the samples referred over 2 months ago. But now this happens within the minute glimpse of time. And that is also important in the context of prophylaxis, having the new technology on our side and the new techniques, particularly the new skin test, antigen-based, which is only one in the list of innovations in the area of early diagnostic and prevention. And definitely the digitalization, IT solutions, as well as other improvements that we are using to address our current challenges as well as objectives. On top of that, we are strengthening our cooperation with the rest of the world, including the cross-border healthcare, despite the war which still goes on in our country, and also the migration issues and implications which are annihilating the borders between the countries and thus could be helping in terms of dissemination of TB, including the drug-resistant forms, but also in the context of European integration, we are making our pathway towards European integration, making sure that we can deliver the best experience that we have, not only in the area of managing TB, but also in the area of leadership. Of course, for us, for our team, this conference is a very potent platform which can and should serve for the benefit of assessing on the one hand, but also designing the vision on the other hand of the epidemiological situation in the area of TB. To better understand the current trends, to better understand the future, to bring together thousands of professionals who can identify, scale up, and disseminate best practices between professionals, between institutions, between the regions, and between the borders, because that is the major investment that we can and should make for the ultimate benefit of the healthcare system and the patients, changing the paradigms, changing our school of thinking, abandoning the obsolete approaches, and utilizing the best advancement in the area of science and technology. And last but not the least, to enjoy our communication and being together both physically and virtually. So taking opportunity, I would like to thank each and every health professional, clinical professional, civil society representative working in the center, all of our partners helping Ukraine, supporting Ukraine, and standing strong with Ukraine, investing their passion, their professionalism, and making sure that we today will be discussing not only current successes, but the future development of Ukraine. And of course, our special thanks to the National Research Center for becoming the host and inviting all of us to this esteemed conference and being one of the most prominent national partners in the area of TB response. Thank you so much, dear Yana. And with that, I would like to hand over the floor to Madam Katerina Hamazina, who is the chair of the PATH representation in Ukraine. Dear Katerina, the floor is yours. Warmest welcome, dear colleagues, dear friends. I believe I should not be taking too much time to describe what the American organization PATH is, because all of you are well familiar with the strong partnership that we have, particularly in the area of TB response, which has the history of not only many years, but decades. This is the strong partnership of working with public institutions, including the National Public Health Center in Ukraine. And the matter is not only to help fighting TB, but to be there side by side wherever and whenever it takes. Also, our history of cooperation with the National Institute for TB and Pulmonary Care also has decades of successful history. We do remember the time when we launched the National Research Center and how we fostered its development. helping with resources, helping with knowledge, and we're happy to see the results of your efforts, because we do remember times when the future was quite obscure. But now the reality is most efficient and promising, and the center is fully functional and potent. Our organization, PATH, is happy to provide support to this conference, and the support from the American taxpayers could not be used more efficiently. And I strongly believe that, because that is another step in strengthening the TB response, no longer the fight, but the actual response to the TB. This is a historical and traditional event already. We have the well-established tradition of having such regular conferences. But looking at the current realities which have been established within the recent 10 to 15 years, we can see very fundamental changes taking place thanks to implementing the innovations on the global level and locally as well. But these are not just words. When we describe Ukraine as one of the leading and most prominent actors and drivers of the response in the globe, because again, we have become the witnesses and the actors of designing them, evolving them, and implementing them throughout the country and beyond. And today, we have evolved to the stage when we have to take a broader look, not just TB, but respiratory health in general. TB is not the end point. Even after recovering from TB, the patient has to continue living healthier and stronger, but not setting aside other respiratory illnesses. As you remember, namely the respiratory diseases take one of the leading positions in the statistics of morbidity and mortality. And that is definitely one of the questions which has to be included into our agenda and addressed purposefully. And that's exactly why we invited not only TB clinicians and professionals, but also other healthcare professionals, including primary care providers, who are opening the doors to the system, being the gatekeepers for the patients. And namely they, the PHC providers, have to pay attention to the symptoms, patient complaints, to provide for timely case finding, treatment and referral, particularly relying on the techniques of differentiated diagnostic of pulmonary diseases, but also making sure we have the well-designed patient pathway to prevent the patient from roaming around different clinicians searching for the right diagnosis when everybody just boldly says, this is not a TB case, please go check something else. But we have to make sure that everything important for the patient and the clinician is well designed, provided, and implemented. And I strongly believe that this conference will be a breaking point. Thanks to our discussions today and tomorrow, we will be enriching our outlook to survey TB in a different manner, to approach TB in a different manner, to manage TB in a different manner, which will make this more efficient. And I hope that we design the agenda that will be interesting and encouraging enough. Also, we might be triggering more questions. We might be setting new objectives. And thank you so much, dear Natalia, for taking the lead in the country when asking these questions, because I do believe that TB control in Ukraine is one of the most efficiently functioning in Ukraine. So once again, warmest welcome and wishing you a productive conference. Thank you so much, dear Katerina, for such words of welcome. Following up on that, I also would like to emphasize that our today's conference, like traditionally indeed, has become possible thanks to the strong partnering support from the proper advanced technologies for health. Earlier, we also relied on USAID support and the support provided by the State Department of the United States of America, making sure that we have a solid platform for our club for our discussions, for our community. So, dear colleagues, please stay tuned, please get engaged. We have a very rich agenda. We have a constellation of speakers who have reserved their time, knowledge, and expertise to be with you. So use that wisely and efficiently. Suggest your comments and questions for broader discussion. As you can see in every section of our agenda, we have not just lectures and presentation, but also floor for discussion. So we'll be looking forward to your questions. Make them challenging, make them interesting and appealing. We would like to make sure that as the result of this event, you will receive everything it takes for you as a practitioner or a scientist to do the best service for the patient. With that, continuing our opening section, I would like to share the floor with Gunta Dravnica, the project manager of supporting efforts to control tuberculosis in Ukraine, implemented by PATH in Ukraine. As you remember, this project also assisted in establishing and equipment of our National Training Center facility. We mentioned about that earlier, but that has to be noted once again. So, dear Junta, please join us for the welcoming address. My dear colleagues and friends, this is my pleasure of extending my welcoming remarks to you. This conference is a really special event because this National Training Center is our reliable partner. Throughout many years, we are happy to be your reliable partners and supporting such important work. Thanks to financial support from the United States government, our project is happy to provide support to this conference and also support your other activities with the results to be presented today. Working together, we are implementing the innovations, make investments into professional development of health professionals, making sure that we can take the modern technology and science of health closer to the patient. Thank you to organizers. Thank you to the speakers. Wishing you interesting discussions, new ideas, and enjoyable communication and productive conference on top of that. Thank you so much, dear Junta, for your welcoming address. And also would like to share the floor for the benefit of welcoming remarks to our good, old, reliable international partner. And I'm referring to the President for Development of the New and Innovative TB Medicines on the TB Alliance, Sandeep Janeya. But before that, I also would like to make a couple of reflections on that organization, which is actually a flagship of technology. And this is the organization which has provided us, the world, with the capacity to use short-term treatment regimens to work with the patients who otherwise would be administered with a treatment course which takes years instead of months. And now, thanks to this organization, we have 6-month regimens which are effective for TB case management. But this is not the end of the story. Our partners continue experimenting and looking for even a shorter regimen. And we are quite fascinated to see some of the new solutions they are currently working on. So now, for the benefit of welcoming remarks, dear Sandeep, the floor is yours.
Dr. Feschenko, Dr. Yano, Dr. Natalia, esteemed colleagues from the Yanovsky National Institute, National TB Program of Ukraine, honored clinicians and partners. Good morning. It's a privilege to address you today at this important event hosted by the National Scientific Center of Physiology, Pulmonology, and Allergology of Ukraine. On behalf of TB Alliance, I'd like to express my sincere gratitude for this invitation. I'm honored to have the opportunity to address you today, and I'm deeply impressed by the resilience, dedication, and unwavering focus over the last 3 to 4 years. Despite extraordinary challenges and realities of the war, Ukraine's commitment to public health has remained steadfast. Ukraine's leadership in the global fight against tuberculosis is commendable and exemplary. You have demonstrated to the international community that deep crisis should not halt progress. Rather, they should underscore the urgency of advancing it. A critical milestone in our continued collaboration and a powerful example of Ukraine's leadership was the rapid implementation of the BPAL-M regimen. When the TB Alliance introduced this shorter, safer, and highly effective treatment for drug-resistant tuberculosis, the Yanovsky Institute, the National TB Program of Ukraine, and the Ukrainian health leaders were among the very first to pave the way for its adoption in the world. Together, you translated clinical guidelines into real-world cures, substantially reducing the time from years to months and helping thousands of patients reclaim their lives. Today, our partnership enters a new chapter as we transition from path-breaking therapeutics to revolutionary delivery. We are moving forward together by integrating advanced digital technologies designed to elevate the standard of TB care nationwide. Specifically, we are incredibly proud to support the deployment of 2 novel digital tools to complement the work you are doing at National TB Hub and the Center of Public Health of Ukraine to ensure the best treatments reach patients even at primary care level. The first is Upskill TB, a modern digital tool that empowers healthcare professionals with expert learning training modules. It ensures that every clinician, regardless of their location, has access to the latest global clinical protocols and drug-resistant TB management skills without delay. And the second is Manage TB, an intelligent clinical decision support system built to assist physicians in designing tailored treatment plans, which will be especially useful in primary care settings. By pairing new age treatments with cutting-edge digital health tools, Ukraine is building a contemporary, resilient, digitized healthcare system capable of defeating TB once and for all. The TB Alliance remains steadfast in our commitment to collaborate with the Yanovsky Institute and the National TB Program of Ukraine, your clinicians, and your patients. Thank you for your extraordinary leadership, your partnership, and your relentless spirit. I wish you all a productive, inspiring, and successful conference. Together, I'm confident we will end TB. Thank you.
Дуже дякуємо Сендіпу за привітання. Ну що ж,
We are
шановні
grateful to Cindy for
колеги,
the
наше
welcoming remarks, so the welcoming remarks and the is finally over.
Ми вас закликаємо
So we are
не
urging you
полишати наш
not
захід,
to
тому що
leave
зараз
our event
розпочнеться
because
саме
right
цікаве.
now the most
І буквально
interesting part
через
will
пару
start,
хвилин
and then in a
ми
few minutes
розпочнемо
we will begin the first session that is dedicated to international approaches in diagnostics and treatment amongst interdisciplinary cooperation to get closer to the clinical practice. So waiting for you in the next session in a few minutes. Thank you so much.
Шановні колеги, продовжуємо нашу роботу. Перша сесія, яка присвячена
Okay, the first
туберкульозу.
session is dedicated to the TB and non-TB conditions of the lungs and also post-TB.
І для першої презентації я
And for the first
передаю
presentation,
слово пані Яні Тірлеєвій.
passing the floor to Jan
Презентація буде
Terleva, and the presentation will be
присвячена
dedicated to the
основним
main
епідеміологічним трендам,
epidemiological
результатам та
trends and the
стратегічним
results and
напрямкам
strategic
подолання
areas of
туберкульозу
works in
в
fighting
світі та в
TB
Україні. Будь ласка, пані.
in the world and in Ukraine.
Дякую, Наталія.
Thank you so much, Natalia, dear colleagues. Let me present the vision of Public Health Center. How does the epidemic situation in TB looks like? What are the trends? What kind of success stories we're seeing? And the challenges that we want to fight together with you. And then please make my presentation open.
Давайте, поки технічно включають презентацію, ми почнемо.
So we have the presentation being put on. First of all, it's worth mentioning that TB is the global issue that has not been conquered in the world, and by the data of the WHO, the world has more than 10 million people who are having TB, and together more than 1 million people, unfortunately, are still dying from TB. Together with that, international goals and objectives that has been dedicated by the WHO
для того, щоб ліквідувати туберкульоз до
to
2030 року,
to remove TB up to 2030, unfortunately, are not reached yet.
Ні, на жаль, в європейському регіоні і
Not in the European region and in our country as well.
Тому та амбіційна задача.
And therefore, this ambitious objective standing in front of us, and then it's not going to be fulfilled. And this really depends on that we've faced pandemic, we've faced the biggest war in Europe that has been started by the Russian economic crisis, migration crisis, and others global trends that are influencing this, as well as insufficient technological progress that we were hoping for when we placed this ambitious goal. If you are to take a look at the main parts of UN and assess the fighting TB and the objectives that are unreached overall in the world are successfully fulfilled and overly fulfilled in our country. You can have a look at express test, and then
54%
54%.
у світі. Охоплення діагностикою лікування тільки
Coverage and
78%.
diagnostics is
Охоплення медичними
like
соціальними
78.
виплатами тільки
Medical social
44%.
payments for
Охоплення від потреб.
44%, and
Охоплення
then
профілактичним
the
лікуванням дітей,
coverage
які
is
живуть без ВІЛ у світі тільки 58%.
and only
І, як бачимо, по
58%,
іншим
and then
показникам також є
and also another
суттєво
indicators there is significant
недосягнутий прогрес. І цим всім
unattainable
показниками зараз
progress, and
будемо
in all those
детально
indicators we
показувати.
go detail in
Україна
detail that
якраз має
Ukraine
хороші такі результати.
still have good
На що слід
results.
звернути увагу, крім того, що туберкульоз залишається глобальною
And
проблемою,
TB is still an issue for the
ситуація
whole
за
world.
міжнародними оцінками, за оцінками Всесвітньої організації охорони здоров'я з туберкульозом в
And
Україні,
then
має
the assessment
певне
of TB in Ukraine,
покращення, що відзначено в глобальному звіті
what was
минулого
mentioned in the
року
global
Всесвітньої
report in the
організації
last
охорони
year
здоров'я.
of the
Україна перейшла з категорії
WHO,
ендемічного рівня захворюваності,
and
тобто
getting
захворюваність
from
за
endemic
оцінками
diseases
ВООЗ
when
в
by the
країні
assessment
вище
WHO
100
is
на 100
higher than
тисяч
100
до
to
верхнього
100,000
середнього рівня.
to
І це є результатом великої злагодженої
and this is
роботи
the result of the
першочергово
line
уряду,
line of work,
Міністерства
both of the
охорони
government and
здоров'я,
Ministry of
Національного
Health,
центру
and then
громадського здоров'я,
also
провідних
public health
наукових
centers, the
інституцій,
leading scientific
міжнародних
institutions,
партнерів,
international partners,
американського уряду і
US
інших
government, and
організацій. ПАС,
also
яка багато
the
років є
PAF
нашим
that for
партнером,
many years
міжнародних
is our
організацій,
partner,
Всесвітня
and
організація
then
охорони здоров'я,
WHO,
TB
International
Alliance,
Organization, TB
Просвіт
Alliance,
Червоного Хреста, Лікарі без кордонів,
Red Cross,
безпосередньо клініцисти.
Medicine Sans
Дуже
Frontiers,
багато
clinicians themselves, and
людей,
many,
які
many,
дійсно
many
докладають
people
свої
that are
зусилля,
really
бачимо,
putting a lot
що
of
є
effort, and we're
вимірний
seeing that there
результат, який
is
продовжує
a measurable
нам
result
давати оце
that
натхнення,
is continues to
мотивацію
give us
рухатися
the motivation
далі.
to move
Разом з тим, низка
forward.
складнощів також
Together with that,
відбувається,
there's a list
якщо
of
говорити
challenges
за
that are still
провідними
staying. If
підсумками
you're speaking about
першого
the interim
півріччя
challenges for the first half
2026 року, то за
of
даними Центру
2026, and
громадського
then based
здоров'я,
on the data
ми
of
зараз
Public Health
бачимо
Center, right
зниження
now we are seeing a
захворюваності на
decrease
туберкульоз на 14%.
in
Це
morbidity
тренд,
for
який
TB
продовжує
and
тренд
14%. This is
минулого
the
року. В
trend
минулому
that
році
continues
також
the trend of
приблизно
last
на
year.
5
Last year,
тисяч
we
людей
also had the
було
same number
менше
of people
виявлено людей з туберкульозом.
less
Разом
detected
з
than
тим, більше
before
7
for TB,
тисяч
and
людей
more than
вони
7,000
зареєстрували з
people we
туберкульозом.
were able
І
to
ми вже
register with
переходимо
TB,
до
and we are
суттєвої
careful in
констатації цього
treatment
факту
of
зниження
just having
захворюваності на
this, that
туберкульоз.
we have a
Адже насправді
decreased
ми з вами чудово
rate,
розуміємо,
because we
що
understand
є
perfectly
певні
well that
програми,
right
які
now
постійно
there are
змінюються, розроблюються з цілею
being a
збільшення
number of
показників. Є
population
міграційні
that
процеси,
influences,
які
there are
впливають.
migration
В тому
processes
числі
that
і
are
обмеження
influencing as well,
доступу
and
до
there's also
медичної
restricting
допомоги,
access
особливо
to medical care,
наближених до
especially the
прифронтових
ones that are closer to
територій.
the
Тому
frontline
тут
areas.
оцінок під ситуацію особливо
Therefore, to such a
необхідно
situation, then
відноситися дуже
we need to
обережно.
treat with as much care
Разом
as
з тим,
possible.
якщо
Together with
подивитися
that,
на
if
один
you
із
are to take a
основних
look at one of the
показників, це
main
смертність,
EP
то ми також
indicators, which is
бачимо, що є
mortality,
доволі
here we're
таки
also seeing that
стійка
there are
тенденція до зниження рівня
unstable
смертності, і в цілому
tendency
ми
for the
прийшли з
decrease
років
in mortality,
організації
and in
смертності
5 years we decreased the
30%.
mortality
Але
by 30%.
ми бачимо зараз таку
But together
тенденцію,
with that, we
що
are seeing a
частина
trend
людей
that the
виявляється
decrease
в пізніх
right now,
стадіях, в
we
тому
have more
числі
people in the
люди,
later
які
stages being
хворіють
detected, and
невиліковною
also people
хворобою,
with the
все-таки не
treatable
всі
conditions.
одужують. Тому
Not
будемо
everybody's getting
вважати
well.
успішним
Therefore, we
динаміку
will be
смертності,
considering
коли
the dynamic of
всі
mortality a
будуть
success story when all the people will
результати.
be
Ми
able to get
маємо
better. And this is
ставити
the objective
перед
that
собою
we
всі
are
разом.
placing in front of
Наступне, на що ми
ourselves. The
звернути
next
увагу,
thing that we
це
wanted to point our
певні
attention, which is the
дії
global
на
influence
програму
of HIV
туберкульозу.
to TB
І
programs.
традиційно саме він
And
є
traditionally,
взагалі одним з таких
HIV
основних
is one of the
рушійних
main
факторів в
moving
цілому
forward
епідемії
factors
світу по
for
туберкульозу. І
TB
саме з цим
epidemic. And
пов'язано
because of
зростання
HIV,
інфекційності
we
людей,
have an
охоплення
insufficient
туберкульозом.
sufficiency
Давайте
of TB
подивимося.
treatment.
За
Let's have a
прeliminarними підсумками
look
6
on the
місяців
preliminary results of 6
2026 року,
months of
в
2026
структурі людей, яких
and the
виявлено
structure of
туберкульоз,
people who are having
16,8
TB.
займалися доглядом за
16.6% were
цією інфекцією.
there are
Досить
people
наша
who live with
тенденційка
HIV,
тенденція,
so
зокрема, в
that this
минулому році
unstable tendency,
трішки
because in the
була більша
past
частка людей
it
з
was a
інфекцією серед
higher
нових випадків
percentage of people
епізодів з
was the
туберкульозом.
new
Зараз
episodes
знову
of people
трішечки
with TB.
ситуація
Right now,
стабілізувалася.
the situation
Звісно,
sort of
потрібно
stabilized, but
продовжувати
together with that, we
вивчати,
still need to
накопичувати
continue to
ці дані,
analyze, to acquire this data, and then to continue to
взаємозв'язок і
reinforce the
взаємодію між
connections and
програмами
interaction between the TB
боротьби
programs
з ВІЛ.
and HIV
В цьому році всіх нас певно
programs.
спонукала
And
ситуація,
so
коли
all of us has been moved by the
від
situation when the frontman from one of the extra pulmonary TB forms, and this is the great for the whole country. Together with that, we need to understand that overall, within the country, the situation of extra pulmonary TB is staying in the stable levels In general, it is considered that only around 10% in the overall conditions with TB, we have a portion for extrapulmonary forms, which means that there is a correlation with how things are supposed to be, and we are seeing that right now 7.6% on extrapulmonary forms of TB. That therefore, overall, saying that we have an underdetection of extrapulmonary forms of TB, we don't have, but together with that, taking into account that there is a global issue in the world with the detection TB, we can say that this is around 25 to 30%, and there we can say that there is another detection of TB among children, extrapulmonary forms of TB. Therefore, we need to continue to reinforce the workforce potential and the capacity for extrapulmonary forms of TB detection. And we are very much worried that there is a complex situation overall with the resistant forms of TB in Ukraine as a top 10 countries with the highest burdens of the resistant forms of TB. This does influence the whole effectiveness of anti-TB program. And also, what is worth mentioning here, you can see on the map of the world, the darker the colored and the higher levels of the resistant TB together with us from one side, their neighbors that had even higher levels of resistant TB from another side. There are countries with the Europe that are having much lower level of the resistant TB spread. And in conditions of war, when you have more than 5 million people have migrated to the European countries, this is creates the responsibilities in front of our countries so that we would not influence the incidence rates in the European regions and for everybody not to have the resistant forms of TB. I am a national focal point on data on people who are moving out. If you have patients with the resistant forms, we're following the data protection, and this is all being aligned. If somebody doesn't know, then reach out to public health center or to your regional physiopulmonological center. Today, we do have an opportunity to pass the data on every person throughout the world. And this is an aligned process and depends on how ready you are to give this much attention to your patients. And so the next thing that it's worth mentioning that even though that we put a lot of efforts and we are seeing the overall reduction and improvement of situation with the resistant TB in the past year, we had the first trend that we need to point our attention to, which is that we have increase in spread in the structure of people having the TB, the list of resistance, and then especially among novel cases and additionally confirmed cases. So most likely that the spread among the general population has increased, and then with lab confirmed cases somewhere we are not treating, so there's probably not enough attention being given to the effectiveness of treatment or support of people during treatment, control over treatment. And this is also worth mentioning. And together at the same time, this is not just like a trend in their country, but overall, the resistance is being perceived as a new threat to the world, and especially WHO Director General Tedros, director of WHO, that mentioned that the future is a part of the reinforcement of diagnostics and treatment. This is not just TB related. And the list of articles that are saying that the resistance to medication is growing, antibiotic resistance is growing, and then one of the antibiotics of the wide profile is just fluoroquinolones that are widely used in our country. There's also an increase in resistance profiles to it. At the same time, because of war, which influences the increase in spread of the resistant forms of TB, please look at the article that has been issued just a few months ago in a licensed international journal, an international article that assesses all of the countries that are fighting TB in the conditions of war. And our experience is unique, and the experience of Ukraine in this article for a few times has been mentioned as one of the success stories in access to treatment, short-term regimens, patients-oriented regimens, and then it was given as one of the leading practices examples that can be used also for the organization of programs for TB within the crises. And then all of those additional factors that had been influencing the effectiveness of TB finding, they're being put within our strategies. And so what are we doing as a country to hold the situation under control? So here, I would just like to put a quote of our chief state secretary, Doctor of Ukraine, Ihor Kuzin. Ukraine has to move to build their own country without TB. This is something of a continuation of a trend and an obligation the WHO put to us and to the Chief State Secretary, Doctor of Ministry of Health of Ukraine. Ukraine without TB, which is a part when the government can guarantee to the government the level of protection and the health system is capable to prevent its spread. So this is what and not only medical sectors to be involved, but there's also have intersector approaches that need to include Ministry of Health, Penitentiary Service, international partners, practitioners, patient organizations. And so for that, we have a whole list of platforms, which is a National Guard, a National Board. And so one of them had happened in December last year. And so Ukraine is forming state policy to international standards and global strategies and Euro integration objectives. And we are supported, and then the comprehensive assessments, like we're recruiting international institutions to understand the and then for the mission from the WHO, the report is accessible at the BHC webpage, the general progress that we need to focus on. And then you can get familiar with that. But if you go into what are the most practical things that you're seeing, and then if you're one of the most important focuses in national programs, the effectiveness of fighting things is depending on the diagnosis. And if you are to take a look, then the planned progress is going in coverages of bacteriological confirmation. And right now we've reached to 81%. And together with that, and then the 100% result. And then there is a need to look for options. And then not receiving the conferred diagnostics because of the list of accessible instruments. And then we've seen that we have high indicators. And then the objective is not yet reached. There has to be 99%. And then we are seeing that the treatment of anti-TB medication is in the high level at 90%. And then the position of our international programs that we are having coverage was that for the second line medication and to have 90%. And let's have a look at what do we have to sustainability or new anti-TB medication, dopamine and other things. And then we're seeing based on the data of anti-TB service on the last 3 years, we're looking that there is a significant trend to the spread of resistance to the new anti-TB medications. You can see that every year there is a reduction in conducted testing, just connected to the population's lesser, and then there's less people with TB. And the list of resistance is growing, which is the signal that we need to reinforce the control over following the treatment, because the issues and the lab diagnostics we are seeing because at the same time, because of this Institute of Physiatry that a national reference lab and public health center, and then the regional epidemiological labs. The labs are one of the strengths within their national program. And right now, even more success stories are going in there. So we, in the scale of the whole country, are moving to the international accreditation, which states that we have a high level of professionalism of our labs. So here is from the Zhytomyr National Anti-TB Centers. And then more than a half of the labs have went for the accreditation, and we are forecasting that next year this process will be finished with all the countries' labs to be done there.
When looking at the accomplishments of TB care, here we can see a lot of progress, particularly in transitioning to primary care interventions and immediate initiation, revising the criteria for hospital admissions. And here we're communicating with the Ministry of Healthcare to present our concerns regarding the TB care accessibility. But also looking at the numbers, we can see that almost half of the people receive sensvapamin for care and treatment. And again, we discussed that number of times, but we have to brag once and once again. This has to be acknowledged and encouraged. But that is the transitioning to the short regimens, modified regimens. And here we have the credit and merit to be paid to the clinicians, to the institute who supported the National TB Response Program, international partners, including PATH, who were pioneering bedaquiline availability in Ukraine. And this was the first brick laid in the building of this new modality. So now we have the drugs available. But we have to make sure we are monitoring the application of the new and modern regimens very closely. Because looking at the indicators, we can see that Ukraine is at the top of the chart, the European and global progress. But when it comes to success, unfortunately, these rates are lower than in Europe and the rest of the world, despite the fact that we are more expedient in making sure broad accessibility is available. So, because indeed, in other countries of the world, including Europe, availability of the short regimens, latest generation drugs, is lower if compared to Ukraine. But that means that the national strategy and the standards, including clinical guidelines and the regimens and drugs, should be tailored to make sure that we can make treatment success more prominent, more reliable, and effective. Because we have to understand whether or not we have any other uncontrolled conditions non-attended in our patients. Maybe the drugs are not used effectively. Maybe there are some other deviations from the standard, and that's where we have to strengthen our oversight and mentoring, making sure that indeed all the patients, all clinicians receive the best of the service, both in the inpatient and outpatient setting. And this year, our strategy would be to cover at least 50% of patients by family clinicians, providing them with TB care. That is our goal, and our team, together with the Ministry of Health, have designed and approved the respective regulations back in 2024. So now is the time to make sure that happens. Moreover, this is supported by international organizations, by social support provided, and in pilot regions, there is a special initiative under support of the Ministry and the National Public Health Center. So legislation is there. Projects support us. And we can see that the number of people covered by medical and social support services is quite substantial. If we are talking about drug susceptible TB, that's over 60%. A drug-resistant TB, that would be more than 80% in terms of coverage. But here we can see that the targets regarding the number of people who are lost to follow-up are quite high. 5 and 15% respectively. But looking at the goals and targets that will be measuring the success should not exceed 3%. So there is clear indication that we have to strengthen our performance. We have to improve that, making sure not only goals but targets are also met. On top of that, we should be mindful that we need combined efforts of medical community, but also community-based interventions. Thus, our team has made a flagship initiative, Free of TB, And this was a colossal effort. Thank you all the partners who made their contributions. And looking into the latest reports, we can see over 200 communities who joined this initiative. But the number of such communities should be growing larger. And thus, we will be making our TB response stronger, addressing not only TB, but other associated phenomena such as stigma, for example. Because looking at the patient surveys, every third patient is facing different manifestations of stigma, one way or another. So we should be tolerant as well as professional. And we should be seeking support from the national public awareness raising campaigns, which are effectively implemented over the course of recent years. But they should not be just individual events like TB Day or TB Week, for example. They should be a sustained effort which is implemented in everyday routine, making sure that the vast majority of the patients is covered, but those who are not patients so far should also be aware of TB, and they should know that TB is curable. And we should also continue designing and building our national response as part of the national strategic dialogue under the leadership of the Ministry of Health, but also relying on the capacity of such platforms like we are hosted by today in order to invite and attract international support, assistance, and partnerships. Because participating in such conferences, international conferences here and there, that brings together our clinicians, practitioners, epidemiologists, scientists, and community representatives. And one of the biggest platforms would be the Global Summit, where Ukraine was represented recently and made one of the keynote reports and presentations. So again, this is something that we can benefit from. And this is also the way and style we are making our contribution. Quite recently, we also made an additional request to the Global Fund applying for the donor support, and Global Fund is one of the leading donors in the area of TB response. And the matter is over $50 billion US to support the Ukrainian TB response program, thus strengthening capacity of Ukraine to deliver on our objectives despite the war still going on. And here, again, we are relying on the resilience of our professionals, people who are working with TB on the daily basis, providing care and support to the patients and their families. And quoting Irina Petrusenko, who's a medical nurse, we can see an example of personal and professional commitment and sacrifice that they are making for this better cause. To reinforce that, indeed, we are integrating the system, scaling up those innovations which continue to be generated globally, and thanking for such opportunity, thanking all the partners and hosts, organizers of this important conference that we are part of here today. Thank you for the floor. And thank you so much for your highly intense in the context of form and context, as well as passion and emotion that you invested into your presentation, describing the realities, the opportunities, the challenges we are facing, but also the solutions that we have in front of us and at our disposal. Now, dear colleagues, do enjoy the format of our conference, which opens multiple communication channels to you, so feel free to put your comments and questions in the chat so that we can refer to those later in the Q&A session. Now, next presentation will relate to the new non-mycobacteria infections and diseases, which is gaining pace across the planet, and also the area where multiple innovations are taking place, thanks to new diagnostics and new treatment regimens available. But at the same time, we have to acknowledge there is a shadow zone which has not been studied extensively and which does not benefit from such extensive support, how to better phrase it, on behalf of the medical community on the one hand, but also the system players, and that would be non-tuberculosis mycobacterial diseases. Because looking at all the successes of managing TB, we also have to acknowledge something which is manifested by the proverb that there's no idle space which will be left unattended. And if there is no mycobacteria, then non-mycobacteria will definitely start dwelling in that location. How to best understand and respond to that, and what to do in that case will be the purpose of our next presentation and discussion, trying to better understand what is non-tuberculous mycobacterial diseases. These are environmental bacteria, also coming from the so-called municipal and communal sources. This is a very big family of pathogens, and all of those who are familiar with Mycobacterium of tuberculosis, which is part of that family, that also includes the leprobacteria. So thus these are pathogens for tuberculosis and leprosis. Just by themselves, they also constitute a very big group, over 190 species, including MAC as subtype of Mycobacterium avium, and intracellular included, which is particularly dangerous, and Mycobacterium abscessus, which is so rapidly growing and unfortunately becoming more and more common. So let us try and understand why diseases caused by such pathogens become a new clinical challenge. First of all, because of the aging of population. We all acknowledge this is a problem. We have a growing share of people of senior age. On top of that, there are chronic diseases of pulmonary health, COPD, ectasis, other structural changes. Then immunosuppression and immunosuppressive medicines on top of that, which are widely used in case of autoimmune diseases and systems, biological active therapy, HIV infection, and that list is not conclusive here alone. On the positive side, we have improved diagnostic capacity because science and technology is advancing. The quality of such technologies definitely is improving, but thus we can see the incidence rising because of the new cases found. And thus we can see that the statistics in the charts are going up. Looking at our statistics over the recent years, particularly speaking of drug-susceptible TB, that would be 2.8%. Drug-resistant TB also 2.8%. The NMTB. And speaking of the patients of post-recovery, that would be 3.8%. So on average, that would be 2.6%. This number seems small, but indeed, we have to dig deeper into those numbers. We need broader statistics, including the regional scale as well as the national coverage, in order to better understand what is the actual gravity of that problem with non-tuberculous mycobacteria. For example, looking into the numbers of other countries, such as Japan, there we have about 15 per 100,000 population incidents, but non-TB mycobacteria caused diseases would be substantially higher than TB incidence. So, looking to some interim conclusions, this is not just a laboratory significant finding. This is one of the causes for progressive lung disease, which has to be diagnosed, treated, and addressed properly. Diagnosing and even suspecting such condition among immune-compromised patients, non-specifically manifesting patients with fever, with cough, or with some uncertainties that we visualized in CT, post-TB, fibrosis, and other manifestations that we can see among the immunosuppressive patients. Another Quite an important patient cohort would be the people frequently asking for hospital admissions, frequent invasive procedures, and also those who are exposed to environmental factors. Some of the elements of high concern would be patients with bronchoectasis, immunosuppressions, particularly if their symptoms and manifestations are progressing. Looking at the new international approaches and guidelines in that respect, because the conventional approach was quite straightforward. The culture testing, diagnosis confirmed, standard regimen prescription, and then looking at the results. As of today, we can see this modality is changing in order to identify the active disease of lungs, which is not caused by the TB mycobacteria. We have to look at the trinity of factors, and such combination, if that is observed in the particular patient case, should be treated as a clinically significant condition which needs individual treatment plan. And then in the course of such plan implementation, we need additional microbiological monitoring, additional to clinical oversight. And thus we'll be treating not only the positive patients, but a clinically significant condition. Decisions should be made based on the survey of such elements of the trinity I mentioned: the clinical presentation, radiological changes, and microbiological testing results. If all three elements come together in that particular patient case, that confirms the fact of having an active phase of disease, which has to be monitored and diagnosed appropriately in order to do the susceptibility testing as well, and then to assess the results in a comprehensive manner. When it comes to diagnosis, again, these are the three elements, starting with the microbiology. Here we have to identify the active actor of disease, and if there are two positive sputum sample culture tests, and or histological confirmation, and at least one positive test results of the culture testing. But how will clinical observations be helpful in that regard? Coughing, sputum excretion, blood availability in the sputum sample, the apnoea. We follow that on top of the results of microbiological tests. That would be strengthening our hypothesis. And then looking at the imaging. Once we can see the multiple nodes, caverns, and we definitely can and should suspect mycobacterial infection to be defined and diagnosed later by the microbiologist. And then only definitely excluding other implications, because we have to suspect TB, interstitial diseases, cancer, fungi, and then only based on that differentiated diagnostics, we can decide the appropriate tactics of treatment. But starting with the infection stage, comparing TB versus non-TB mycobacteria, we do understand that human-to-human transition happens in case of TB, where the TB positive patient becomes the source of transmission. If this is non-TB mycobacteria, there would be the environmental source, such as soil, dust, water, sewage systems, medical equipment, and airborne way of transmission. In case of non-TB would be inhalation of aerosols or direct exposure to contaminated water systems. So this is no longer about human-to-human transmission. This is routine transmission between humans in their habitat, and this has to be kept in mind. The key reservoir would be the human, in case of TB, and environment in case of non-TB mycobacteria. And of course, there should be a different system of infectious control implemented under the circumstances to make sure we can control the infection.
Mycobacterium abscessus transition between humans and patients with cystic fibrosis. Other options, which is the transfer from the environment to a person. Apart from TB, non-TB mycobacterium are not in line with the critical contagious infection. The main sources of infections is natural reservoir from the environment. And why such a difference is present? Because there is a key biological specific of non-TB mycobacterium. They create a biofilm that gives them the ability to hold to surfaces. It gives us the ability for prolonged survivability, protection from disinfectants, resistance to antibiotics, and constant spread. And where those biofilms are in nebulizer, bronchoscope, reservoirs for water filtration system. So why this is important clinically, the constant stores of being infected, intra-hospital risks, recurrent infection, the complexity in eradication, and a controlled over water supply system. So to form those biofilms is one of the key reasons of non-TB mycobacteriums in survivability in the environment, its sustainability to disinfection and constant exposure to human being, which signs the specifics of IPC, the control of water system. This is the main idea in non-TB mycobacterium and all the other infections that are causing biofilms, and then preventing biofilms in the environment, adequate disinfection of medical equipment, and regular monitoring, multidisciplinary approach. And if you are comparing IPC in TB and non-TB mycobacteriums, yet again, I'd just like to highlight, so what do we have to do? Water quality control, water supply system, bronchoscope control, and control over nebulizers if they are multiple use nebulizer, multiple level disinfection, and this allows us to do prevention of biofilms and completely different approaches to IPC and use anti-TB algorithms for non-TB mycobacteria is not needed. So what are the methods for identification of mycobacterium? As it was demonstrated in the previous slide, the classical methods, which was the detection of positive culture, there have been additional biochemical tests and some of the enzymes to be detected that are typical to those mycobacteria. And the phenotypical specifics and all that went for a long time. The results was received later. This was low precision. And what are the modern methods that exist? They are on the screen, and if you say shortly, this is the modern methods of molecular genetic diagnostic using MALDI-TOF PCR with the type specific and sequencing, and this, well, different types of sequencing from targeted to full genome sequencing to sequencing of separate genes in automated systems. And so for our country, and some of the methods for us are accessible, and some of the methods are only being developed or planned. But this is something that's being recommended by the international experts so that we would be able to effectively conquer or at least control this infection. And then for the identification, the selection of the types of treatment, which is great because different types of those microorganisms require correct identification procedures, and because for that, and effective treatment regimens, the clinical significance of isolate, and then it prevents the unjust treatment and the forecast and need for susceptibility testing, which is the different types of different profiles and different forecasts for conditions. This is why it's very much needed to make a correct diagnosis. What is the non-TB mycobacterium? They are shared to two types, the saprophytes and conditionally pathogenic. And so they're growing more or less And the main representatives are from the ones that are growing slowly, which is the MAC, Mycobacterium kanzasi, and rapidly growing, which is Mycobacterium abscessus. And then clinical significance, the biggest in the world, the most frequent in the world, where the identification is being done, which is MAC complex, Mycobacterium abscessus, and Mycobacterium kanzasi, for others that are being seen much more rarely. And the big group of saprophytes, they don't have any clinically significant for us. They only exist in the environment. They don't cause a disease in adult population. And so who to treat and who to observe. So where can we see saprophytic flora, and then where is the flora that requires treatment? As we mentioned before, up to 2020, it was just the diagnosis is confirmed and that the treatment start right now. It's not enough to confirm the diagnosis. You need to comprehensively assess the clinical factors and then select individual decision on every patient separately. Based on what are we guaranteeing our clinical conclusions? How big the symptoms are, the continuous microbiological confirmation. So we remember, so one culture from sputum is not enough anymore. And so we need to assess the immune status and comorbidities. Remember which statuses are most likely being support, like going hand in hand with that infection, progression on CT and identification, and then comparison risk benefit ratio. And only then we are making the decision either we're starting the treatment or are we conducting dynamic monitoring or not. What are the modern approaches for treatment, and what are the algorithms for selection of the algorithms for treatment? Then we have three main areas right now, which is the approach to treatment of MAC complex, which is macrolide-oriented regimens, which is the Mycobacterium kanzasi requires rifampicin selected regimens, which can be isoniazid, rifampicin, or rifampicin. And the most important part, which is the Mycobacterium abscessus, an intensive multi-component regimen where injectable amikacin with macrolides are being used in other types of medication. On the right part of the screen, what you're seeing, what's new. So it's right now the developments are going on the use of the modern anti-TB medication or reprofiled medication that is being used in TB for the usage of non-TB mycobacterial infections. The modern regimens, macrolides, are still staying the heads of the treatment for everybody who's MAC having profile, and also Mycobacterium abscessus is being recommended in the complex forms of Mycobacterium abscessus and other types in case the other medication is not being well tolerated. Amikacin liposomal or inhalational is recommended in cavernosus processes in the high bacterial load. Carbapenems are being recommended in Mycobacterium abscessus in the intensive phase. And also please point your attention, bedaquiline, a flagship for treatment of TB. Right now, there's also clinical trial conducted for the resistant cases. Right now, there's only restricted clinical data on the effectiveness of the usage of bedaquiline for that, and the decision on inclusion of bedaquiline into the treatment of, for example, complex form of Mycobacterium abscessus has to be conducted on the level of expert center. Shortly on liposomal amikacin. What is that? This is the inhalational solution of an liposomal form. First and foremost, right now the research is present on the MAC group, and the treatment is ongoing, and it so far has a niche for being prescribed after 6 months of the standardized treatment that was ineffective. We are making a conversion of the culture, and the treatment is ongoing as a combined regimen according to the general recommendation, not less for 12 months after the conversion of the culture. And then the research is still ongoing regarding whether what is supposed to be its optimal longevity. How is it working? Better delivery system into the lungs, liposomes are going deeply into the airways. They're going to the places, caverns as well. And then that way they're providing for a higher concentration and the place of infection. The longevity and duration of treatment and monitoring during treatment are two important matters or issues that right now there's no 100% answer to, which there's only proven results on the longevity of MAC complex, and then the treatment has to go for at least 12 months after conversion of the culture. The same thing goes for Mycobacterium consensum, Mycobacterium abscessus. Unfortunately, there's no specific recommendation on the duration of treatment. The only thing that we can see from the results of different research and from the practice that the longevity is being individualized, and frequently it's much longer than 12 months after the culture conversion. And the monitoring has to be conducted for, as in TB. It's better to do the sputum sampling every month, but it's mandatory that clinical assessment, CT, and the dynamics control toxicity of the medication, and then the results assessment for treatment. In more or less formed approach to this, only been formed this year in 2026, the international experts have given us the instruments according to which we can assess the results. So we have the reconvalescence, which is clinical, microbiological. If somebody got better, and reinfection as well. So, but the most important part is that in every patient, so that to get to the results, you need to do the assessment of the 5 different things, which is the clinical response, microbiological response, radiological response, and how well the treatment is being went through, and then the quality of life. Another treatment of non-TB mycobacterium is also it's a serious matter. Right now, there are still discussions going on how to correctly unify the approaches to such cases. And the only thing is that was clear to us is that it's near TB. And the comorbidity when we have positives, and the same algorithm going forward. And all those approaches that are going for the permuted and the repeated, and the future in treatment of non-TB mycobacterium, from the personalized treatment to the new technologies. What is being used? This is the inhalational liposomal amikacin, bedaquiline, linezolid, clofazimine, and then personalized in treatment. What is actively being researched? Bacteriophage treatment in the first line for the Mycobacterium abscessus, the new oxazolidinons and other medication, antibiofilm medication. So there's something that removes the biofilm, that substrate that is protecting non-TB mycobacterium for the influence of disinfectants and other types of medication, new inhalational forms, and genome approaches, and a precision medicine. Thank you so much for the attention. This is the last slide where the international expert till 2030, by using those approaches that are on the slides that I have just voiced so far, they have this ambitious goals that this infection will be able to take under control till 2030. So not only about the improvement of treatment, we're not saying so far, but at least to control it. Thank you so much for your attention. And we will be moving on. And then we're having a very interesting topic, which is post-TB conditions of lungs and interdisciplinary approach and international experience of management of post-TB of lungs. We will be presented by and will share their experience, an international expert, Neha Kuksha. And she's working in the University Hospital of Riga from Latvia, who is also national manager on the fighting TB and non-TB conditions, and then post-TB lungs condition from our side, I'd just like to mention that this is the big issues for us. This is a great area where we've always, when we have improved the effectiveness of treatment of TB, we've thought that in case the successful course to be conducted, then our patient has been treated and then doesn't require a future. Right now, we are spreading our horizons and also for lifestyle treatment after the TB will be because the irreversible changes that are happening in the lungs, comorbidities that are going hand in hand with the TB, they're not giving us an opportunity that the person has been fully recovered and recover their health, and what to be in the post-TB period, who is supposed to be dealing with that, and which way we will listen to the experience of Latvia and the experience of international community on this matter. So Liga, the floor is yours if you're here.
For TB survivors. According to the different publications, and this is one of the last publication from the European Respiratory Society, that we have a different understanding of the approaches to post-tuberculosis lung disease. And this study, not study, but article quite clearly defined between tuberculosis-associated lung disease or TB-ILD against the post-tuberculosis lung disease. And TB-associated lung disease is the broader concept. It includes respiratory abnormalities that may be present before tuberculosis, develop during the TB episode, or persist after the treatment. And these abnormalities may occur with or without symptoms and may be only partly attributed to tuberculosis. Because, for example, smoking, air pollution, previous infections, and other respiratory diseases can also contribute to this status. And at the same time, post-tuberculosis lung disease, or PTLD, is a subgroup of tuberculosis-associated lung disease. and that is identified after successful completion of tuberculosis treatment. And as I mentioned before, microbiological cure doesn't mean that patients have not the respiratory symptoms at all. And the key message for this and after this article also is that lung health should be assessed from the time TB is diagnosed and not only after treatment completion. Patients should be discharged from care solely because should not be discharged from the care solely because microbiological cure has been achieved, but the continuity of the care for those who experienced symptoms should be continued. And the nearest years, the evidence is coming more and more, and there is also a new article published this year in Lancet for proposed research case definitions. I will show at one slide later. But it is very clear that up to 50% of TB survivors may live with long-term sequelae. These people have 3 times higher mortality. If you look at the all-cause mortality, these problems can be with or without symptoms, but reflects on the X-rays or the lung functional tests. And lung damage, that's also very important part of the post-tuberculosis lung disease, that lung damage may also occur after previously undiagnosed or untreated pulmonary tuberculosis. So, and the new definition insists on this, that actually that this article pay attention that we have different studies and they used a very different definition of post-tuberculosis lung disease, which made it difficult to compare results across populations and also across the settings. And this recently proposed research case definition aims to provide a more standardized approach. It is important to emphasize that this is primarily a definition for research studies rather than a definitive clinical diagnostic criteria. But I will show later also our experience. This is very important at the very beginning if we think about any evaluation, to be clear about in which cases we talk about post-tuberculosis lung disease or only about sequelae after tuberculosis. And so that, I switched the slides. The patients must have a history of successfully treated pulmonary or pleural tuberculosis, no evidence of current active TB. That's also very important. I will approach this later. And abnormalities in at least 2 or 3 domains. You see the lung function, there are chronic respiratory symptoms or abnormal radiological finding. And these domains are complementary. Some patients may have significant structural abnormalities, but relatively few symptoms, and opposite. And when an abnormality is found in only one domain, the authors of this article suggest using the term post-tuberculosis lung abnormality, or as I said, sequelae, rather than disease. And finally, the abnormality should be attributed at least in part to the previous tuberculosis episode and should not be completely explained by another condition. And this definition, therefore, helps us move towards more consistent identification and reporting of post-tuberculosis lung disease in the future. And for me also was very important to understand, because if you look at the patients, there should be the huge varieties of how a post-tuberculous lung disease look like. And this is summary of articles from 2020, 2023, which explains post-tuberculous lung disease phenotypes. And we see those also in practical life, that for the part of the patient, more their airways problem should be TB-associated obstructive lung disease, and I will show also later case. And not always it is so easy to differentiate, because many of our patients are smokers. This is additional problem. And the second is bronchiectasis, which is also one of the most contributor for the post-tuberculous lung disease. This could be parenchymal problems, residual cavities, parenchymal destruction, fibrotic changes, and also you will touch during your conference Aspergillus-related lung disease. And then pleural problems, most often this is pleural thickening, and pulmonary blood vessel problems, particularly pulmonary hypertension. And for all those phenotypes, there are different recommendations for evaluation and diagnostic tests. So, but for the clinical life, it really makes sense that we understand this meaning of different phenotypes and also approach to them. Maybe this is not a very new publication. This is ARS monography about tuberculosis and the challenge of tuberculosis in the 21st century. When the paragraph is devoted for post-tuberculosis lung disease. And I think this figure very nicely emphasized that prevention and management of post-tuberculosis lung disease should not begin only after tuberculosis treatment completion. It should be integrated across the entire tuberculosis care pathway. Prevention starts at population level by addressing shared risk factors such as smoking, indoor pollution, air pollution, the occupational hazard, and by preventing tuberculosis itself. In people with possible tuberculosis, early diagnosis and rapid initiation of effective treatment may reduce the extent of irreversible lung damage. This is the second domain. This is very important that to avoid very, very severe consequences of the tuberculosis, which should pay attention to the active case finding, tuberculosis preventive treatment in relevant groups, and also pay attention that the quality of the treatment during the treatment, the priorities are effective regimen based on drug sensitivity tests, meaning availability of drug sensitivity tests. We pay attention on good adherence and appropriate management of inflammation. And there are also coming a lot of evidence, and we are looking toward the host-directed treatment as well, like corticosteroids for TB meningitis. And of course, we have several host-directed treatment trials in due, and we are looking for possible adjuvant treatment during the treatment. But as I said, effective treatment according to the DST and also the quality of the treatment and all possible intervention to adhere patient to treatment are crucial. And then after the treatment, patient with symptoms or risk factors need structured assessment for post-tuberculosis lung disease. Relevant comorbidities and recurrent tuberculosis follow-up may then require multidisciplinary services, including pulmonary rehabilitation, management of airway disease and bronchiectasis, vaccination, which is one of the points, and we'll touch also later if we talk about our experience, treatment of complications, and of course, psychological support. The important message is that post-tuberculosis lung disease care is a continuum. It includes prevention, early recognition, assessment of treatment completion, and longer-term follow-up, not simply management of established lung damage. And this is also one of the approaches from the WHO that we can state for the final outcomes for the treatment after only 1 year follow-up. And this is also a very good time and to assess patient also for post-tuberculosis lung disease or provide necessary management for the patient. And if you talk about Latvian experience, that we started in 2022, we did prospective cohort, quite difficult to recruit the treated patients, but we look at the impact of post-tuberculosis lung disease on clinical presentation and also quality of life. And this is that was accepted ARS abstract 2 years ago, and we see that despite successful treatment for pulmonary TB, most patients experience some chronic lung changes. For some of them, only one domain exists, like respiratory symptoms, without the huge different problems in lung functional tests or in X-rays. But what we saw, the sequelae in patients is primarily driven by persistent symptoms and their impact on daily activities. And for us was also the very important message that impaired lung function was observed in 39% of patients, only 6 restrictive, but 33 obstructive. As I mentioned before, the vast majority of our patients, and I will show the latest data, are smokers. And it is problematic to distinguish between the smoking associated obstruction or infection like TB associated obstruction. But this study also brings us to thought that we should evaluate bigger group of the patient and do that more programmatically and more prospectively. And this is proposed our evaluation of the patients who are survivors of tuberculosis. There is no time frame when it was. The only we needed to records that this patient had tuberculosis before. And we are successful to get the grant from the state, and this is mentioned there in the bottom of the slide. And this is information which we are collecting prospectively. We are in the middle of this project, and we look at the medical history, physical examination of the patient, also do the questionnaires like COPD assessment test, modified medical research council dyspnea scale, a St. George respiratory questionnaire, which is quite difficult for the patient and time-consuming, but nevertheless we do this, and also short form 36 health survey. From the pulmonary function and exercise testing, we do spirometry with bronchodilation, diffusing capacity test, body plethysmography, 6-minute walk test, and also newly introduced here in our hospital oscillometry. And imagining for sure blood test, basic blood test, but also paying attention to aspergillus diagnosis and the sputum test to exclude active tuberculosis, and also see what microflora exists in patient with TB sequelae. And those are preliminary findings. Very shortly, because this is not the main story of my presentation, but we see that we have data on 57 participants. This is analysis done so far, but at the moment we have screened more than 120 patients, mainly male patients. 86 were current or former smokers. At the same time, the more than half of the patient report passive smoking, and almost half of them also occupational respiratory hazard as well. In a large proportion, you see 51.8% of the patients we found bronchiectasis, and clinically significant non-specific microbial growth was detected in 30%. This is let's say, eighth of the patient. And also the problem for some of the patient provides a sputum sample, but we see more than internal problem than the quality of education of the patients. Then it is not possible to collect sputum at all. From this group of the patient, we see that microbial growth was significantly associated with bronchiectasis. And of course, one of the let's say, the problems we see that we have very low coverage of influenza vaccination and pneumococcal vaccination, which is a recommendation for all patients with chronic lung diseases. And this is also a very important point to work on this. And from this study is very sure, we are very sure that structured screening is feasible, and effective post-tuberculosis lung disease care requires more than confirming the diagnosis. It requires identification of the dominant clinical phenotype and the degree of overlap between the phenotypes. And as soon as we understand the phenotype from the screening, then we understand the clinical implications and do the very specific management of each group of the phenotype of the patients. And at the end of my presentation, very short clinical cases. This is a patient actually very compliant to the treatment. MDR-TB was diagnosed in 2017. Patient completed full treatment course. With some problems, patient had adverse events like polyneuropathy, and at some points maybe the treatment was not so effective as we thought. And the problem is that subsequently the patient developed high-sided bronchiectasis with recurrent pneumonias caused by non-specific bacterial flora. And at the same time, also several times we found non-tuberculous mycobacteria repeatedly isolated. But nevertheless, as we managed the non-specific bacterial flora, we never started NTM treatment. And so what I wanted to say that is very important to understand the main approach is the error clearance, and we work with physiotherapy. Regularly, patient performs breathing exercise. He is also using positive expiratory pressure device called aerobica, and it helps to clear airways. And we see the functional assessment of the patient is still good. And one of the messages from this case is also that patient compliance or adherence is crucial in the management of post-tuberculosis lung disease with bronchiectasis. And next case is a bit more complicated. This is patient with obstructive lung changes. In my view, he appeared only this year, months ago. He has a quite long history of tuberculosis, and I think this is one of the explanations why he has post-tuberculosis lung disease, because he was treated in 2005, 2006 with not very good compliance. And finally, in 2018, he had a relapse. Then compliance was good. He was treated with first-line plus kanamycin according to that time guidelines. We know the patient has COPD since 2016. You see before a diagnosis of the last episode of tuberculosis. He used Ultibro inhalator. This is dual LAMA-LABA inhalator, bronchodilatator, sorry. And his clinical status was worsening, and this year he was switched to Trimbov, the triple therapy, but actually we do not see any improvement. And you see from the diagnostic or functional assessment, he has very severe COPD. 6-minute walking test he is not able to provide in full scale because there is desaturation during. The good news is that he had very good recovery after the stopping the test, but the diffusion test also is quite low, and plethysmography showed the very, very huge residual volume in the lungs. So besides the bronchodilators, we need also to pay attention to physiotherapy. And this patient was also sent to rehabilitation due to age and due to also the possibility to and seeing the capacity of rehabilitation. And you see also from the X-ray that there is emphysema. Patient is still smoking. He is not vaccinated, which is work for us to work for smoking cessation, and also to work that he is compliant to breathing exercises and regularly, and also to provide the vaccination for the patient. And at the end of my presentation, I wanted just to say that this quote comes from a qualitative study by Sander and colleagues published in 2022 by BMC Public Health. And the qualitative studies mainly show the patient perspective, because one is the symptom collection and the functional assessment, but this human side of disease is also very important. And the statement, I am cured, but I'm not healthy, we have to pay attention. Patients are still struggling, and this is our responsibility to evaluate these problems and provide care for all these patients. Thank you very much for your attention, and good luck with this conference. And thank you for inviting me as well.
Дуже дякуємо, пані Ліга, за таку важливу, сучасну і креативну презентацію. Шановні колеги, а я вас закликаю, задавайте питання в чаті. Зараз ми побачили, що вже є кілька питань для дискусії. Але, будь ласка, задавайте питання із приводу посттуберкульозного захворювання легень. А ми будемо рухатись далі. І остання презентація нашої сесії дуже цікава, як на мене. Вона буде присвячена останнім даним щодо майбутнього у лікуванні туберкульозу. Тобто те, що у нас чекає щодо скорочення загальної тривалості лікування і нових сучасних ліків, нових форм доставок препаратів протитуберкульозних, які дозволять значно скоротити загальну тривалість. І доповідь цю ми з вами прослухаємо від першої особи, від представників TB Alliance, які є розробниками нових препаратів і нових режимів короткострокових. Це Салах Фарайда. Він є головою медичного департаменту по туберкульозу TB Alliance. І, будь ласка, слово Салаху для презентації.
Hello, everyone. I'm glad to be here. My name is Salah Freda, and I work for TB Alliance. We are a nonprofit organization dedicated to the discovery, development, and delivery of newer and faster TB treatments. Today, I will share our future vision for TB treatment. This is part of our pipeline. I will quickly go through sulfaquilin or TBAJ. It includes pretuminid, sulfaquilin, TBAJ 587, and also Q203. I will also quickly touch on sutazolid, which is similar to linezolid, another OXA that we think it might be safer, oxazolidinol. Just as a quick introduction to sulfaquilin, usually known as TBAJ 876. As you know, bedaquiline was the first-in-class bioquinolone for TB, and sulfaquilin or TBAJ 876 is a next generation of this family. We believe that it has less potential for QT prolongation in the ECG. We also believe that it's 10 times actually, 10 times more potent against TB than bedaquiline. It also has a shorter half-life. The half-life of bedaquiline could be something around 5 to 6 months. The half-life of sulfaquilin, we believe it's shorter. Maybe it's still long. It's maybe 10 weeks, around that. So half of the half-life of or shorter than the bedaquiline, around 2 months or 2 months and a half. And also, it may overcome the increasing problem of increasing resistance to bedaquiline because of being more potent. We did the NC009 phase 2 results. We presented the 8 weeks results in the Union last year, and we will be presenting the newer, the full results in the Union in Brazil in a few months for the follow-up. This is the study design. We investigated 3 doses of sulfaquilin or 876, the 25 milligram, the 50 milligram, and the 100 milligram, compared to BPAL regimen, which you all know, and HRZE. And the population was DSTB. So this is the first time, in addition to the sulfaquilin or 876 being investigated in DSTB, it's the first time to see BPAL in a clinical trial in DS population, drug-sensitive population, not DR population. And it's being compared to HRZE in the same population, the DS population. The study was designed to give the 3 doses of 876 for only 8 weeks, and then wait for the immediate result at week 15. If there is a conversion, then if there is a conversion, then some patients will stop at week 15. So this is only 15 weeks of ATIV and 6. And some of them will continue if they did not meet the criteria. And then the BPAL is as usual, but for DS population. And the HRGE is, as you know, HRGE for the first 8 weeks and then HR for the remaining period. If you look at the key here, the colors, patients who do not meet the criteria will continue on HR, just like the HRGE. Results were interesting because we saw a dose ranging response. So when you increase the dose of 876, you see more conversion by week 8. If you compare the 25 milligram to the 50 milligram to the 100 milligram, you see that the percentage of participants converting, like the sputum conversion is higher when you increase the dose, and it's actually higher than the BPAL and the HRGE, as you can see here. And interestingly, the BPAL and HRGE were similar to each other from efficacy standpoint at week 8. So few good things. There is a dose response when you increase the ATIV and 6 in efficacy, and it is higher in the 100 milligram dose than both BPAL and HRGE. And actually, when you look at BPAL and HRGE, they are comparable to each other from an efficacy standpoint. This is again all of them. You see HRG is almost similar to the lowest dose of ATIV and 6 or surfactant. The 50 milligram surfactant is as good as BPAL, and the 100 milligram surfactant is better than everything else when it goes to week 15. Same thing is also at week 8, as you can see here. This is only focusing on the highest, the 100 milligram dose of surfactant compared to HRGE. And you can see that by week 15, 98% of participants were okay, and I mean, with a stable sputum conversion. That was efficacy-wise. If you look at safety, when you increase the dose from 25 to 50 to 100, you do not see an increase of any adverse events or adverse events related to surfactant, which is good. So the efficacy increases with increasing the dose, but the safety is comparable. And also, if you look at the BPAL with HRGE, for any adverse events, it's comparable. It's even less. If you look at the green bars, the red is related to bedaquiline and surfactant, and as you can see, the adverse events are comparable to each other. If you look at the grades, the green here on the right is any grade 3 or above adverse events. They are all comparable. Even the HRG is higher. So safety-wise, it's as safe as BPAL and HRGE, the standard regimen HRGE. And you do not see an increase in safety events when you increase the dose. This is for, if you look at, for example, the peripheral neuropathy, which is known with linezolid, and linezolid is in all arms except the HRGE. We actually observed 10% of peripheral neuropathy in HRGE, compared to similar or even lower peripheral neuropathy with BPAL and the SPAL, the sulfaquilin, protomid, and linezolid. All arms had linezolid except the HRCE, and the peripheral neuropathy was very comparable. Cytopenias or bone marrow suppression, anemia, and stuff was also comparable between the arms that included linezolid, all of them, when compared to HRCE. And there was no, the ACG data showed no effect of sulfaquilin or 876 on QT prolongation to show the improvement when compared to bedaquiline. The next steps are we are doing another phase 2 study now, already started, to try the loading dose of sulfaquilin, 200 milligram and then 100, similar to what we do with bedaquiline, because we think that this may or may not even improve the regimen. But also next year, we will start a phase 3 study in MDR TB population. So the previous study that I just presented was in DS population. This one will be in DR TB, and it will be 4 months of SPAL, or plus or minus moxifloxacin. So just like BPAL/M, it's going to be sulfaquilin PAL/M. It's going to start next year in 2027. We are now doing the clinical sites assessments and selections. We are engaging with regulatory authorities in WHO, and we are ready to start this phase 3 study as an improvement to BPAL-M with SPAL-M. With a target of 4 months regimen compared to the BPAL-M, which is a 6 months regimen in MDR TB. With a more strategic objective is we think of the ultimate goal of a 1 month treatment for drug-resistant TB or even drug-sensitive TB, which means that the patient will start with 3 or 4 drugs for 1 month, and then at the end of this month, take an injection, long-acting injection, for example, including a pretominid and 876. This injection will last for, let's say, 3 months. So now we know that regimen is good for 4 months. So what we will do is we will do an oral oral regimen for 30 days, 1 month, followed by an injection or 2 of pretominid and 876, for example, which will last in the body for the next 3 months. So the bacteria is being attacked for 4 months, but the patient is only interacting with the healthcare system only for 1 month. 1 month of oral treatments, medicines, and then 1 or 2 long-acting injections of, for example, pretominid and sulfaquilin, which will last in the body for the next 3 months. This is the ultimate goal for future. So this is our vision. Is historical the treatment of DRTB was hard. BPAL now is 6 months, all oral regimen. SPAL, we will start the phase 3 study soon, and we think that we will be able to reduce the 6 months of BPAL/M to SPAL/MOXI for 4 months in drug-resistant TB, and we know it's also working against drug-sensitive TB, as you saw in 009 study. And then the optimized will be a universal regimen for both DRTB and DSTB. 3 drugs for the first month orally, and then followed by a long-acting injectable, 1 or 2 medicines that will last for the next 3 months. Ideally, it's a 1-month treatment, or the patient will need the healthcare system for 1 month. And it could be universal for both DS and DR TB. On another note, sutazolid is from the class of linezolid. It's also in one of our assets, not only to improve the bedaquiline side, but also maybe the linezolid side. Sutazolid is being now investigated in these clinical trials, one with the ACTG under NIH. It's an ongoing study, and the idea of this study is BPAS sutazolid instead of linezolid. There is also a study called ORM PAN-TB HM that was concluded recently, and we are still waiting to see more results and analyze the results. So it's not only the bedaquiline side, but also the linezolid side, or any other oxazolidinones in the future or in the pipeline. Also, very important to mention that the pediatric program for Pretominid is ongoing. We finished the single-dose study. We will start the multiple-dose study. And we actually recently published some data and information about what we know about Pretominid in pregnant women, which was published 2 weeks ago. I would like to thank everyone for listening, and thank you very much. Also thank our donors, participants in our clinical trials, and partners like just like you in Ukraine. Thank you very much.
Дуже дякуємо, Салах, за цікаву,
And now
корисну,
thanking Salah
дієву,
cordially for such interesting, inspiring information and presentation about the future of TB care. And indeed, looking into the future, we are quite wishful to have a similar trend in managing any other disease, including TB, which has been mycobacteria caused. Now, we still have a couple of minutes spared for the benefit of our discussion. Some of your comments and questions can be answered in writing in chat, but there are 3 particularly appealing ones, which I would like to refer to Madam Yana for a more extensive answer. First of all, speaking of the military doctors, I mean health professionals working in military hospitals, what are your plans and expectations about their role and place as part of the reform in making their contribution to TB diagnostic and care? And what about public military communication and cooperation? A highly relevant question indeed, remembering about the war which still goes on. And one of the initial steps that we made would be mobilizing all of our public sector resources to support military medical sector. So nobody can deny any kind of request coming in favor of servicemen, and they are primarily becoming the targets for our service and care, remembering that they are the citizens of our nation as well, and they should be provided with comprehensive care and services. Understanding that there is some differentiation and distribution of duties between military and public sector, but all of our laboratory capacity, facility capacity, pathways, all of them have been coordinated with the Ministry of Defense and their medical corps, both at the national and regional level. So there's effective coordination and cooperation going on between different services and their sectors. Thank you so much. Another highly interesting question would be referring to the experience of family practitioners in the area of case finding and managing TB in different countries. Maybe have some statistics about percentages of patients, patient cases managed by family practitioners. A very interesting question indeed, but before answering that, let me refer to a couple of model designs possible. Number one would be quite topical for post-Soviet Union countries with high TB burden. After collapse of the Soviet Union, their healthcare systems were designed to have a standalone TB response service. And thus, in such post-Soviet countries, there are well-established institutes, research and development centers at the national and regional level, and thereby there would be specialized TB care professionals prescribing such treatment and managing the cases. But looking at the countries like Belgium, France, Poland, Lithuania, the TB incidence will be lower as compared to the Soviet Union countries, and historically the healthcare system does not have TB clinicians as a standalone profession. And thus, they have either general care pulmonary specialist or general care infectious disease professional who attend to such patients. But what's universal across those countries? That would be the patient care management, not just limiting this to prescription or administering the medication to the patient as part of directly observed therapy or some other modalities. That would be the role and place for primary care provider, either family clinician or primary care provider per se. And that's the most prevalent practice, and our country here is not an exceptional case. And we are quite determined to continue our reform, making sure that family care providers will also be as close to the patients as they could possibly be, including the TB care options in terms of diagnostics, prescription, making sure drug-to-drug interaction is taken the due care of, and managing the case respectively. Also making sure there is respective patient-provider relationship established, and also emphasizing the importance of comprehensive case management. As you remember, quite recently we had a series of webinars. They were published in YouTube as well, and that initiative is supported by the World Health Organization. And please stay tuned to our social media. We have a lot of new publications going there. Excellent, then. And that drives us to another question. And who should be managing patient cases in case of non-TB mycobacterial diseases? Pulmonary care professionals or somebody else? Let me split that question into a couple of elements and invite in Natalia to take part of that, because you are speaking on behalf of a research and development institution, while I will cover the practical elements and implications. So, speaking of the national level interventions, quite recently we've initiated establishment of a working group under the Ministry of Health, chaired by Dr. Kuzin, the Chief State Sanitary Doctor, bringing together representatives from the Ministry, the State Expert Center. In their current instance, the representatives of the Institute for TB, Pulmonary and Allergic Disease Care are the community representatives, and we are designing the prototypes of the documents that will serve as foundation for the guidelines and standards of care for an non-TB mycobacteria-caused diseases. Based on such standards, the respective procedures will be designed to clearly regulate who provides care, where such care should be provided, where diagnostics should be taking place, because we understand and recognize this as a problem that does exist. And we need both national and local attention given to respond and also enable the practitioners to provide the respective care, because we do receive and acknowledge the additional requests coming from the practitioners, and I believe within 1 year of time this will be addressed. Thank you so much, dear Yana. Following up on that, let me also explain, my dear colleagues, that in order for a clinician to be able of providing care to the patient under the current circumstances, and also remembering about our European approach, we should not be providing any kind of care without having standards to diagnose and treat any kind of disease, including those which are caused by non-TB mycobacteria. And thus we need a clear tool to allow and a clear pathway. And to do so, we need a standard to begin with. And then step by step, we will continue having constructive negotiations with the National Health Service of Ukraine to make sure this service is remunerated, since all of us remember that it takes at least 12 months to provide treatment and follow-up care, while the remuneration is estimated to be the same episode, which might be 2 to 3 months of regular pneumonia, because indeed any NTM will take at least 1 year from start to finish, and it has to be assessed, evaluated and remunerated by NHSU with respective amounts. The additional standards and regulations, that is definitely coming, that's in progress. But importantly enough, as part of Package 9, any kind of health advice regarding the NTMs can be done by pulmonary care professionals as well as TB clinician. Probably TB clinicians can recognize it better than pulmonary care professionals. So do remember, you have service package number 9 at your disposal, including outpatient interventions. You can invite your patients, come to monthly checkups, and definitely you will receive the appropriate remuneration from the NHSU accordingly. There was another question in the chat, where to find money to cover the drugs? Remembering that the drugs are quite expensive, especially if we are talking about Mycobacterium abscessus. Again, there's no simple and clear answer to that question, but the regional pulmonary care centers can provide some assistance here. Some people might get lucky to have tuberculosis on top of that, and thus, together with TB care, they will be treated for NTMs, one that has been diagnosed. But should that be a mono disease case, then everything we can offer at the moment, that would be outpatient care and follow-up, offering them with the respective diagnosis statement and recommending to be monitored as an outpatient follow-up. With that, my dear colleagues, we will be adjourning our first session. Thank you so much for being so active. Should you have any follow-up questions, do remember that our chat is open for your contributions. Later on, we definitely will look into the chat again to have them addressed in our final Q&A session. There were some questions regarding the records, but our conference is broadcasted live at the National TB Hub, which is free of charge to join. And at any moment in time, you will have an opportunity to watch any presentation or the full session on the YouTube channel. With that, thank you so much again for your kindest attention. After a quick break, we'll be back for the session number 2.
Шановні колеги, доброго дня. Рада вітати всіх
Dear
учасників
colleagues, good
нашої
day to you. I'm happy to welcome all our participants to our scientific
conference
conference who join us online.
сесію,
We are starting
присвячену
this session
надзвичайно
dedicated
актуальній
to
темі
a very important
виявлення,
topic,
профілактика,
detection and
туберкульозу
prevention of
та
TB
мультидисциплінарна
and
взаємодія,
multidisciplinary
основи
interaction,
скринінгу,
the background of
алгоритм
screening,
діагностичного
algorithm for
обстеження.
diagnostics and
Наш сьогоднішній
testing.
блок
Our today's
поєднує глобальні
session
міжнародні стратегії, передові
measures the
наукові
strategies
алгоритми та реальний практичний
and
досвід
real
як
practical
українських громад,
experience
так і міжнародних
Ukrainian
партнерів.
communities and
Ми
international
поговоримо
partners.
про весь шлях від
We will
рекомендацій
speak about the whole
ГОС до первинної
pathway,
діагностики
then from the
кашлю
initial
у дітей до
diagnostics and then
рентген-скринінгу первинної ланки та
the
до
screening of
всіх
primary
умов
care
інфекційного
and
контролю.
requirements.
Чому це важливо?
And then why is
Сьогодні
this
туберкульоз
important?
залишається
Because
одним з
Ukraine is
ключових
still staying one of the
викликів для
key
системи охорони
challenges for the
здоров'я.
health system,
Сучасні підходи
and modern
вимагають від нас
approaches
не просто
require from
швидкої
us not just the
діагностики,
rapid
перш за
diagnostics,
все системного
but first and
скринінгу на
foremost the
первинній та
system-wide
вторинній
screening on the
ланках,
primary and
а
secondary
також чіткої
branch and
безперебійної
the
мультидисциплінарної
interdisciplinary
взаємодії.
cooperation as well.
Ефективний зв'язок між сімейними
Effective connection
лікарями,
between the family
фтизіатрами,
doctor,
пульмонологами, фахівцями
pediatricians,
лабораторної
pulmonologists,
діагностики,
experts of the lab
соціальними
diagnostics and the
службами
social
– це той
services.
міст, який
This is
дозволяє вчасно
the
виявити
gateway that
захворювання,
allows us to
запобігти його
detect the
поширенню
disease,
та
prevent it
зберегти
spreading,
життя
and preserve
пацієнта.
lives of the patients.
Мета нашої сьогоднішньої
The
сесії
objective of
розібрати
today's session
сучасні
is to
стандарти
look at the
та
modern
інструменти
standards
скринінгу
and the screening
туберкульозу,
instruments for
оптимальні
TB,
алгоритми
optimal
діагностичних
algorithm for
обстежень на
diagnostic
різних клінічних
testing on different levels
умовах,
of care,
практичні кейси
and then the
та
practical
маршрути
cases, and then
пацієнта в
patient
рамках
pathways within the
інтердисциплінарної співпраці.
multidisciplinary cooperation.
Сьогодні з нами
And today,
працюють
together
провідні
with us,
експерти
there are
галузі,
leading
які
experts in the
поділяться
area that will
теоретичними
share their
засадами
theoretical
та
things
практичним
and skills
досвідом.
and knowledge.
Коротко про регламент нашої
Shortly
роботи.
about the
Тривалість
agenda of
кожної
our work,
доповіді
the
20
duration of each
хвилин.
presentation under
Після
20 minutes.
виступів наприкінці
After a
сесії
presentation and the end of the
передбачено
session, we
25
have foreseen
хвилин
20
для
minutes
дискусії та відповідей на
for
ваші
discussion and
запитання.
answers to any
Тому
questions that you might
прошу
have.
вас
This is why I'll
писати
kindly ask you
запитання
to
в наш
write your
чат.
question
І запрошую всіх
into
до
the chat, and I
активного
welcome
обговорення.
everybody to the active discussion.
Запрошую до першої
And welcome to
доповіді
the first presentation,
нашого доповідача,
our
пані
presenter
Олесю
Olesa Medvedeva,
із доповіддю нові
with the
міжнародні
presentation
підходи до
Novel
виявлення
International
та
Approaches for the
профілактики
Detection and
туберкульозу від
Prevention of TB
рекомендацій до
from
рутинного
recommendation to the
впровадження.
routine implementation.
Пані Олеся – це лікар
Olesa is the
відділу
pediatrician of the
координації
Department of
програм
Coordination of
лікування
Programs of
державної
TB
установи
of this
Центр
institution,
громадського
Center for
здоров'я
Public
МОЗ
Health,
України.
of Ministry of Health of
Керівництво
Ukraine,
операційних
clinicians
досліджень,
and the
автор
operation
публікацій
research,
міжнародних
author of
проєктів
international
ведення
publication and
членів
international
мультидисциплінарних груп
a part of
з розробки
interdisciplinary
галузевих
groups and
стандартів,
the
має
state
досвід у
standards and have the
проведенні
experience in
вебінарів,
conducting
тренінгів,
webinars,
інших
trainings,
навчально-освітніх
and
заходів.
other
Пані
educational
Олеся,
activities. So
прошу
Alessia,
до слова.
the floor is yours. Greetings, dear participants, dear colleagues, dear organizers. We are really grateful for this wonderful opportunity to join to such a wonderful event. And I'm so happy that I have this opportunity of sharing the latest recommendations and detections and then prevention of TB and how are we implementing this in the routine practice in Ukraine. So to say about the dynamics of TB, we need to understand, all of us need to understand that this doesn't unfortunately only prevention. This is the comprehensive list of activity. There it has the detection, prevention, diagnostics, and treatment of TB, and every stage has an important meaning to it. And the main objective of public health system is not to allow for the development of the disease, but if it did so happen that the disease had occurred in a person, then we have to detect it as soon as possible, test them correctly, and timely start the treatment, and of course, effectively try to manage it. If you are to mention about the implementation of recommendations, international ones at that, we need to understand that Ukraine needs to have the bylaws needed for that. And I would just like to highlight shortly about the main legal documents that are requiring TB in Ukraine. And the first, I think, thing, which is the law in Ukraine on conquering the TB diagnostics and then conquering TB. And this is not many laws in Ukraine that are connected with the diseases, and TB, a separate role is being given. That means that the government considers this as an important area of work. And also the decree of cabinet of ministers of Ukraine, which is in 2019, we have agreed upon the state strategy in conquering HIV, TB, and viral hepatitis to 2030. And also during 2024, that there has been strategies, and then the decree of cabinet of ministers of Ukraine on detection and order number 702, the organization and detection of TB and the TB infection. This is the order number 406 on epidemiological surveillance on TB, and order number 102 so far acting the approval of the care and TB for, and then the order of provision of primary care, the order of Ministry of Health 504. Each of those orders or legal acts, it's recommended in terms of detection, prevention, diagnostics of TB, and in the law of Ukraine, the Article 9, it's saying that the active detection and for people who have the TB that are infected as well, and also on primary care level, by constant detection of patients that are within the risk groups, and also we have the latent TB infection and the organization of their annual testing on presence of TB. You can see that this is on the highest administrative and legal levels of care. If we are to take a look into the strategy, then it's the strategic objective 3 that tells us about the decrease in mortality and morbidity from TB. And their implementation of the routine monitoring models, and then screening discrimination, and then there's also about the detection of TB supposed to be provided with the effective detection on the new cases. And so here, the valid informing, the big portion of that is dedicated to before TB is detected, prevention, and then medical screenings and active detection. And then the treatment for the TB infection, and then the vaccination of the newborn. In order number 302, the responsibilities on TB is being, this is the state administration, regional ophthalmological centers, and then if we are speaking about the then the key group risk groups are being done, and then the number of people that are supposed to be tested for the TB infection because the preventative treatment. This is also under the competencies of medical care facilities, and then regional ophthalmological centers are providing the general conventional role in the health facilities, and then controlling organizational methodological work. They're conducting the analysis of this support in their region, and the Center for Disease Control and Prevention. And the big role is dedicated to episurveillance and in the region over TB. And recently, based on the Center for Disease Control and Prevention, right now there is testing for TB infection by using interferon tests, and the Center for Disease Control and Prevention specifically. And so right now in the Health Department that are conducting control over the implementation of how it's done, and then the events, reporting, and the main coordination function and role. The order number 406, it specifically states the roles of family doctors within the conduct of the episurveillance, what's supposed to be done, and timely detection, and TB infection, and also the specific algorithm of actions of primary care experts on testing and treatment. And then the main document for primary care, which is the order on provision of primary care. And I'd like to point your attention that there's also area for TB for key target groups of higher risk groups, and getting TB defined by the state standards to the standards of medical care for TB. And also we are conducting questioning on the symptoms, and also we are conducting the X-ray assessment, what is happening if the person is having the risk groups. And then we all understand fully that we are included in within the program for medical guarantees. This is why an important documents are requirements of product for medical guarantees in primary care and prevention and diagnostics of or detection of TB. It's being put as the requirements of program for medical guarantees. The main legal document regarding TB, which is the standard of medical care. Just like to mention that right now there's a lot of new work is being conducted in Ministry of Health. Is it the lookout in the nearest time they will approve changes there. And in those existing standards that are the most modern approaches in prevention of TB, then there's the groups of higher risk. There's this far-sighted screening algorithm for TB and TB infection, and then as the most modern models of treatment as well. And you can see that the first document that we have, which is TB prevention, which is the first and most effective tool in fighting TB. But if before the TB prevention was only vaccination and IPC part, so right now the most effective part, the most evidence part to ensure the prevention of TB, which is the preventative treatment, and then not everybody's following them. There are specific groups of people that's supposed to go through both TB screening and TB infection, and then decision is made that the preventative treatment is supposed to be prescribed in the treatment itself, and then the monitoring as well on whether this treatment has been finished or not. So then also on the prevention, this is not vaccination. The remembering about the preventative treatment. If you are to take a look at the option of implementation of preventative programs in Ukraine, then this is from the latest recommendation of WHO, how it was implemented in Ukraine, the updated recommendation of WHO in 2024. Ukraine started implementing from 2022, and then until today, some of the elements of the program that we've been moving on in. And right now there are new standards, revised risk groups, and then there are new methods for testing. There's new skin tests that right now started to be used actively in health facilities that are based upon the antigens for TB and also tuberculin as well, but much more sensitive and specific, but short regimens for treatment. So rifampicin containing regimens that until today in the world hasn't been actively used because of how pricey it is. In other processes in Ukraine, this test is present. Also updated preventative tests regarding the BCG vaccine as well. The assessment of effectiveness and what is the effectiveness of the preventative programs altogether and the cascade method. And so I'd just like to mention here that we're continuing the active development, implementation, and we've started new operational research that allows us to treat people or prevent things for people who contacted with people with resistant to TB. There is the regimen with delamanine and others. So the implementation of such a research allows us to give protections to people that don't have the ability to be protected or anything else. If we speak about the monitoring of those indicators, then we have the standardized indicators, which is when the contact people are we finding enough contact persons for them? And then the coverage with screenings among the contact coverages with the preventative treatment, and not just coverage, but the number of people has been covered, but also effectively finished this preventative treatment. So I guess and from 2026, we've seen that from in every stage of this cascade, somebody was lost. And so the biggest loss, which was the coverage, was testing for the TB infection. And so only 62% from the ones that were supposed to be tested, so that there is a difference in all of that. And then not everybody's being tested. And then detection of infection among the contact people, which is 30%. So it's higher than among other risk groups, which means that prevention on contact people that's supposed to be is the biggest role because there's the biggest chance to get a disease. And we're also seeing that the higher number is supposed to be there. And then that those who are not tested by the WHO recommendation national standards, we still have to prescribe to them the preventative treatment because the advantages are higher than the possible risks. And then to start a preventative treatment, only 79%, which is not a lot. In other countries, it's supposed to be 90. And we are hopeful that after this conference, everybody will hear and everybody at their specific places will be trying to improve this line of work. If we are to take a look at different risk groups, which is HIV infected, patients with the psychosis, even transplantation, and people who are living with HIV, here the coverage of preventative treatment 82%, but the coverage of testing is still low. And we're getting your attention to the fact that the new rapid tests are being introduced and then accessible for the special cases like quantiferon test in the CGCP, and then nobody said no. The MEN2 testers can prick test, which can also be done.
Speaking of TB case finding, there are also some indicators that will be quite helpful. Again, there could be active or passive case finding. Speaking of active case finding, we have percentage of people covered by screening, with the target being more than 90%. Speaking of passive case finding, another very interesting indicator, which is the percentage of positive test results in the gene expert. And looking at the WHO recommended ranges of readings, which are clearly suggesting that once the screening and sampling was appropriately established, that would be between 5 and 15% of positive test results. In Ukraine, we can see 8.8 in 2025 and 10% in the first half year 2026. So we seem to be within the range. But looking at the regional breakdown, we have the situation ranging between 2% and almost 20%, which is not a normal case scenario, clearly suggesting that in some cases the sputum samples are sent to gene expert without any discretion, while in other cases, definitely the sample coming to testing only in those patient cases who are suspected with TB. Based on the symptoms, manifestations, most probably this would be suggestive of the TB case. So definitely we need some in-depth analysis of the situation in every given region and also improve the quality of sampling. The patient should be further referred using the diagnostic algorithm and also working on the quality of the sampled samples and media. Looking to high-risk populations, we have quite a promising trend over the recent 5 years, growing from 80% to 87%. But again, the target is 90%. Please be mindful of that, and this target is achievable with some effort. That effort means improved algorithms, improving the gene expert coverage and availability, and also addressing other matters and objectives stated in the national strategy, including the monitoring of coverage with screening and sampling, because that is done on a quarterly basis in every region. Here we're looking, scrutinizing this information. And again, looking at the first half year 2026, we are still at the 87% benchmark, but also the high risk, the contact people, people with HIV, people in custody. Here we do accomplish 90% coverage, the highest one being the 78% among the people beyond the poverty line. which clearly suggests that additional cooperation is required with the social protection sector and services, as well as social service providers, making sure that we can improve accessibility and service availability rates. Speaking of the so-called PASS initiative, started in 2022 together with the country office of the WHO and the leading practitioners and scientists in Ukraine, well, quite a helpful screen TB exercise was performed to prioritize risk group populations. Based on the information that you submit in your regular reporting using WHO Toolkit, we have identified what categories at risk would be in the highest risk category and who should be given the priority attention, remembering about the war going on in the country. And based on the latest edition of that standard, we have reduced the total number of risk groups to 16. The initial was 23, as you remember. So children, contact, people in custody, healthcare providers, and also personnel of the law enforcement institutions, as well as others were appropriately attended. And also the pulmonary presentations, neoplasm, diabetes mellitus, immunosuppressive therapy, hemodialysis, transplantation, including bone marrow transplantation, and postpartum women, as well as people in contact with such women and the neonates, people who have treatment cases in their history using drugs, and other at-risk populations to be screened by communities, including migrants and IDPs, but resident in local communities, people without any permanent place of residence, mental health patients, servicemen serving active duty, as well as law enforcement officers, as well as smokers. Another interesting category, because there are no official data regarding the number of such people. And I do believe we all acknowledge about the importance of interviewing your clientele about smoking habits for the family clinicians, because the smokers are at high risk of TB. Nevertheless, here, our initiatives and our efforts and recommendations, respectively, should be targeting the awareness-raising activities and patient education, first of all, in that particular category population. One of such solutions, making sure the services are closer to the patients, especially in the neighborhood of the areas where active hostilities continue, would be using the mobile services, mobile outreach services as well. And here you can see some numbers regarding the outreach visits, but the TB case finding statistics are quite low. Maybe this is related to the fact that additional sampling intervention would be required among the people who present for screening, and that should involve family clinicians who would do some preliminary screening on the one hand, but also making sure there are additional interviews conducted with the local patients, encouraging them to come to such testing sessions. That will improve case finding, and that would be important enough, because TB response cannot be unilateral. We need a multidisciplinary approach, interdisciplinary coordination, where each and every agent has a role to play. And our common goal would be overcoming TB, and family clinicians would be responsible for at-risk population determination, future referral, and follow up with the patients. Epidemiologists will also be working in the outbreak areas, contributing to awareness-raising activities, making decisions at the regional, national level. TB clinicians will be coordinating the patient care, contributing to training, counseling support, and follow-up throughout the course of patient care management. And shouldn't be also remembering the social partners overseeing commissions, committees, and partners, patient organizations helping with stigma and discrimination eradication, and of course relying on the modern, including digital techniques and technologies, including artificial intelligence, interface and technologies which will be helping to identify the TB cases, looking at the imaging results, strengthening screening for TB as well as other infectious and non-communicable diseases as well, again relating to the digital technologies and analytics, remembering about the availability of the new tests, systems and technologies, including point of care, like the oral swabs, which will be making even closer the availability of diagnostics as well as care. And I hope I didn't take too much time and your attention, so thank you cordially, and we'll stay tuned for any questions you might have. Dear Olesya, thank you so much for such a comprehensive overview of international standards. I'm scrolling up and down the chat. I can see lots of thank you notes, no questions at this moment, although. So I'm happy to invite another speaker to discuss how such technologies and guidelines are actually implemented in realities. So the second topic will be active case finding of TB and other pulmonary diseases, relying on X-ray technology, to be presented by Gorokhiv community representative. Irina Psuk will be our speaker, Deputy Director General of Gorokhiv Polyclinical Facility. Additionally to administrative and clinical work, Dr. Irina is chairing the Advisory Clinical Commission and the Military Consulting Commission, being also the coordinator of the National Public Health Council, paying a lot of attention to development of the project management in the healthcare sector, contributing to establishment of palliative care centers, which would be community-based, as well as mobile solutions. Dear Irina, the floor is yours. Warmest greetings, dear colleagues. My name is Irina Psuk, and I'm representing the Gorokhiv Polyclinical Facility in Volyn Oblast. Let me start by thanking organizers for the kindest invitation to share our experience about decentralization of screening of thoracic disorders, relying on X-ray technology and artificial intelligence in the context of rural communities. The matter is, this is not just technology. This is the matter of using modern tools for high-quality diagnostics becoming accessible to the people. Since I'm working in Gorokhiv, which is a small town, we still can see people on a daily basis who present in advanced stage of pulmonary disease. Sometimes people don't have time for timely X-ray investigation. And that's exactly why we decided to make this diagnostic tool closer to the people. After 2022, this problem has been more well manifested because of the growing number of internally displaced people and the growing work burden, operational burden in the healthcare sector, as well as the big number of relapses, recurrent incidents, and people presenting for multiple times, including pulmonary diseases, TB, and cancer, which were diagnosed at the late stage or never diagnosed on time. Thus, our objective is not to wait for the patient to come to a hospital. Instead, we should make this point of diagnostic and care as close to the patient as possible. And this is where outreach activities, and mobile solutions using portable X-ray machines and other elements of technology would be quite helpful as compared to having the stationary installations in the facility. And then in Horokhiv community, we have 6 outpatient care facility and 1 polyclinical facility to cover 24,000 patient population. Implementation of our project was possible after December 2024, when our hospital received a portable X-ray machine by Fujifilm, with the software and training provided under the respective project for strengthening TB response activities in Ukraine, supported by PATH and the government of the United States of America. And thus, in 2024, we started systemic outreach visits, relying on the capacity of our mobile installation. And we worked not only in remote locations of the Horokhiv community, we paid special attention to the settlements of IDPs, as well as mental health facility and other categories of population who have limited access to healthcare. Such X-ray images were analyzed by our X-ray professionals using the Insight software, and thus we provided for the preliminary investigation without the need for a patient to present to a clinical facility. Since the beginning of 2026, we have a collaborative initiative with the Red Cross Society, who provided us with additional resources, such as the vehicle, reimbursement of the driver services, and the price of fuel. Also, would like to emphasize that the success of our project was not depending on the availability and quality of the equipment alone. The matter is that cooperation between our polyclinical facility and PHCs is equally important. Every month, we would be designing a schedule for visiting different settlements, and our multidisciplinary team would include family care providers, medical nurses, X-ray professionals, ultrasound examination specialists, and also other healthcare providers when and if necessary. In order to make sure that we have continuum of care provided, we have designed a joint order to support performance of multidisciplinary team, as well as the standard operational procedures, X-ray algorithm, log registries, and also the list of the patients who were identified as candidates for X-ray examination and follow-up care and support of such patients in case any anomalies were found. Over the course of 2025, we have performed over 2,600 chest X-rays, including over 2,000 made in stationary settings and 556 in mobile settings, which means almost 20% of our patients screened in remote locations would have different anomalies identified. And also, among the patients presenting to the hospital, this would be only in each 11th case, which is less than 10%. Particular attention was given to the high-risk populations, internal displaced people, people with disabilities, residents of the mental health facility, as well as other categories of population. The most convincing result was not the fact of conducting over 5,000, almost 600 outreach visits, but the fact that case finding rate would be double as compared to those patients who presented in clinical settings, and thus having about 9.7% of case finding. 126 would be the actual number of cases identified, which is 21.9%, which means that we reached out to those people in those locations who needed our help at the most. And thus, we were successful in fighting pathologists and effectively approximating our service availability to those who need it. Most frequent finding in our mobile investigations would be the pneumofibrosis, 17.2%, 2%. And for comparison, in clinical setting, this indicator was only about 5.5%. Pneumonia suspected in 18 people, 3%. TB suspected in 6 patients, which was 1%. And cancer in 4 people, 0.7% respectively. These numbers seem small, but these are the cases of clinical significance because they were identified at the stage of screening. And when comparing not only incidence but the structure as well, it's clear enough that outreach screening is most helpful at the place where it's needed, which makes this not only medically significant but socially important as well. Otherwise, these cases would not have been diagnosed for a long time. Analyzing our results of 2026, we grow confident in efficacy and success of our performance. We have visited 4 locations already, covering 743 individuals. 83 anomalies were identified, including pneumonia, TB, including 3 cases with laboratory confirmation and another one going into our second half-year statistics. 21 cancer suspected cases and 24 fibrosis. That again demonstrates efficacy of our program. But most importantly, we should remember behind each number there are patients. And speaking of the patients and their cases, I would like to invite you to the next part of my presentation, reinforcing our understanding of how helpful our screening is. 53-year-old patient presented to a family clinician would be the first one who complained of cough, subfebrile fever, body loss of weight, and sweating, referred to X-ray during the multidisciplinary team visit, cancer suspected. 2 days later, he was already consulted by the cancer care specialist, and Hodgkin's lymphoma was confirmed. Another case, 58-year-old male abusing alcohol and tobacco, having no declaration with the family clinician, but was referred to a family care provider. 24th of May, interviewed as part of screening intervention. 2 days later, during the outreach visit of our multidisciplinary team at the place of his residence, the chest X-ray was performed. 26th of May, the sputum sample collected and tested via GeneXpert with a positive test result. On the 27th of May, the TB clinician examined such patient, and on that same day, the TB was confirmed. Currently, he is on effective treatment regimen.
And the newest case, to female 55, abusing alcohol, and then receiving treatment on TB. On the 19th of June, there's no complaints, but a family doctor has mentioned there was persistent cough and affective structure, body's composition. And there's in the question, there's more than 2 yeses. The X-ray of chest has been conducted because of the X-ray equipment where the patients are leaving. The 14th of July, GeneXpert has been conducted. So he has conducted a positive result on GeneXpert. So the previous samples have included additional components that did not allow for it to conduct the full testing. Then the 15th of July by the Volin physiatrist has been conducted a survey, and then on 30th the resistant form of TB right now, the treatment has been selected, and then the patient is being treated. And because of the small bowel screening, those patients were timely detected, referred to treatment, was the approved diagnosis, and started their treatment. Therefore, in our opinion, decentralized screening is in the use of the portable equipment and AI technologies is effective addition that allows us to cover the people that without active search and surveillance most likely would have stayed outside of the health system, and the experience of our hospital has shown, and then his effective model of early detection of lung conditions, as the condition of cooperation of primary and secondary care, and that the use of the modern digital technology and well-established patient pathway, we are hopeful that this experience will become useful to other communities in Ukraine, and we will add in the future development of the programs for active screening programs. Thank you so much for your attention, and I'll be happy to answer any questions that you might have. Thank you.
Пані Ірино, дякуємо вам за чудовий
Irina, thank you
приклад
so much
роботи
for
з
such a wonderful
громадами.
example of working with communities.
Дякуємо за вашу
And thank you so
доповідь.
much for
Наразі
your
дивлюсь,
presentation.
запитань в
Now we're
чаті
seeing that there's no
немає, лише
questions in
слова
the chat,
подяки
only
та
the words
слова
of gratitude
вітання.
and words of welcoming.
І ключем до
And
раннього
the key
виявлення є
things to
вміння
early
розпізнати
detection is
перші
an ability to
симптоми,
recognize the
особливо
initial symptoms,
найвразливішої
especially in
групи
the most vulnerable
пацієнтів –
groups
це
of
діток.
patients, which is
Наступна
children.
наша доповідь
The
присвячена
next
клінічній
presentation is dedicated
діагностиці
to the
на
clinical
ранніх етапах.
diagnostics in early stages.
Симптом
The
кашлю у
symptoms
дітей,
of cough
алгоритми
symptoms in
правильного та
children,
раннього
algorithms of
встановлення
correct and early
діагнозу. До доповіді
diagnosis. To
запрошую
the
пані
presentation, we are
Олену
welcoming
Рєчкіну, це
Olena
доктор
Rechkina,
медичних
which is
наук,
Doctor of Medical
завідувачка
Sciences,
відділення
the head of the
дитячої
Department of
пульмонології та
Pediatric
алергології
Pulmonology,
Державного
Neurology of State
установи Національний
Institution,
науковий центр
State
фтизіатрії,
Scientific Center
пульмонології,
of Deciding
алергології
Pulmonology,
імені Яновського
named
Національної
after
академії
Yanovsky National
медичних наук
Academy of Medical
України.
Sciences of
Пані
Ukraine.
Олена є президентом громадської
Olena is the president of
організації
the
Асоціації
NGO
дитячих
and Association
пульмонологів
of Pediatric
України,
Pulmonologists in
національний
Ukraine, and then
представник
the
України
national
в
representative of
Міжнародному
Ukraine to
товаристві
International
дитячих
Community of
респіраторних
Pediatric
захворювань,
Respiratory
має
Diseases,
багаторічний
and has
досвід
multiple
наукової,
years of
клінічної та
experience of
освітньої
clinical and
діяльності у сфері
educational
дитячої
activities within the
пульмонології та
pediatric pulmonology
алергології,
and
автор
allergology,
наукових публікацій,
and
доповідач і
author of
тренер
the
національних
publication
та
and trainer of the
міжнародних
national and
професійних
international
заходів. Пані Олено,
training events.
прошу вас до
Olena, the
слова.
floor is yours.
Дякую. Вітаю,
Thank you so
шановні
much, and
колеги.
welcome, dear
І дійсно
colleagues.
ми розглянемо
And
з вами
we will be
один
looking
із
at one
найбільш
of the
частих респіраторних
most frequent
симптомів, з
respiratory
якими
syndromes that
приходять до нас
the
пацієнти,
patients are
а
coming
саме
to us
це
with,
симптоми
which is
кашлю.
the cough
І
symptom.
впевнена, що той
And I'm
алгоритм,
sure
який
that
ми
the
зараз з вами
algorithm that
будемо
we
розбирати,
will
ми
be
його
looking
можемо
at today,
використовувати
we will
не
be able
лише
to use it
для
not
дитини, яка
only for
кашляє,
children who's
а і
coughing,
для
but
дорослого
also for
пацієнта
adult
так
patients
само.
in the same way.
Будь ласка, презентацію можна? Дякую. Отже, кашель є
So
одною з
cough
найчастіших
is one of
причин
the most
звернення до
frequent reasons of
лікаря, і
encounter to a
фактично
doctor
щоденна
and de
практика
facto daily
кожного з нас.
practice of
Якщо
every one of
розглянути
us.
дітей,
If you
вони,
would look
особливо
at
діти
children,
молодшого віку,
especially
вони
children
можуть
of
мати
younger
від 6
age,
до
they can
10
have from 6
епізодів
to
гострих
10
респіраторних
episodes of
інфекцій
acute
на рік, і
respiratory
тому кашляти
symptoms per year, and
десь
therefore
140-200
coughing
днів на рік, а це
140
майже
to
більше
200
ніж
days a
півроку.
year. This is more than half of the year.
10-20%
And 10
дітей
to
після
20% of
вірусної
children
інфекції
after
можуть
viral
продовжувати
infection, they can
кашляти
continue to
3-4
have
тижні,
cough for 3 to
і
4
саме це
weeks.
дуже часто
And
буває
this
зоною
is
клінічної
the area of
невизначеності,
clinical
бо вважається,
indecisiveness and
що, скоріш за
undeterminateness
все,
because
це
it's most
поствірусний
likely that
кашель, але там же може і
it's a
ховатися
post-viral cough,
більш
but this is
важливі
where the
причини,
most
які
important reasons
викликають цей
can
кашель.
hide that
Кашель
can cause this cough.
важлива і важка
The
інколи
cough is a
діагностична
complex
проблема,
diagnostic
і
issue, and
найнебезпечніше,
the
що саме
most
під маскою затяжного
dependent
кашлю
under
можуть
the prolonged
ховатися
cough,
різні як
different
легеневі стани,
types of
так
both
і
lung conditions
позалегеневі
and out.
причини. Кашель є найбільш частим приводом
The
для
cough is the
призначення
most
медикаментозної
frequent reasons
терапії.
to
Це і
prescription of
повторні
medication
курси
therapy, which is the
антибіотиків,
additional
дуже
courses
часто
of antibiotics,
необґрунтовані. Це може бути
usually ungrounded
необґрунтоване
for. This can be
призначення
ungrounded for
ін'єкційних
prescription of
кортикостероїдів,
inhalation
комбінованих
corticosteroids.
сиропів
We
і
combine
призначення зайвих
syrups and then the
обстежень.
prescription
На
of
сьогодні
additional
доведено,
needed
що
testing. Right now, it's
80%
proven that
дітей, які
80% of
мають
children
хронічний
that have
кашель,
a chronic
здійснюють
cough
понад 5 повторних
are
амбулаторних
conducting
візитів
5
до
additional
лікаря
ambulatory
за
visits
рік
to
з цією
doctor a
скаргою,
year with this
поки не буде
complaint up
встановлений
until
правильний
the
діагноз
correct
і
diagnosis is
призначена
being stated
ефективна
and then effective
терапія.
treatment
І,
is
на
being
жаль, дійсно
prescribed.
ми
And
спостерігаємо,
unfortunately,
що
we
інколи
really are observing that
нам
sometimes
вдається
we are
через 2-3
capable
місяці
in 2 to 3
встановити, що
months
дитина
to
має
state that
хронічний кашель
if
інколи
the child has a
раніше,
chronic
а
cough
інколи
symptoms even
буває
earlier, and
звертаються
sometimes they're
батьки
just
зі
reaching out by
скаргою, що дитина
parents
вже
because they
кашляє
the
2
the
роки,
person
3
that the
роки,
child is
але
coughing for 2 to
дотепер
3
не
years, but up
знайшли
until now
причини.
they haven't
А
found
саме
the reason
хронічний
why the
кашель
person
–
is
це
coughing
суттєве
the chronic
зниження
cough. This is
якості
the
життя як самого
decrease in quality
пацієнта,
of life for
ну
both the
та звичайно
patient
його
and also
батьків. І
for
от хочу
parents.
вам показати декілька прикладів. Діти скаржились, всі діти скаржились на кашель.
All
Ну
the children
найчастіше,
has just
звичайно,
said that they
це
had cough, but most
гостра
likely this is there is acute respiratory viral infection, but the child, 3 years of age, they have dry cough, and after 2 months, an X-ray is being conducted, and you can see that they're seeing changes. And in the future, they detect that this ganglioneuroma is being there. It's the wet cough. She's 8 years of age. She's coughing through 5 months, and after a prolonged treatment, when she was treated a lot and she was tested a lot, and then the X-ray is being conducted on the chest, and then the bronchoscopy is being conducted, and then we see that then is the plastic spoon, 4 centimeters in size. Then the next child, dry cough, and then wet cough as well. This has been observed in the past 7 months. In a detailed co-assessment, what we found out that there is the plastic bronchitis, the dry cough, 7 years of age, and in a few months so far, they're arguing that they have a dry cough. In additional testing or CT testing, they found out that the TB is present, multi-drug resistant at that. And so you can see that in all those patients, they have a cough as the main leading symptom, but such vastly different reasons can be caused by this cough. And how can we get in depth in this? What kind of algorithm do we have for the search when somebody's reaching out to us with this issue? Each cough has their own history, and our objective is to open up its history. Sometimes we can really be, this can be a patient with cough as it's like a mystery case when you're like a detective trying to find out, because different decision solution, we need to find a source. Where is this cough coming from? At the Congress of International Community of Pediatric Respiratory Conditions and Diseases, there has been a big list of attention is given to this matter, and then they're stressing out that when we are seeing patients that is coughing, the most important part is patient history, because there's a lot of hints in patient history and characteristics to the cough and the age of the beginning of the cough and how long the coughing for, that would allow us to state the diagnosis, and also listen to your patient, and then they will tell you your diagnosis, and then the mistakes are happening not because we don't know something, but because we're not looking for. And let's have a look at which kind of clinical characteristics of the cough that we need to touch based upon, so that we can find the reasons of why our patient is coughing. And then the first characteristics is to see the cough as how long it was lasting. And then right now, there are differences with chronic cough in children and in adults as well. The cough right now is being separated acute and chronic cough. And then in children under 14, chronic cough is when it's going for longer than 4 weeks. For children over 14 and adults, this is a cough that's persisting over 8 months. And this longevity is being taken on the natural course of cough that is connected with the viral infections. And then it's considered that in the end of the week 4, if cough was caused by a viral infection, then in 95% of patients, it's going to go away. This is why this line of 4 weeks, not to miss a significant condition that can be caused as cough. And then acute cough, this is a manifestation of acute respiratory infection, and in the future it can be post-viral cough. And then, but we still have normally healthy child. We have an absence of any concerning aspects that we will be touching based upon. We have to gradual regression of that symptoms, and then in that case we can observe and then not prescribe any excessive treatment that's probably not needed. But the reasons for a chronic cough in children are plentiful. And first and foremost, it can be post-infectious reasons, and this can be an infection of airways, and then prolonged bacterial bronchitis, chronic porous bronchiectatic disease, immunosufficiency, and this can be breathing anomalies, primary or secondary bronchomalacia,
Це може бути астма.
And this
це
can
може
be an
бути
asthma,
аспірація
this can be
дихальних
an
шляхів
aspiration
як
of
стороннім
airways,
тілом, так
as
і
opposed
як
as the
прояв
foreign
наслідок
body, and as a
гастростреснального
manifestation of
рефлюксу. Це може
gastroesophageal
бути синдром
reflux.
кашлю
This
верхніх
can
дихальних шляхів,
be
те,
cough
що ми
syndrome of upper
раніше
airways, something that we
називали
have called
дріп-синдром або
before the
синдром
drip
запікання,
syndrome,
який
or
як прояв
this
риносинусіта,
is the
аденоїдіта або
rhinosinusitis,
алергічного
adenitis, or
риніту. Ще
allergic
одна
rhinitis.
проблема, яка, на
Another
жаль, з
issue that
кожним роком
unfortunately year
набуває
after year is
актуальності і
becoming
частіше
more
спостерігається
widely
у
spread,
наших
and we are seeing this
дітей,
more and more in
це
our children,
тіково-соматичний синдром,
which is
тобто
somatic
тіковий
syndrome.
кашель
So the
або
tick cough
психогенний
or
кашель. Ну
psychogenic
і
cough,
позалегеневі симптом,
and extrapulmonary
проблеми,
ones as
також,
well,
наприклад, вушний рефлекс
that
Арнольда також може
reflux Arnold
проявлятися
reflux
сухим
can also
кашлем
be
у дитини.
manifested as a dry
Нагадаю
cough in a
вам, що
child.
тривалий
Let me
ковід
remind you that the
також
long
лонг ковід
COVID
може
can
спостерігатися у
also be
20%
first seen in
дітей.
20% of
Кашель може
children.
тривати і
The cough can be
достатньо
ongoing and for
довгий період часу.
quite a
І
long
ще одна
periods of
проблема,
time. And
яка
another
також
issues that
набуває
is also
актуальності,
becoming
це
more and more
ураження
prominent,
легень,
which
яке
is the
пов'язане, на
lung
жаль, з
injury
використанням електронних сигарет
connected
і
with the usage
вейпінгів,
of
і
vapes.
евалі, і яка
And
стосується не
then
тільки
that's
дорослих,
concerning
а,
not
на
just
жаль,
adults,
і
but
дітей.
unfortunately also
І
concerns
ще хочу
children.
зупинити вашу
And I also
увагу
like to touch
на
based
одну з
upon
причин,
one of the
яка може
reasons
викликати
that can
хронічний
cause
кашель
chronic
у
cough
дітей,
in
особливо
children,
це
especially
підлітки
this is
і
for adolescents
дівчата
and
або молоді
females and
жінки.
or
Це
young
кашель,
females. This
який
is the
сухий
cough,
кашель
a
при
dry cough,
дисфункції
and
голосових
the
зв'язок.
dysfunction
На
of
сьогодні
vocal cords.
є
And so
більш
right
новий
now there are
термін, це
novel,
індукована
which is
ларингеальна
the
обструкція.
induced
Якщо ви будете
laryngeal
зустрічати
obstruction.
такий
And if you will be
діагноз, то
seeing this
це ми можемо
diagnosis, then this
поставити
is
знак рівняння
it
діагнозу,
equals
який
to the
раніше був
diagnosis that
дисфункція
before was
голосових зв'язок.
dysfunction of vocal
Як
cords.
вона
And then
проявляється? Це
how
сухий
does this manifest,
гавкаючий
which is
кашель,
the
надсадний
cough, dry
кашель,
cough,
це буде відчуття задухи,
a feeling
особливо,
of
але при
being
цьому
unable
це
to
буде
breathe, but together
відчуватися
with that,
під
it's
час
being felt like
вдиху.
during an
Але саме це призводить до
inspiration.
того,
But this
що
leads
дуже
to
часто
the
такі
fact that
пацієнти
frequently such patients
спостерігаються,
are being
їм встановлюється навіть
observed and they
діагноз
have the
бронхіальної
diagnosis
астми,
of bronchial
вважається, що
asthma and is
вона
being considered that
важко лікується,
is
або
being
це
hard
тяжка
to
бронхіальна астма,
treatment, or
яка
it's a
не
complex
відповідає на
bronchial
лікування.
asthma
А
that's
на
not responding to treatment. But in
в
reality,
цьому випадку просто це
in this case,
інша
this is
причина,
just the
яка
completely different
призвела
reasons that has
до
caused
цієї
the
задухи і привела до
this
кашлю. І ви
dyspnea and
бачите,
then
що
with to cough,
відсоток
and then the
таких
percentage
дітей
of such
достатньо високий,
children
це 15% підлітків, які
and
мають хронічний кашель.
mm,
Отже,
and
наступна
chronic cough as well.
характеристика
Another
після
characteristic
тривалості – це
after
обов'язкове
longevity,
визначення
which is the
характеру
detection
кашлю.
of
Який
what is
кашель?
the
Вологий,
character of the cough. It's
продуктивний
dry,
або
is it
сухий. Це
productive,
основні
is it
фенотипові
wet?
ознаки кашлю,
Main
які є потенційними
phenotypical manifestation
індикаторами
of cough, there are
патологічних
potential
станів.
indicators
І
of
якщо мова
pathological
йде,
states. And then
наприклад,
if
при
you are speaking about the
гостро-респіраторно-вірусну
acute
інфекцію, то
respiratory
ми
viral
розуміємо,
infection,
що
then what we
ці
are
стани
seeing here that
переходять
those
один
states are just moving one
від
into
одного до
another.
іншого. А от коли ми маємо
But
пацієнта,
when we
який
have a
скаржиться вже
patient that is saying that
більше 4
they
тижнів
have
на
more than
тільки
4
сухий
weeks of cough,
кашель,
not
або
just for
більше
dry cough,
4 тижнів на
but more
тільки
than 4
вологий
weeks for
кашель,
not just
ми
wet cough or
можемо
production
вже
cough, then
думати
we can
про
think
певні
that there are
діагнози.
some
І на цьому слайді ви бачите саме
diagnosis and
диференціальний
then
діагноз хронічного
differential
кашлю в
diagnosis
залежності
of the
від
cough,
типу.
then depending on the
Найчастіше все
type.
ж таки хронічний сухий
Most
кашель.
likely the
Це
chronic
можуть бути прояви
cough, this
кашлюка,
can be
це
a pertussis
прояви
manifestation, this can
тікового
also
або
be a
соматичного
tick-related or
кашлю.
somatic
Він
cough,
може бути тільки
and then
хронічним і
it can be
сухим.
just
Це може
chronic or
бути прояви
just
бронхіальної
it can be the
астми, це може
manifestation of
бути
bronchial
неспецифічний
asthma,
ізольований кашель,
non-specific
кашель
isolated cough,
пов'язаний з прийомом ліків,
cough connected
ну
with
і
the
може бути проявом туберкульозу,
medication
хоча
intake
і
and manifestation
вологий
of TB
кашель
as well.
також
Even
може бути
the
проявом
wet cough
і
can also be a
туберкульозу,
manifestation
і
of TB
астми.
as well and asthma as
Якщо
well.
мова йде про хронічний
And if the
вологий
question
кашель, то ми
is
в даному
about the
випадку вже думаємо про затяжний бактеріальний бронхіт у дітей дошкільного
and
віку. Це
bronchial
може бути прояв
bronchitis in
муковісцидозу,
children or
первинної
cystic
целярної
fibrosis,
дисплазії, повторної
severe
аспірації
dyspnea, the additional
або
aspiration or
сформованих
formed
бронхоекстазів.
post-infection
І
bronchiectasis.
коли мова йде
And so when
про
we
характер
are speaking
кашлю,
about the
тут обов'язково
character of
треба і
cough, then
запитати
you need
батьків,
to ask
і
parents,
якщо, але пам'ятати,
and
що
then
дуже
to
часто
remember that
батьки, на
most
жаль,
frequently
описують
parents are just
неправильно.
describing
Були проведені
wrongfully.
дослідження,
There has been research conducted that proven that every third or fourth
of the parents are describing cough in the wrong way, and they are saying that it's productive or not productive. And here to our assistants is the request to record, especially when we're not seeing how the child is coughing at the visit. We're just asking them to make a video recording on their smartphone and then to send it to us, because frequently the video and how the child is coughing is helping us tremendously to conduct the differential diagnostics. The next characteristics, which is the sound of cough, that also can help us to think that there is a specific diagnosis. If it's a dry perpetrating cough, this can be tracheomalacia, a tick cough, somatic cough, and then acute stenosis. Paroxysmal cough can be pertussis that we can think of, or parapertussis. And then the cough when the patient is coughing like products and clots. This is the plastic bronchitis manifestation. A wet cough or productive cough, which is usually passes diseases, cystic fibrosis, and then this can also be the presence of endobronchial secretions. On the primary care level, what we're having is patients that frequently having isolated dry cough, isolated wet cough, but also there are patients that have chronic cough that are being aided with the anxiety signs, so the chronic cough on top of something else and something bigger. So what is meant here by something more and something bigger? You need to find out whether our patient has, apart from cough, a dyspnea or shortness of breath, and they when he's calm and when he's doing something. Also warning signals is recurrence and presence of productive cough, recurring pneumonia is when cough supports with is present with blood in the sputum, when we have system-wide symptoms, loss of weight, delays in development, when they have anomalies in neurodevelopment, when there's complexities in treatment, street or any other sounds, when we have the absence from norm in the clinical assessment and auscultation or an objective testing, when we have the when we are referring such patients to an X-ray of the chest in case needed. The chest CT is being conducted spirometry if the child is older than 5, and then we are conducting a full-blown assessment.
На цьому і наступному слайді ви бачите рекомендації 2024 року.
Further and the next slide, you can see the quotation from the guidelines as of the latest edition 2025 with the clear instructions what to do in case of chronic cough in children. And these insights will be helpful in 80% of cases to clearly identify what is happening and where to refer such child, or alternatively to think of the reason why we have this particular cough, and starting about the origin, the onset and duration. Onset, I mean how early in the day and how early in the lifespan of the child the cough started, because if we are talking about the initial couple of months on the neonate, this could be the congenital, this could be a gastroesophageal reflux, respiratory syndrome, and also we'll be looking for additional reasons. Also, was the onset spontaneous or related to some kind of pre-existing disease, the so-called moist or dry, productive or non-productive? How frequent is that? What would be the trajectory of such coughing syndrome? Also, do ask the question about the child coughing during the nighttime. Because if parents admit that this cough can continue throughout day and night, but when going to bed there's not a single incident, then under such circumstances, indeed, we can be suspecting psychogenous origin of such cough. If alternatively there is more cough during the nighttime or in the morning when waking up, well, during the daytime there could be some sporadic coughs under pressure, under change of the environmental moisture level, then this could be related to the syndrome of fatigue of the upper respiratory airways. If alternatively we can see this growing during the nighttime and almost at one at the same time, let's say between 4 and 5 a.m., the child could be waking up with the coughing attack, and then we could be suspecting bronchial asthma as one of the options, but do scrutinize. In case of a healthy child running around in a playground and then starting to cough sporadically, then sometimes the child might not admit it, but we as clinicians will find a lot of value in such small tips and tricks. And of course, checking the concomitant symptoms and manifestations, as well as factors which might be exaggerating this effect. Was there any linkage to the pre-existing or earlier disease and treatment, like broncholytics, for example, which could be quite helpful, having other concomitant diseases, other medications, which might be triggering this as an ADE, or if alternatively we are suspecting this as a bronchial asthma case, so looking into the family history, atopical diseases, or rather congenital and severe respiratory diseases in other family members. And also looking at such alarming indications, especially in case of chronic cough, we can suspect the respective diagnosis. If this is recurrent infection, that would be the bacterial bronchitis or relapsing bronchitis, bronchoectatic disease, mucoviscidosis, which also are quite frequently diagnosed in patients of different age, not necessarily within the neonatal period, within 1 year of life. Mucoviscidosis, as you remember, might be manifesting via recurrent infections and pneumonia. Also, the cough with some blood excretion can be a manifestation of bronchiectasis or foreign body availability. If there's hypnea associated with any physical exercise, this could be larynx or tracheomalacia or cardiac deficiency, and here definitely we'll have to relate this to additional examination by cardiologists. And again, relapsing pneumonia, this could be a foreign body, mucoviscidosis, immunodeficiency, aspiration effect. So do remember about such alarming indications and the diagnosis hiding behind. My particular focus would be on clear indications when you, as a clinician, should suspect TB in that case. So what are the red flags here? First of all, chronic coughing, which lasts longer than 3 to 4 weeks, relapsing pneumonias in a child with unilateral infestation, cough associated with long-lasting subfebrile fever, which is associated with weight loss, nighttime sweating. Definitely we'll have to find out about the contacts and to see what would be the response to the standard antimicrobial treatment. If there are any X-ray findings with pneumonia, which might be complicated with atelectasis, then such patients should be referred to an additional X-ray, and also looking at the pleural edema without any obvious region. The earlier we suspect TB, having such signs and symptoms, the more efficient our diagnostic and respective prevention and or treatment would be, including prevention of transmission of that infection. Thus, whenever you can see a patient with cough, you should study the patient history, do the examination of the patient, conducting chest X-ray, and also look into the CT imaging results, and in any child older than 5 years of age, then spirometric study. Any additional technique to be deployed based on the results of our initial findings, checking the allergy, including tuberculin-based diagnostics, and I'm referring for additional examination and counseling. And also answering the question, when should you refer such child to the specialist? When you have any uncertainties or suspicion as a primary care professional, when such symptoms are congenital, when there's vomiting effect, when we have sustained productive, moist type of coughing, when you have family history of any pulmonary disease, when you have no lasting treatment effect, or you have additional clinically significant data, either stridor or dysphagia, anomalies in terms of crying effect or language and speech, no effect of conventional treatment, and also additional concerns suggested by the patients who also will be helping you with the appropriate diagnosis. Thank you so much, dear Olena, for such clear-cut clinical algorithm, because the coughing symptoms would be one of the most common complaints that our patients would have. And now speaking further of the patient pathway, particularly in countries with high TB burden, that would be another subject where we invite experience of our international partners. And our next subject would be the primary case tuberculosis detection and multidisciplinary collaboration in Philippines experience. We're happy to invite Dr. Eden Mendoza Haisi, head of the INK Knowledge Hub, who has more than 18 years of experience in designing, implementing and monitoring implementation of the programs and capacity building. She is Doctor of Medicine and Master of Public Health. As I mentioned, she is heading the PeerLink Knowledge Hub, not only designing the training materials, but also assessing the quality of education in Philippines and other countries. And we are happy.
I'm Eden Mendoza Haisi, and I head PeerLink. Today, I will be sharing the Philippines' experience in bringing drug-resistant TB detection and treatment down to the primary healthcare level. I'll walk you through what we've built, the disciplinary partnerships that made it possible, the challenges we've met honestly along the way, and the lessons that may resonate with you in our own settings or with your settings. Here are the three primary reasons why the Philippines decided to decentralize or integrate drug-resistant TB services in the primary healthcare facilities. First, we want to make sure that access is equitable for all to ensure early detection, reduce delays in treatment, and prevent further transmission of TB. When DRTB was still centralized, people would immediately know that you have TB because there is only one facility that they have to go to, which was the lung center of the Philippines. That increased the stigma felt by the patients. But when we decentralized and made the services available at all primary health care facilities, we were able to enroll more patients, not only by reducing the stigma, but it also addressed the socioeconomic problems of the patients. It reduced transport costs, reduced travel time, and improved the geographic access. This slide is just to show you the global versus the Philippines TB situation. The data was taken from the WHO Global TB Report in 2025. And as you can see, the global TB incidence is 131 per 100,000 population. But in the Philippines, the incidence is around 5 times higher at 625 per 100,000 population. The Philippines also has higher MDR RRTB incidence rate as well as TB mortality rates. So, although it is not something to be proud of, the Philippines is among the top 5 high-burden countries in the world. So this is just to give you a background of how the Philippines have distributed our healthcare system in the country. The country has more than 7,100 islands, which is divided into 82 provinces and 146 cities. These are grouped into three main island groups, the Luzon, Visayas, and Mindanao. And the provinces and cities are further organized into 18 administrative regions. In order to make the DRTB services more accessible, we have established around 3,048 IDOTS facilities nationwide. And I will be talking about the meaning of IDOTS in the next slide. So here, IDOTS actually stands for Integrated Delivery of TB Services. We changed the original meaning of DOTS, which was Directly Observed Treatment Short Course, for our purposes. This slide is just to give you a brief history of how we integrated the DRTB services at the primary level. So in 1919, we discovered that we started having drug-resistant TB cases. And then it took a lot of advocacy to convince the government to finally address the increasing number. And so it was only in 2008 when the drug-resistant TB was included in the TB program. The Lung Center of the Philippines and the Tropical Disease Foundation were the first treatment centers that were established. And this was later expanded to a few selected provinces and cities in 2011. By 2015, the Department of Health decided to bring DRTB services further down to the primary healthcare facilities, which we call rural health units. The rural health units with DRTB services were then called IDOTS facilities. So take note, not all rural health units were provided with DRTB services. That was phase one, and it involves establishing satellite treatment centers, which in turn manage and oversee the operations of the IDOTS facilities. The satellite treatment centers usually do the initial assessment of the patient and enroll the patient for treatment. Once the patient is stable, the patient is then transferred to the IDOTS facility nearest his residence and will continue and complete his or her treatment there. Then, when the people M was introduced in the country in 2020 under operational research conditions, and seeing that the treatment outcomes were greatly improved when People M was offered at the RHU level, the satellite treatment centers were eventually removed, and each RHU or rural health unit became an independent unit offering the comprehensive services for DRTB management. So this was at the IDOTS phase 2 of the program, which was implemented in 2022. And for the rest of the years, or the coming years, we started building the capacity of our health workers nationwide and ensured that policies and guidelines were already in place. In parallel, when we established those IDOTS facilities nationwide, we also established a laboratory network across the nation. Take note that the number of laboratories capable of detecting drug resistance is only around 1/3 of the number of IDOTS facilities. The rapid test diagnostic was only 1,100, while LPA, TB culture, and DST accounts for only around 50 lab stations. This means that one TB laboratory has to serve up to 3 to 5 IDOTS facilities requesting for drug resistance testing. When we realized that there were so many patients that were getting lost to follow up even before diagnosis, we realized that there must be some access challenges or issues to these laboratories. And so we tried to resolve this issue by hiring striders. So in 2017, the Philippine Business for Social Progress, which was the primary recipient of Global Fund, initiated the Strider program, which stands for Specimen Transport Rider. It engaged motorcycle riders to transport specimens from IDOT's facilities without expert machines. And by 2024, we had expanded the networks to 400 striders, and they had started delivering specimens for other disease programs as well. So as a result, we were able to enroll around 24 patients for the first year of implementation. And so as you can see in the first column of the diagram, 24 is very negligible in the first year. But by the following year, we were able to detect 7,489 patients for drug-resistant TB, and 80% of that were actually enrolled in BPAL-M. BPAL-M enrollment even went up to 86% by the following year, which is in 2025. And this year, we've enrolled around 2,300 in the first half of this year. So the cumulative total of patients that were enrolled in BPAL-M is around 14,787 out of the 25,600 TRTB patients that were detected and treated. So unlike any other programs, we've had a lot of challenges during the initial implementation. Many of the nurses had to resign when the operations research ended. And because rural health units are like outpatient departments in hospitals, sometimes the volume of patients seen daily can be overwhelming, and the number of doctors and nurses stationed in those facilities is very limited. So we had to hire new ones. But sometimes when hiring is not feasible due to budgetary constraints in the local government unit, the staff from adjacent facilities were requested to transfer or split their time between the two facilities. There was also a long turnaround time for fluoroquinolone resistance detection. Take note, we only have 4 second-line line probe assay, and only 2 are functional. So we had to shift to expert MTB XDR. We also experienced stockouts of lab reagents, and so those that ran out had to borrow from nearby lab facilities. There were also instances when specimens were lost or missing at the National TB Reference Laboratory, or NTRL. And so to resolve this, we had to closely follow up and call them on the phone to get their verbal confirmation that they had received the specimen. Sometimes the specimen is rejected due to food contamination, which caused further delay in the diagnosis and treatment. So we had to train patients repeatedly on the proper sputum collection. There was also poor patient progress monitoring by the health workers, including poor management of adverse events. So to address that, coaching of staff was conducted during the monitoring visits from the Department of Health, and job aids were developed. We established the TB Medical Advisory Committees composed of TB experts at the national and regional level, so that if the primary care doctors encounter difficult to treat patients, they can refer this case to our TB experts. As you know, the BPAL-M is associated with adverse events, and one of the adverse events of special interest is optic neuritis. Unfortunately, IDOT's facilities do not have specialty clinics, so the patient has to be referred to another health facility to get eye care. Of course, we also encountered the same patient problems even before decentralization, such as the financial problems, transportation issues, geographic isolation. And then we encountered stockouts of bedaquiline and ancillary drugs during the initial stages of implementation. So we had to get supplies from adjacent facilities to cover for the deficiencies. For this slide, I wouldn't be discussing this in great detail, but suffice it to say that there was a lot of preparation and consideration before integrating the RTB at the primary level. I have placed governance and policy and also leadership right at the center because this would be providing guidance and overall direction on how to proceed with the rest of the components, such as making sure that there is supportive supervision at the beginning. That is what our satellite treatment centers and the TB medical advisory committees are for. The finance and the social support is also important to sustain the integration. We need to ensure that there is enough health workforce to take on the additional load and ensure that they are capacitated to perform their new roles. Referral systems should also be set in place, especially for areas where the ideal setup has not yet been met, such as installing expert machines in every rural health unit. We still lack expert machines, even up to the present. So there must be also a sufficient supply of the second-line drugs and ancillary drugs delivered on a timely manner to the RHUs. And of course, there should be a reliable health information system to track progress, and it should be in place. So although the systems, as I have mentioned earlier, are already in place, we are still facing some challenges up to the present. As mentioned earlier, we do not have a 1:1 ratio for RHUs and laboratories capable of detecting drug resistance. We are still highly dependent on Global Fund and for the purchase of second-line drugs. Even the government is not yet prepared for the eventual pull-out of global funding. And I hear that it's going to be our last funding this year. We were also recently categorized as upper middle income country by the World Bank, and therefore I think we will no longer be qualified to receive any donor funding from any country providing this assistance. Also, our national health insurance, which we call PhilHealth, only covers drug-susceptible TB. Insurance benefits for drug-resistant TB is still a work in progress. The quality of the RTB care is even not uniform across the country. The rich municipalities or provinces and cities would have better services, complete with medical amenities, while those low-income municipalities usually only offers the minimum or even sometimes less than the minimum, depending on the priorities of the mayor and the governor. Also, infection prevention and control at the primary level still needs to be improved. So I think this is my last slide. I'll be happy to answer questions if there are any. Thank you.
Дякую, пані Іден.
Thank you so
Дякуємо
much,
за цікавий
Eden. Thank you so much for an
міжнародний
interesting international insight to find and direct the patient, refer a patient, which is an enormous amount of work. But not less important to provide a safe conditions for medics and for other patients for on all of the stages of treatment. And by finishing up our line of presentation, a very important topic of protection and infectious control over TB, updated challenges and leading practices. We are welcoming to the floor Roman Kolesnik, the manager of the project of the in Ukraine International Organization PATH, an epidemiologist and an expert in public health that is specializing on prevention and control of infections and also interaction of the state institution in health, and has an experience in implementation of national initiatives in health who is the coordinator of activities dedicated to the AMR and implementation of modern approaches for prevention and control of infections in Ukraine. Roman, please, the floor is yours. Greetings, dear colleagues. Thank you so much for welcoming me to this floor, and thank you so much for such a high-level event and allowed me to tell you a few things, everything considered IPC on TB. And of course, when we are speaking about the management of TB and things that are the government is moving to more of a transition of people who are having TB on the primary care of medical care. But if we are mentioning about IPC, we are mostly speaking still about the health facilities that are providing medical care in patient conditions or hospitalized care. And so we need to remember that there are some activities that are decided upon by the regulation and international recommendations as well that have to be implemented in the country. And also just like to judge based upon from the statistics data regarding how well in Ukraine the IPC measures are being implemented in the inpatient conditions or hospitalized care for people with TB with the bacterial expression, and then and resistant forms. Regarding the statistics data by the public health center, and then there's being spread here with their discretion, we have an issue that's concerning the placement of patients with the multi-resistant TB in isolated wards separately, one from another. That's foreseen by both the standard IPC and also foreseen by other legal documents and everything else and approved in Ukraine, especially order Ministry of Health 1617, when there's a prohibited cohort resolution of the patients, and we have beg your pardon, an issue that unfortunately so, because of such placements of patients, we might have a spread of mitral resistant flora, and partially this can be confirmed with statistics data that the number of resistant forms of TB in the country is still sufficient, quite high, and this can be connected also with the insufficient isolation of such patients. And the next data, statistics data that exists right now regarding the placement of rooms, on the distribution of the infection risks. We're also having the issue on the inpatient level, which concerns not just the TB facilities of the epidemiological center, which considers most of the health facility centers in Ukraine. But unfortunately, this matter usually being negated, or if you're speaking about the regional epidemiological centers, and we have in the statistics that around half of such centers, they don't have a room separation in accordance with the risk of infection zone, which additionally brings risks of being infected to the medical employees in the health facilities through a possible misunderstanding, like where and which places you need to use those in the personal protective equipment, or use them and implement additional means and matters not to allow the infection being spread, and then so on and so forth. This is why if in your health facility you still don't have rooms in accordance with the risk zones, we kindly ask you to create such a distribution, conduct the training of the personnel so that those infections risks would not be reoccurring. Regarding the additional means for protection that in Ukraine has been widely used and then has been used mostly because of the insufficient mechanical ventilation in the health facilities. And also what we have is a set of issues that are also bringing risks both for medical employees and for the patients. And please point your attention that according to statistics, these pulmonological centers are conducting assessment of effectiveness and safety ultraviolet radiation rarely, and because of that, there can be too much radiation for patient, medical workers, which leads to burns, negative consequences for mucus of the eyes and other things as well. Apart from that, not conducting assessment of effectiveness, so ultraviolet radiation causes the possible spread of with air and infectious agents, and especially TB in the context of these pulmonological centers. And this is why the usage of such means as ultraviolet radiators, their effectiveness might vary or might be decreased in accordance with the fact that all of these pulmonological centers, they have present radiometers. So please, if you're not yet doing this kind of assessment, then please pass it. And regarding such a simple things or the most simple things, but also we have issues in terms of provision of respirators. Unfortunately, there is a list of these pulmonological centers that are not provided with the respirator fully. And in accordance with that, if you are to mention the provision of such respirators, then around a third of health facilities, they have issues in terms of that they have just one type of respirators present in stock. So if you all remember and understand, if you are going from the statistics data, even of what is given by the manufacturers, then in vast majority, the respirator fits to 80% of the users, meaning in any case, the presence of just one type of respirator in TB facility potentially is signing that 20% of medical employees that are using them might not be protected sufficiently because of that. And of course, that for some respirators indicators can be higher, but still 100% protection, one type of respirators for all the employees cannot provide physically, which is showing to us the research on the fit testing in health facilities, and then depending on what kind of respirator is being used, the effectiveness of them can be from 60% of medical workers and up to 90%. Therefore, a big request is to please point your attention, and the fit testing has to be done at least once a year, and for the medical workers to provide for the presence of a sufficient number of different types of respirators. The issue that unfortunately we have created ourselves in Ukraine, because we, during our presentation of fighting against TB in Ukraine a long time ago, because of the insufficient number of the personal protective equipment at the time, and especially quality respirators, we were using the recommendations of the Center for Disease Control and Prevention of the CDC in the US on the continuous prolonged use of respirators in anti-TB facilities. And please point your attention to the fact that as of today, the practice of prolonged or multiple usage of the one-time use respirators is prohibited or not allowed anywhere in the legal acts, and the respirator has to be one-time use personal protective equipment as it's being specified by the manufacturer. This is why the usage of any paper or other types for storages of respirators, also for wearing those respirators in the pockets or anything else. It's a practice that is not foreseen by the current regulations of Ukraine, and hopefully so that slowly but surely this practice will not be used anymore, because the manufacturers of the respirators is not guaranteeing effectiveness in the second layer of the respirator. And also what we would like to point your attention separately, which is also concerning the safety of health workers during the use of means of personal protective equipment, including respirators, so that this personal protective equipment to be really, really safe before putting it on and before taking it off. You need to conduct a hygienic hand processing or hand processing by washing it with soap and water. This is also possible and important, not just in the context of not in the context of the combating TB, because TB is not being conducted with the hand-to-hand contact, but we do understand that in any health facilities, there are many other infectious diseases that can be passed through hands, and then their number is much higher than of other communicable acts that are being passed through other means. This is why following hand hygiene brings an ability to fight the infectious agents with the contact means. And please remember about this protections. The matter of to the discussion and causes a significant discussions in terms of experts and everybody else we're doing with the treatment of patients. And then the experts and the specialists they're dealing with the IPC. This matter is when the patient and the patient pathway has to be tested. And that was an X-ray. So it's in terms of IPC, in terms of other things, if you have the ability not to conduct testing of the patient together at the same time for them to do the sputum and to conduct an X-ray research, if you have this opportunity in time and the patient does not require an emergency decision to be made, please look at the option of the first and foremost, try to get the results of these sputum samples to gene experts, and then in case needed to have an X-ray. Why is this important for IPC and IPC safety? It's all very important. If the patient has the excretion, then you can make a high quality procedure. So an X-ray technician will be wearing a respirator, and you'll be able to inform that the patient has bacteria secretion or excretion of bacteria, and you can make additional means for aerial disinfection to have UV radiators, increase the mechanical ventilation, or if there is no capacity to conduct MBT detection or anything else, then additionally, what you can do is you can conduct a not letting any future assessment of patient during the period of time, so that the aerosol could settle down in the room, so that the patients that are there or entering in the following way could not be affected or infected. Therefore, if you have this wonderful opportunity to get tested microbiologically to a patient, and then on a gene expert, and to understand that there is a bacteriological secretion, and then to do the X-ray of the chest or CT, then please do that in that way you will reduce the risk of getting infected of both the medical personnel that is testing this patient, and also you can divide the patient pathways on the time, and then to test this patient in the X-ray to be the last one so the other patient would not go in there and wouldn't be able to potentially be infected.
And also that will sustain protection for the healthcare professionals working there. Definitely this could be the scenario when no emergency care would be required to attend to that patient, or alternatively, this would be just kind of routine CT or X-ray, unless this is important to do it here and now. And also, last but not least, speaking of IPC, and making sure we do not spend too much time on that in the context of presentation, but save more time for the discussion. So this would be the general care inpatient facility, but also TB and pulmonary care specialized wards and departments, whereby, in line with the new requirements regarding the construction and development, as well as sanitary precautions applicable to the newly designed and constructed health facilities, where all patients with aerogenic infections, including naturally the tuberculosis, should be located in the respective boxes or wards for designated patients. And the respective requirements applicable thereto would be availability of the negative air pressure and sanitary and hygienic care premises and utilities within the patient ward, which should be designed to accommodate one patient only. Definitely, considering such an option outside of newly designed and constructed facilities will be next to impossible, but should your facility in the nearest time of the future or in the long-term future be planning some redesign, reconstruction, then please pay attention to the requirements of the new construction regulations as endorsed in 2023. They were approved in 2022, but endorsed in 2023, specifying the requirements to make sure there are such isolated wards and boxes depending on the total patient bed capacity of your facility. But if you are talking about a specialized care or pulmonary or TB profile, then definitely you should invest into redesign and reconstruction, because there are no alternatives applicable in line with the national legislation. I hope you understand the importance of doing so without any additional explanation, just emphasizing that this will be done for the best interest and safety of both the patients and providers, preventing airborne transmission in such wards, in case the sufficient ventilation, air purification, and HEPA filtering installations are provided. On top of that, please pay attention to the fact that if you are not a representative of a TB or pulmonary care facility, but you're representing just a general care facility, then TB and patients with TB or patients with suspected TB, they can be admitted into the general care system in a routine manner, but during any diagnostic proceedings, they should be placed into such isolated wards in order to prevent any possible transmission to either patients or healthcare providers working in such facility. Remembering that additionally to TB, there are other agents and pathogens which can be airborne, and respectively, adherence to such strict norms and regulations will be on your side. So please do remember about such requirements. The more so that now it's legally binding, and in case of redesigning or reconstructions, do consider having such wards and premises with respective amenities and equipment, which will be making this impossible to infect other patients and other providers. So with that, thank you once again for your kindest invitation and attention, and I'll be happy to take any questions. Thank you, dear Roman. And I do have an immediate question as well. What do you think would be the most common mistake that occurs in the context of IBC management at the laboratory level? Well, mistakes, in my opinion, any errors or misdoings which would be applicable at this stage would be quite familiar to both clinical and laboratory professionals, and that would be inappropriate patient pathway design. And here we should be led by the common principle, which is the patients presenting at their own time to their own place with their own outfit without respective PPEs, then which would be different from the patient pathway specification as applicable to TB suspects, then definitely that could be the direct risk of contamination, transmission, and infection, which means that such pathway as applicable to TB patients and TB suspects should be designed appropriately. Another problem that I also can't fail to mention here, directly associated to infection prevention and control, that would be the expectation that the PPEs would be the effective means for protection, particularly when it comes to primary care settings. And that would be the sad fact of using recirculators, open ultraviolet lamps as the means for TB prevention. Recirculating ventilation devices are prohibited for use in line with the sanitary regulations as of 2021. And speaking of ultraviolet lamps for sanitizing, do remembering that this is prohibited to use them with human beings in attendance, and you can switch them on only after any proceedings with the patients have been completed and the place is vacated. But using them within a healthcare setting for the benefit of patients and providers would be totally inefficient. And also, do not forget that once you have a patient, if you have a potential one as well, who could be smear positive, who couldn't have active phase, then you should never rely on non-evidence-based practices and do not expect that your respirator will be protecting you absolutely, because definitely it's close to 100%, but never 100%. Thank you once again, Roman, for such a comprehensive answer. But we do have more questions, this time to Dr. Rechkina from Madam Demchenko. I do believe that today family clinicians are between the hammer and the mace, running the threat of excessive testing and excessive medication. So the question is, how can we develop the clinical maturity and bravery of clinicians who would be avoiding excessive prescription, but be clinically effective and reasonable? A highly relevant question, because indeed we should avoid anything which would be excessive, but at the same time not missing something which is important and significant. So once you have a patient with cough syndrome, you should look into additional red flags and check for the auscultation symptoms and representations. But also, you should check the CBC, for example, complete blood count, to look into the C-reactive proteins, to better understand whether or not we need any microbials in that patient case. But at the same time, you should not be suggesting any excessive diagnostics and tests, like, for example, immunoglobulins, when you are looking for the worms invasion, which happens quite frequently in the case of children presenting with cough. And they have been screened for atypical mycoplasma or chlamydia, and also the invasion. So please remember, if your child has cough only for a long time, this by no means can be suggesting of the worm's invasion. On the other hand, even if you suspect that this could be caused by bronchial asthma or allergic causes, you should not be referring the child to molecular diagnostics. Better do the complete blood count, check the eosinophils. If you believe additional screening is required, please do that, but avoid extensive and expensive examination and laboratory tests, which could be difficult to implement in a primary care setting. But also following up on a question, Another comment regarding the excessive treatment and medication, because in many cases we can see antimicrobials are prescribed to children who cough, while on the other hand that refers not only to children but adults, and that would be using glucocorticosteroids. You cannot treat the cough with steroids in case of acute respiratory infection or pneumonia, for example. And we see multiple cases when indeed, in case of pneumonia, there would be antibiotics, broncholytics, and steroids prescribed at the same time. There's no sense in doing that. And thus, if you have a patient with cough, if there are any red flags, that would be one case scenario. If not, just prescribe symptom-based therapy and monitor this patient for the period of up to 4 weeks in case of children, and up to 8 weeks in case of adults, and check for dynamics. Thank you so much, dear Madam Olena, for your comments and responses. And indeed, I'm sure we have lots of GPs, family clinicians, and pediatricians in our audience. So highlighting those red flags would be of extreme importance for them. And that is manifested by the number of thank you notes who I can see in the chat. Participants are thanking you for important, relevant, and appealing information. And this is our pleasure. And with that, I can see that the time of our session comes to the end. So let me thank on your behalf to all of the speakers for investing your time, passion into the content, and thus enlightening us not only with the interesting presentations, but also fostering our discussion, because these presentations and the cases, they do clearly suggest that our technology and science are moving forward, thanks to your well-motivated professional passion. And also, thank you for being so clear with time, being well prepared, all of the members in attendance. Thank you for being active listeners and students. Hopefully, all these findings and all these lessons will translate into new projects, publications, and practical accomplishments. Wishing you to have more of those, and as well, peaceful sky above all of us. And with that, I'm happy to announce a 10-minute break before we continue under the framework of this session number 3. Please stay tuned. We have a lot of interesting material for you.
Шановні колеги, продовжуємо нашу роботу і розпочинаємо заключну сесію нинішньої конференції, яка присвячена алгоритмам диференційної діагностики захворювань легень за принципами міждисциплінарної взаємодії.
So we are continuing up with the last session, modern clinical conditions for.
В даній сесії ми будемо з вами обговорювати питання.
And we can discuss the matters of the correct diagnosis with the wider circle of specialists. In this session, we have microbiologists present, we have bronchologists present, thoracic surgeons are present, we have specialists on radiology, specialists on CT, computer diagnostics, and also pulmonologists. This session is dedicated to an example of work as a part of multidisciplinary team. What is very much lacking to the clinicians and an assistance when there is a complex case and when the complex line of diagnostics is impossible to be done within just one specialty, one approach. We will be able to discuss the correct diagnosis, what's considering the lung conditions and what to do so that all of the diagnostics would just go for as short period of time as possible and a correct diagnosis was instated as soon as possible. And the floor for the first presentation is given to the representative of microbiological community because in lung conditions, the first branch of differential diagnostics.
Надаємо слово Анні Барбовій. Вона є старшим науковим співробітником відділення мікробіології.
Of the microbiological department of the National Center of Physiatry and Pulmonology named Dr. Janowski. And Anna will tell you an interesting and important topic, which is the correct microbiological and molecular genetic diagnostics of two conditions that we have mentioned so much, which is TB and non-TB mycobacteria. So Anna, please, the floor is yours. Thank you so much and good day to you, dear participants of the conference. My presentation is named Novel International Approaches on the Microbiological Diagnostics of TB and non-TB mycobacterial conditions, from recommendations to the practical implementation. And I would just like to start my presentation of in almost 145 years of existence from the moment of discovering by Koch, Microbacteria TB has been for a list of changes, biological, genetic, resistance profile because of the spontaneous mutation in genome under therapy is the most aggressive manifestation of its evolutionary changes. The pathogens has become a new dynamic target for TB diagnostics, meaning that there is an evolution of the pathogen and an evolution of diagnostic approaches for this infection has also started. In that way, the modern microbiological diagnostics of TB is being based upon the velocity, quality going out of monodiagnostics, ability to see changed forms of the pathogen and the usage of comprehensive phenodiagnostic approaches, prioritization of the rapid molecular tests for a full bacteriological mapping of the patient at the beginning of the treatment of the infection. And right now, I would just like to shortly present to you the updated international recommendations of 2025. And those recommendations, they were not born in 2025. This was a list of, it's a teamwork of international community. And those recommendations are based on the molecular tests of low complexity that are being recommended as an initial diagnostic instrument. There's a few tests like that, but in Ukraine, we are using GeneXpert, MTB Riff Ultra, and you know this well. And the capacity to spread out of the resistance profile of TB using molecular and genetic tests. And as the first place is GenExpert, MTB XDR, and phenotypically for susceptibility testing. And then before they update recommendation on the targeted sequencing right now, this recommendation is only for the reference labs. And I would just like to mention that the implementation of all of those recommendations, a new edition of the standards of medical care for TB, it's found its way and its footing and will be updated in 2026. So we have processed all of those updated international recommendations, and we will be working on an updated standards for TB diagnostics. Right now, Yana Terleva has also mentioned about the novel test, molecular genetic test that is closer to the patient. This kind of test does not consider diagnostics for TB, but is a screening method. This is a PCR, it's a simplified PCR that allows us to test the sputum in samples from the tongue. At the place in the house facility where our patients actually inhabit. And this methodology allows us to see DNA of Mycobacterium TB, and it doesn't give you an ability to detect which resistant profile against the TB medication this one has, and the screening, it's going to be easy to use and useful. And I think that it will find its use also in our algorithm for diagnostics. I also want to mention the molecular genetic methods that right now exist. They're really helpful in how fast the clinical decisions are made. This is mostly, as I mentioned before, GenExpert, MTB-RIF Ultra that allows us to detect the mycobacterial DNA and resistance to rifampicin in such a short period of time. And this is the primary diagnostic test. We all use it. And then GenExpert MBT XDR. The objective of it is to see the resistance to the first-line medication also in this short period of time this is happening. And so all of those tests that are leading the way in shortening the time to the beginning of the adequate treatment regimen, which is very much needed for our clinicians. And I would like to notice that when we've started to do our line of work, we only have microscopy and then the heart media, then the traditional microbiological diagnostics of TB that had formed the background for TB diagnostics. But right now, the modern technologies are allowing us to move forward and cultural methods for diagnostics in the liquid media and the backtech analyzers that are golden standards, and they are the background of bacteriological diagnostics of TB. And why and how comes? The automated system for backtech as of today is the rapid testing methods for TB. It gives us a positive answer from day 7 to some mycobacterium, and then most likely we are receiving answers from day 14 on day 42, and it also allows us to test sensitivity to all the list of medication that is accessible right now, including anti-TB medication of the last line. And this test can be ready to use from day 14 to day 55, depending on how fast the growth is present on the media. And this method allows us to differentiate the living or dead mycobacterium, so the viability assessment of the pathogen. This also answers the question about the activity of TB process. No other molecular genetic test cannot give us this kind of answer to that question. In modern technology, which is targeted sequencing, that is very much interesting to everybody. What does it give you? The assessment of the genetic code of specific pathogens of TB, the typing and subtyping, and then looking for genetic targets compared to GenExpert, which allows us to receive the genetic profile for resistance to a wider spectrum of anti-TB medication. And fortunately so, this recommendation is still conditional, and level of evidence to different kind of medication is not equal. So meaning they're still acquiring the knowledge on mutations, what kind of clinically significant mutations are there. So this method is still just being developed. And then the targeted sequencing, it does foresee the testing of samples directly without the culture roll method, which is important because this expedites the time till results and the transition to clinical consequences. And even though the targeted sequence is a breakthrough, it's considered a breakthrough, there's always a finalization of the results of the sequencing by the phenotype in tests of the medication susceptibility. And this is a bit of a load for the lab. Well, not a bit of a, it really is a load in the period of such a deficit of work for us. This is why even an organizational moment is needed to just organize it in a way, the working of the lab, so that everything was able to be done timely. And this stage, targeted sequencing is being recommended for the level of reference labs, as mentioned, not for all of the labs in Ukraine, but only for 1 or 2 labs within the country. And then the next part of my presentation is dedicated of non-TB mycobacterial conditions and diseases, which is the new challenge of today, which are the infections that are caused by non-TB mycobacteria. Natalia had in her answer had mentioned this before, and I would just like to highlight that non-TB mycobacterium, it's simple to Mycobacterium tuberculosis, so it's also the same kind of rod under the microscope as Mycobacterium TB. This is why it requires a very much thought out approach for its identification. The non-TB mycobacterium spread is only spread through the environment, not from human to human. And unfortunately, the effectiveness of treatment is around 50%. And then on the reasons of spread, and then Natalia has mentioned before, what I'm not going to mention about the clinical reasoning. I would just like to mention that the appearance of the new and modern diagnostic methods, taking into account microbiology, allows us to detect, identify mycobacterial infection of non-TB origin. And then a significant reduction in patients with TB actually opens up the niche to spread out the non-TB mycobacterium. And later on, I would just like to, on this slide, to demonstrate the classification of mycobacteria. That right now there is around 200 types. All of them look the same under the microscope. They're all just rods upon rods. In our knowledge and our skills, they can aid within the situation for us to correctly provide the clinical results in physiatry, physiopulmonology, the answer that which kind of mycobacteria this is. They're being separated onto the TB, and this is all the pathogenic mycobacteria that are causing TB in the human being. Right now, there's 11 of them, and that's this group from the tuberculosis complex. They're all look-alike, one to another, and then the approaches to diagnostics are the same, the treatment regimens are the same. And in GenExpert, what we're receiving is an answer that there is a mycobacteria of TB complex. On the heart media, this is what they look like. They have this pigment less, and they're looking like as a, I would say, as a color for flower. And then another group, which is the non-TB mycobacterium that right now we are speaking about, then they are around 190 of them, and they have the potentially pathogenic that cause mycobacterial infection, which is 30. It's around 30 of clinically significant mycobacteria. And as you can see what color they can provide, which pigment in incubation on the hard media they can provide, but it's not mandatory. Every one of them is given this concerned to be a very serious non-TB pathogen, and then they're taking up to 30%. And it doesn't give a pigment. And then because you can miss this with the Mycobacterium TB complex.
Сапрофітні мікобактерії, які не викликають захворювань, їх близько 160 видів. Тобто, бачите,
Now, speaking of the saprophyte mycobacteria, which are not causing a disease, but again, variety of them is very substantial, as you can see it. And now, looking at this slide, as you can see, they can be disseminated via different media and environmental factors, including water, soil, and other media. And pay attention to the elements highlighted in blue, suggesting the Mycobacterium kansasi, sepsis, which would be resulting in influenza-like diseases of the lungs. And also, they might be resulting also to something similar like TB. And there you have to be extremely careful to both clinical and microbiological diagnostics of such diseases. With that in mind, I also would like to refer you to the clinical guideline. Again, I don't want to recite it because that will be time-consuming, but we can be referring to both the British edition as well as American edition of the guidelines with clear criteria for diagnostics. But what I would like to do would be making a particular emphasis on criteria of clinical diagnostic for TB, mycobacteria-caused diseases, and the specificity of their diagnostics, providing for at least 2 indications for TB bacteria from different samples to exclude the cross-contamination or colonization of airways without any symptoms. Alternatively, at least 1 positive or bronchoalveolar lavage, and as the result, the suspect for NTMDs could be driven by clinical considerations and not only based on the laboratory testing results. As of today, in Ukraine, and again, this has to be underscored, to better understand what is the current situation, because clinicians do not sample patients for the benefit of diagnosing NTMDs. First of all, laboratory can see the results in the biological sample. These could be findings which have been identified when conducting diagnostic already. And that means that laboratory will be reporting to the clinician about availability of the pathogen. And here in the slide, you can see at what stages of microbiological testing you can assume availability of NTMs in the sample. As you might remember, the TB diagnostic starts with a gene expert. Gene expert, in case of NTMs, will be negative in any case. Microscopy would be next. This could be either positive or negative, but that will depend on the amount, on the quantity of the bacteria within the sample volume. And if you have some confronting or conflicting results, you can only suspect. And that suspicion can be validated via culture testing, either in liquid or solid media. So either Levenstein, Jensen being positive and negative in gene expert, allows us to suspect availability of NTMs in the current sample under study. And here in the image, you can see the port factor. But again, do remember that in case of NTMs, we won't be able to see such clear picture under the microscope, because here we can see these mycobacteria, which are quite distant from each other, and the probability of having NTMs in the sample would be even higher. But if you can see such colorful picture in solid media, then exactly you can be certain that you have to deal with the NTMs. Next stage of identification will be using and relying the immunochromatography test. So if you can see one stripe, like in this test, notch, which will be different from the TB case scenario, then you can be certain that these are NTMs in the sample, and that will be the full stop. This is the end of diagnostics, of the current diagnostics in the body of your patient. Because currently we have no alternatives, we have no follow-ups, we have no additional tools for diagnostics of non-TB mycobacteria diagnostics. But the rest of the world does. So let me explain why in the follow-up slides. I will provide you with a more detailed explanation, but I have to admit first that identification of NTMs in the sputum sample does not always suggest pulmonary bacterial contamination. This could be contaminated from external sources during the sampling procedure or transportation and logistics side, or colonizing the airways. That explains why you need 2 samples of sputum for the follow-up identification and validation to make sure you are dealing with the NTMs. While laboratory test results, they are only one part of the comprehensive diagnostic solution. To finalize and validate your decision, you need additional clinical and instrumental examination and research. As I mentioned, before 2023, there were 4 laboratories in Ukraine who identified NTMs thanks to molecular genetic system. We call it Heinz system by the Life Science Diagnostics. And thanks to that equipment and that technology, which relies on PCR testing, we could do that in 4 locations. And thanks to a couple of such subsets, we were able to conduct diagnostics for the most significant and non-tubercular mycobacteria. And thus, we could receive results within the matter of 1, maximum 2 days after sputum sampling. But today, this opportunity is no longer available. We are not procuring any reagents, and such identification testing in Ukraine is not available. And this, as you remember, would be the test result with a different type of stripes, clearly suggesting the NTMs, which are matching them here in the chart. And these would be the results for additional interpretation that would be provided as the laboratory report. So here on the left, we can see the names of mycobacteria. The list is quite extensive, but the microbiologists with some experience, for example, our laboratory is doing that for 12 years. But here we can see only 2 subsets for Mycobacterium avium and Mycobacterium abscessums. But these are subtypes. And that's important to acknowledge, because once you start discussing it with the clinical professionals, it's important to explain in order to discuss and decide on the follow-up management of the patient, which is critically important. Identifying of NTMs, Madam Natalia has described that already, can also be done by mass spectrometric technology which is providing additional tools and techniques, analyzing the protein profiles of the NTMs, which are quite unique for each type of the non-tuberculous mycobacteria. Unfortunately, such spectrometry devices are not available in Ukraine, although they are used widely in microbiology and pulmonology elsewhere in the world. Thus, we also would like to have such device. Currently, it's available at the National Public Health Center. And again, thanks to sequencing technology, we also can perform identification of the NTMs, which I mean the gene sequencing HSP I65, because their gene is available within each non-tuberculous mycobacteria. And since we are sequencing the patch, which has 440 nucleotide cores, we can clearly identify which kind of NTM is circulating within the patient's body and whether or not this would be a clinically significant strain. And then, following the same logics, we will have to decide on the drug susceptibility or resistance of that mycobacterium. But that will be quite complicated because of the heterogeneity of NTMs. The matter is that non-tuberculous mycobacteria do not have a universal definition of susceptibility definition. So the testing panel should be designed appropriately to the type of the bacteria and results of in vitro being correlated to the clinical presentation of the patient. The technology also includes phenotypical and genotypical definition of drug resistance. Speaking of phenotypical technology, there are excellent devices, the sensitive filter tracker, which allows us to identify the minimum inhibiting concentration thanks to automated interpretation. There will be the loopholes with different concentration of the medicine, and the only thing we have to do is to grow the mycobacteria to identify where they are growing at a slow versus expedient pace. When speaking of molecular genetic technology for drug susceptibility testing, in case of majority of mycobacteria, the full spectrum of resistance is not studied well enough. That's why this will be of assistive value. Sequencing is not quite feasible in case of most mycobacteria, except for minor cases where you can test for erythromyces. Within the Heinz system, you can test resistance to macrolides and aminoglycosides for Bacterium avium and Abscessus sepsis. Otherwise, there are no means for drug resistance testing. On that note, I'd like to acknowledge having some experience among Denmark, Belgium, United Kingdom, which, not in all cases, but at some laboratories, they do test for drug susceptibility of NMTs, remembering how expensive that might be. Speaking of practical laboratories, this could take a month to accumulate 3 to 5 samples, and thus we have to collect those strains so that later on we could run them as a batch, because nobody will be running a full batch with one strain only. That will be extremely expensive. And thus, we could consider establishment of a couple of local hubs or centers, maybe 1 or 2 per country, just to allow us to continue working with such non-tuberculous mycobacteria. Like in some countries, this happens at the level of national reference laboratories or at the level of institutes. As an example, this could be a research and development institution of the national level. And also, speaking of the clinical findings about the drug susceptibility versus resistance, the clinical professionals definitely should rely on availability of the local capacity within the country. But no matter what we suggest and or discuss regarding different technologies, the centerpiece of every technology would be a professional operator. Nowadays, this doesn't mean to have people with a microphone. This means having a team of professionals. And I'm confident that today in our online conference, we also have members of our team available, including the regional representatives, and their competence, knowledge, and expertise will be helpful in identifying the right method and technique, getting the defined results, and helping the clinical professionals interpret them appropriately. And on that note, I thank you for your attention and wish you every possible success in your professional and personal endeavors. Thank you so much, dear Alla. Wonderful presentation. Anytime I'm listening to your lectures, I receive not only a lot of information, but a lot of professional pleasure. So thank you for making that contribution. And with that, also let me thank you for your particular passion for microbiology and performance of the microbiological service and its capacity.
Сучасна наука, розвиток сучасних технологій і те, що, на жаль, більшість із цих технологій поки що нам не доступні.
Including also the most recent accomplishments and developments in the area of both technology and the science for NTMs, because if tuberculosis is more or less well established, then non-tuberculosis mycobacteria represent the pool of knowledge and expertise, which definitely takes us deeper into the TB relevant microbiology, which was lying flat some time ago and now is on the rise, and the same will have to be done with the NTMs. With that, dear colleagues, please be encouraged to continue. Do ask your questions. And now you have an excellent opportunity to continue your discussion with the professionals. And with that, I'm happy to hand over the floor to follow up with this pathway of discussing the visualization, which is another important element in diagnostics, particularly discussing the modern technology and opportunities of imaging, the modern imaging capabilities, new CT capabilities for diagnostics, and the role of artificial intelligence. And now it's very high in any discussion among professionals. So indeed, let us talk about that.
Chief radiologist elected, head of the development of radiological service, deputy director on the radiological diagnostics in the Dobrobit Clinic. And then Oleg, please, the floor is yours.
Шановні колеги, дякую за запрошення прийняти участь в чудовому конференції. Ну і власне поговоримо.
Greetings, dear colleagues, and we'll speak about the CT more so in the organizational sense. Last year, I think 2 times in this walls we had talks in terms of CT, diagnostics, and let's just repeat ourselves then how things are done with the organization management. So at the beginning slide, then we have done the statistics and everything else, a lot of the things we mentioned before, and then a lot of the things going to be mentioned.
Як же ж нам діагностувати, диференційно діагностувати легеневий туберкульоз?
How do we diagnose TB? There are methods different. There is an interesting trend, the recovery of X-ray. So is one of the methods of the diagnostics, and then X-ray didn't say all of it, but unfortunately right now there's not a lot of X-ray specialists right now. They're not in there.
Того, що в нас є достатньо великі кількості, в тому числі в Україні, це комп'ютерна томографія.
And usually it's a CT tomography. Time before we can mention that the CT does not provide us the equipment, and then and then the number of scanners per capita.
На рівні там Словенії, на рівні Польщі,
Slovenia, Poland,
своїх східноєвропейських сусідів. Тому питання
and then the matter only in accessibility.
Зараз, напевно, швидше за все не стоїть. Що ж нам дає комп'ютерна томографія в порівнянні з
As it now probably doesn't stand in its comparison with the regular
власне можливість бачити
if you projection the ability to see
активності, та звичайно там є
нюанси,
але ми поговоримо
its nuances and then to see what might be the signs of this activity.
ураженнями легенів, власне контроль лікування і візуалізація ускладнень.
And visualization of the complications, and then on this slide, and then to see pictures and everything else, and then CT and everything else.
Рентгеном полягає відсутності
And then
так званих сліпих зон, то це переважно
so the blind zones, which is retro sinuses, periostal areas covered by the diaphragm, and then mediastinum, heart, and everything else, and then the ability to conduct the research with the small sections, for example, and then because of that, there's small knots, and then with low density things, so something that you're not going to be able to see after COVID. This has become known because it exists for as long as I'm working as a radiologist, but 2020 nobody knew it, and now everybody knows what it is. And so right now the assessment of bronchi and bronchioles, and then you can have the situation as a assess the process, and X-ray does not have this ability, therefore, since it has a restricted part.
Це буде, напевно, не зараз. Власне, ми можемо
But
виявляти
this is probably going to be a next talk, and so different nods and different localization as the symptoms of Buck or the flowering tree, but it's not specific to TB. It can be in bronchiolitis and non-TB character, but makes us think on the symptoms regarding TB, and so the dissemination and as a so pleural excess then cannot be differentiated on the X-ray in the vertical position of the patient. And so classical signs and symptoms that can be in any combination can be met in the lungs of the human being and pulmonary TB, which is the presence of granuloma. So with small knots, they have a specific, this is solid ones, and then presence of the coverage. Bronchogenic dissemination of central lobular parts, and then this symptom that I mentioned before. Because of this widening of the pulmonary interstitium, most likely near the, and then the presence of cavities, and then having those lines as the prolonged process in the lungs, and also this can be ameliorary changes as the multiple small knots, and then calcification and lymphadenopathy that can also be. I mean, having calcium does not really says that it's TB. It's seen in other conditions and even in sometimes a metastatic injury of extrapulmonary tumors. But when we are seeing the primary patient calcinated anything, then we are still thinking that it's possible that there is TB in such a patient. Overall, among this differential diagnostics, the pulmonary knots is a separate topic because we have a whole approach to the pulmonary knots. We have recommendations of Leishner Society or British Thoracic Society that are telling us how we're observing those knots depending on their types, solid or not solid. Right now, we're not going in depth on this, but we can mention that the sign of pulmonary TB can also be lymphadenopathy, can be consolidation in pericardium, pleural excess, and then if you are comparing like how those processes can look like an active TB process or an active TB process or in some types of cancer, then in those processes there is a significant overlap. There is a significant joint changes present, and quite frequently radiodiagnostics without the morphological identification, it's not enough to see what we're doing with this time the number of this kind of pulmonary cancer that look like tuberculosis unfortunately increased, and then we're actively dealing with the interventions and thoracic biopsies. we are trying to biopsy things when we can send things to do an expert. Before we took everything in formalin, then we put it into histology lab, and then we got the answer that this is not a tumor process or it's not a cancer. Then we were sending to the gene expert, but now we are sending to gene expert right away. Histological assessment, because it's seen options when we are suspecting TB when we get cancer, and then other options as well. The classical cancer, they're usually having such a nodular part, and then they don't have any other parenchyma as in nodes or anything else, because it can be shown in the picture, the infiltration along with the pulmonary interstitium alongside the pleura. This is connected with the local or cancerous conditions that influences the whole lung. But if you are saying that there is an TB process or the situation when we are seeing that there is a pulmonary destruction, in an active TB we'll be seeing much wider borders, really thick borders. The surrounding infiltration will be known, and then a lot of nodes and lymphadenopathy will be more pronounced. And in an active TB process, then the widths of the will also be different. There's a bigger internal diameter of that cavity in comparison to the external diameter, and less pronounced the pulmonary changes. If this is the initial patient who just came for testing and you don't know anything about him, then to speak of those things is hard. But sometimes when we're seeing the patient dynamically, then we can see this response for glucation, and we're supposed to see it. And it's clear in such a conditions of TB to get a full radiological capacity. It's almost impossible, but we will try our best to more so having dynamically infiltrations changing around cavities and everything else, and how does the wall of the cavern are changing. It's worth mentioning the contrasting is being used by us, but we are also interested in the necrosis in the lymph nodes that we can't really see or didn't lead to development of caverns. So it's the process is still ongoing, because practically the attempts to differentiate TB from cancer by having the density, the dynamics of the density of solid parts, it doesn't have any success story to them right now. In small number of patients, it doesn't really show any promising results, or is not a discrimination between TB and, for example, cancerous tumor. And so the military TB, in the same way, well known to everybody who's dealing with this pathology, this is multiple different nodes so that they have an even distribution, because nodes are a separate topic, and then they are, in many processes, they look like the same. And the big meaning for differential diagnosis have their placement where they're located. And so this diffuse kind of settlement is characteristic to a inflammation. Usually metastases don't look that way. Sometimes we can see a similar type of during metastases changes. The only thing is that most likely in such a spread of metastatic condition, we will be seeing the significant changes on the interstitium and pleura as well. So here in pleura is almost not involved, and so you can see a significant mediastinal lymphadenopathy. And so we will be thinking of the pulmonary TB in its miliary form, and then active, non-active. I mentioned here before, and here it's for presence of USC changes, how are they happening, and then to characterize it fully, when in the left column we're seeing the signs of the inactive TB or active TB. It sort of notices down or tunes down. The central image is more prominent, and we are seeing the infiltration around the lungs, interstitium, and other localization. This infiltration is being decreased, and it's usually goes as lines or filaments, and those widening lines along the bronchus, and then or bronchi, but its manifestation is being decreased compared to an active TB process. And then what is happening within the modern capacity? And if you're mentioning about the high definition CT, it's already here. All those scanners have this function, so they don't, there's no issues, and those scanners are sub-millimeter depths in case needed. The only thing that you need to remember is a very important thing is that we are having high definition, but if you're looking at the unprocessed one as the 0.6 millimeter, it's going to be very noisy and a lot of the artifacts will be there. And self-structure viewing can be impaired. This is why we need to reconstruct those images in wider ones, 3 to 4 millimeters. It's much more comfortable to look at them, and train eye of radiologist or clinician that has constantly working with the pathology, and such images will be effective. Regarding tone counting CT, right now for spectral CT, for the detection and assessment of widespread of the emphysema, in their publication about their use for iodine cards, and then there's the data on the usage for the differential diagnostics and assessment of the spread out of TB. Even though they matter whether they give additional information in this scenario, it's really up for the discussion so far. And if you are mentioning about the capacity of AI here in the same way, most likely I am one of the skeptics using AI. There are reasons for that, and the main reasons is that all the modern models that we have on the market, that we'll have on the market in the future, because we're talking to people who are developing them, usually those models are developed for the diagnostic equipment, and each manufacturer has their own AI. When you're
вони пропонують щось своє, дають потестити. Воно все непогано працює, ну як є хороші моделі, які непогано працюють на
There are good models that are working on,
але в них погана всіх цих систем робота з зображенням іншого вендора, скажімо так. Тому вам потрібно або мати великий парк однорідного обладнання, на якому однорідно сканувати. В національних масштабах поки що
national scale, this is hard to do. Even the robot network,
ну і ми вважаємо, що це нормально.
We have equipment of different manufacturers, so this is just to be more and it's good to have widespread equipment. When you're looking at the same equipment, it works on different pieces of equipment because of specifics of scanning or those algorithms, and then it's not working well. With time, it's going to be better. So what can we have right now from what can AI propose for us? This is an automated cards or computer automated detection based on the protocol and the system and the comparison with the previous CT. It can be of assistance in the following way: to segment, to assess the pathology, to form a conclusion of separate type, depending on what we want to achieve from that. And for example, there is a picture and how it works. We see knots and everything else, and this is the app that marks with any other way the areas that we want to say that we want for them to mark in parenchyma, but at the same time, the second type the knots, and the third time's caverns. It's going to be selecting things that it thinks as such, and then marking in the following way. And radiologist's work is to defend the true changes from what is being considered of a change. For example, bronchiectasis can be perceived as a cavern. They need to say that this is not that, and then the equipment is putting it out. And also for knots, sometimes in a way a vessel is located on an artifact from breathing or something in a basal or near the apex of the lungs. We are using after AI, so we're just decreasing the degree of that condition. Usually it's usually doing hyperdiagnostics, and after that it just can calculate for and it's time and make cards, and then you can have 2 3-dimensional ones, and then there's consolidation knots or caverns, and then in the dynamics to track all of those things if we have a sufficient number of database, and then we have a sufficient number of comparison with the preliminary data. So far, in the context of TB, pulmonary TB, the real option of those instruments that we can really use, it's assistant in the faster assessment of the lungs as a future revision by the radiologist, and then the final assessment and the assistance in the dynamics of this process based on the, if you're having one image and then another image of the same patient to the dynamics, and then it can help us with to faster assess those changes and to give a more definitive response or a report if it's a positive or negative process. And then there's data programs that are showing us the dynamics of the process. This activity or not activity that was mentioned, this is the experimental model, because there it's a big overlap when every time we're seeing this picture for the first time, then to understand it in the special person, whether inactive or inactive tuberculosis, looks like at least can still prescribe the chance of activity. And then this is an additional instrument for the radiologist that needs to compare this with the clinical data, patient history, and also his experience and expertise. And so to give the finalized definitive answer, as the colleague had mentioned, so human expert that we cannot go anywhere for, hopefully so. And in that way, emerging imaging biomarker we can assess, and then we can get from those programs a specific number of structural description with the number of knots, parenchyma injury, and then presence of caverns. All those things require the future research, because this will be influencing the future of treatment, quality of care to patients with TB. We don't yet know. This is just single center studies that have potential, that have interest preserving scientifically, but right now it's early to say how universal they are.
And now, bringing this all together, the algorithms of artificial intelligence, imaging plus experience, that provides with a cumulative result. And finalizing my part and my contribution to this discussion, most probably we will continue to the same good old style imaging. Maybe there will be something better, but the price versus effect ratio is still in favor of the CT. Now, quantitative analysis segmentation, definitely this will be helpful, but there is so much to explore and research. But to do so, we need more cooperation with the clinical professionals, with technologists and designers, plus respective equipment and artificial intelligence on top of that to make decision-making more time effective and offering some solutions which can be further finalized and validated by the professional, either in a unilateral or multidisciplinary manner. Excellent, dear Oleg, and thank you for the perfect presentation, making this appealing, making this modern, especially for your contributions from the artificial intelligence. Maybe that would be the most appealing to many of us. And I believe that many of us who are clinical professionals are well familiar with those who appreciate the CT values. And again, even the highest quality X-ray does not come close to the performance of the CT, especially if that would be enhanced with all these add-on features. And we definitely are appreciating this kind of diagnostic reinforcement and support. So indeed, let's stay put for the new technology and the new tricks to come. While we continue along with our agenda, and before I announced our next speaker, I can see quite a big number of questions in the chat regarding the presentation materials and the record of the stream itself. So please keep in mind that accessing the recorded version will be possible at the YouTube channel of the National TB Hub. At any point in time, you can join our YouTube community and watch the record either in full or any presentation that you would favor at the time and frequency of your convenience. With that, continuing our discussion of about the differentiated diagnostic, where another tool number 3, following the microbiology and then visualization, will be the more precise intervention-based technology, which starts with bronchoscopy. And to discuss that, I would like to invite our next speaker and presenter to describe the new instrumental solutions using the needle IBUS biopsy, its advantages and possibilities, as well as limitations. This presentation will be made by Viktorom Bychkovsky, who is anesthesiologist in charge of the endoscopy department of the National Center for Medical Sciences under the National Academy of Sciences. He is one of the first professionals who implemented the technology in Ukraine, and will be sharing his professional experience. Thank you so much. Thank you, my esteemed colleagues. My major focus in this presentation will be done on bronchoscopy when it comes to diagnosing any pathology of the respiratory system, remembering that bronchoscopy is one of the most important techniques of the modern endoscopic diagnostics, and thanks to its rapid development, the technological context, it has become an indispensable element for pulmonologists, anesthesiologists, thoracic surgeons, and endoscopic investigation professionals, because we are not only looking at the trachea and bronchi, but also looking at the variety of interventions, collecting material for biopsy, removing foreign bodies, stopping hemorrhage, installation of stents or bronchodilating devices, and also using surgical interventions to remove neoplasms or to provide for dissections of some tissues to restore functionality of the airways. Looking at the growing morbidity of lung cancer and growing number of TB, which is associated with aggression and health attacks on health from Russian Federation, we also have to pay attention to the timeliness, availability, and accessibility of the timely diagnostics. And the most frequent location would be the mucous membranes when it comes to neoplasms, and also segmental, subsegmental, and lobar sections. Majority of them result from the mucous membranes of the bronchus exequites of the lung cancer, usually are growing at the bronchi opening, and thus they are blocking their passage. As the result, we have retrosomatic inflammations, including pneumonia and acidosis, and that is including hemoptysis as well, which can be addressed thanks to timely diagnostics and timely presentation seeking help, which can be complicated in case such diagnostic and help is not available, especially in the neighborhoods close to the front line and the area where hostilities are active. This can be manifested by the hemoptysis, as I mentioned, apnea, difficulties at breathing and coughing, and this could be also observed in X-ray, and also computer tomography will be quite helpful to provide for imaging and visualization, to look at the stage, to look at the metastatic implications, to look at the volume and exact location, which will be important for timely diagnostic and validation, and then selection and managing the case appropriately. Counterindications to bronchoscopy, speaking of them as such, could be either broad in nature, such as complication or acute stage of bronchial asthma, although that is not a direct counterindication, because sooner or later it still has to be performed even in case of asthma. Cranial circulation difficulties, epileptic seizures, mental conditions, cardiac conditions, or very ill health of the patient. We have to remember that intervention bronchoscopy includes different types of diagnostics for bronchi and lungs using this special equipment, which allows to intervene into locations of both bronchi and lungs which were not commonly accessible. There are electrical and surgical techniques which would be aimed at dissection or removal of different neoplasms or dissection of post-TB ridges, cryodestruction, which is aimed at the neoplasm adhesion or growth section removal, orbital biopsy, which would be ultrasound guided, which is important for diagnosis of peripheral neoplasms. The same relates to the lymphatic nodes to identify any metastatic formations, then bronchoblocation and stenting, respectively. There are needle aspirations with ultrasound and without ultrasound guiding. In most cases, I believe we prefer to avoid using transbronchial needle aspiration without ultrasound control. Looking to the recent practice, and which is also informed by the CT tomography of lymphatic nodes contributions, where X-ray professionals were positioning the respective transponders to lymphatic nodes, and the most widely used technique will be transbronchial needle aspiration with ultrasound support, which will be performed in real life setting. It would be associated with intrathecal lymphadenopathy of ventral nodes, sarcoidosis, lymphoma, or secondary implication. The IBAS-TBNA, the endobronchial ultrasonography with transbronchial needle aspiration, will be the most modern, mini-invasive technique, which brings together benefits of endoscopy, bronchoscopy, and now high-frequency ultrasound. And respectively, this combines benefits of both. This biopsy allows us to conduct complicated diagnostic objectives in different areas of expertise, including the impairment of the lymphatic nodes to see whether surgery would be relevant, collecting the sample size if it's located in immediate proximity to trachea or bronchis, identifying sarcoidosis, amyloidizing, and other similar diseases, identifying the infectious impairment of the lymphatic nodes, fungi affection, molecular diagnosis, to make sure that we can receive the appropriate sample for genetic testing, and also for assessing lymphatic nodes of any cranial collector section. Here in this section, in this scheme, you can see all, if not all, then most of them marked. And this has served as the golden standard for diagnosing the lung cancer, thanks to its accuracy, more than 95% specificity, which would be similar to surgical technique, while at the same time being micro-invasive. So in case of mediasthenoscopy or thoracoscopy, that would be absolutely different case scenario, allowing for the patient to be discharged within no time. The minimum complication rate, thanks to the ultrasound-guided technology deployed here, both as applicable to major vessels, but also allowing for more detailed control of the lung parenchyma location so that we can identify where exactly the node under interest is located, and thus preventing any damage done to anatomical units. Speaking of some limitations, which in my opinion still exist in case of this technology, the matter is that some of the collectors cannot be diagnosed appropriately. For example, number 3, 5, 6, 8, and 9 cannot be reached thanks to this technology, because in that case you should refer to the chest surgeons and rely on conventional surgical diagnostics. And also the sample size, because the needle usually extracts some cells for molecular diagnostics, but not a lump amount. But slicing the rods of the node, we definitely have the amount which might not be sufficient for immunological and histochemical type of assay. Another limitation would be the experience and competence of the provider and the overall cost, remembering also that sedation of the patient will be required. So the matter is that taking a deep breath by the patient during the biopsy can result in commotion of 3 to 4 centimeters. And we have to make sure that the patient is relaxed and stable. In case of patient who's fully conscious without sedation, would make it next to impossible. And also the possibility of false positive results if the amount collected would be demonstrating that this particular section of the node is accumulating the contrast media, then you may miss it with your needle and collect the sample from the adjacent section. So again, we have to be mindful of both advantages and disadvantages of this technology. Speaking of artificial intelligence applicability in our intervention-based pulmonology, my opinion is yes, there is place for AI. And the artificial intelligence has converted this conventional bronchoscopy into a high-tech procedure, remembering how complicated anatomically our lungs are with minor bronchi involved. And sometimes it's quite challenging for clinicians to find their whereabouts in order to identify and spot when conducting biopsy the respective spot, which could be only 1 centimeter in dimensions. And thus, again, this technique and its artificial intelligence element is used for respective navigation based on CT images of the patient, and thus the artificial intelligence will be navigating the probe, making sure that we are spotting the exact neoplasm or section of interest. Because we have to remember that we should avoid applying biopsy in the areas outside of the interest zone. Of course, using robotic systems with respective algorithms and assistive aids, which will be precise enough for ultra-thin catheters positioned in the appropriate section of the lungs, would be offering additional advantages with computerized vision and real-time analysis and support with the X-cams, which are guided by the neural networks that will be recognizing the anatomy of the patient and also highlighting the key benchmarks and beacons that will be guided by the respective navigation assistants, highlighting the areas of suspicion, micro turmoils, or some foreign objects which might be visually missed by the surveyor. But basically, this is the same technology which is used in gastroscopy and colonoscopy. Because in those cases, namely visual control, would be important. Cluster images, sometimes they are not clear enough, and that's why we need additional stabilization of the imaging of the ultrasound reflection, and also with the assistance of artificial intelligence, we are drawing a clear line of the lymphatic node.
Also, it knows the elements that the doctor has processed already and that stay without attention. The research is showing that AI with an assistant, the coverage of anatomical area increases 10%, which is a lot for the endoscopist. Now using the AI learning and different centers is being used for students, interns, and then for doctors and specialists that want to acquire. And in my opinion, AI is not going to replace a pulmonologist. A doctor pulmonologist will definitely not be replaced, but an endoscopist, but still the percentage of assistant is being provided by using AI assisted tools. And on this slide, on a video, like how does this process of sample collection is happening, that in real time, a needle is in the lymphatic node, and then syringe is being connected with the negative pressure, and then you're starting to slice the columns of the lymphatic node before you receive a material to the syringe. You can precisely see the border. The needle is not going out of the wall of the lymphatic node. And also the process of sample collection. So first we are taking out of the needle biopsy that we've taken, and then from the canal itself, the separated columns are being given, and then out of the syringe at the later date. I don't really agree that an insufficient number of sample material can be, but when you're cutting in the columns, you'll be able to see the tissue of the node. It goes in black, and all of that material is being selected up until to the pathology testing. Therefore, to have both with cytology and morphological testing as well. You can see on the picture the cytology. Those are this also the carcinoma. So we see that this is the oncological process and using pathomorphological testing, and then we're seeing that this is the small cell carcinoma. From the conclusions, interventional bronchoscopy is much safer and requires less time for the recovery of the patient than during traditional ones, but the traditional ones have still a place to be when our endoscopic methodologies that we are using, or testing methods are not always can be of help to us in selecting a big number or a big volume of the material. The capacity to conduct diagnostic in the higher stages of cancer with minimal traumatization, to making biopsy correctly, to have as the good result for the testing, and then the usage of interventional bronchoscopy as a stage treatment before a surgery is being conducted or proposed or anything else. And the last thing is on using AI, that it cannot replace the endoscopist, and it just gives them an accurate visions, and it allows you to detect the lung cancer in the first stage when the chances of patients to recover is much higher. Thank you so much for your attention. Thank you so much, Victor, for a wonderful presentation. Yes, I think that our clinicians are most so interested in innovations, especially during conferences. People want to hear out the perspectives for the future, because the diagnostics that exists right now, it does exist, and the equipment in the regions are present in this niche of interventional bronchoscopy. Colleagues, please ask questions into the chat. If you have the ability in the regions to have access to such a diagnostics, and we, at the same time, will be moving on in the next presentation in the part of diagnostics, taking into account that we are having still war in the country, we can't really avoid military combat trauma. How to correctly diagnose this, how to correctly treat it. And so the next step is being done by the thoracic surgeon. This is why it was the great pleasure. I'd just like to pass the floor on the military trauma of the chest to a medical director and thoracic surgeon on the National Scientific Center Pulmonology, Yanovsky, the Doctor of Medical Sciences, Alexander Tereshkovich. Alexander, the floor is yours. Thank you so much, Natalia. Thank you so much, dear colleagues. The wonderful presentation that we had present today. I think that we will be treating TB with the medication using AI, making this tomography. I would never want to make presentations, to be honest, but unfortunately life makes its requirements open. Unfortunately, when the science is developed and people will finally know to colonize the Mars. So our neighbors still fight our land. This is why we like to show how our work is different of the civilian clinic. I'd just like to say right away that this presentation has been done with their cooperation with their colleagues with the Chief State Military Hospital. We are cooperating tightly on the stages of evacuation of the patient. I'll show where we are at the evacuation and how our work has changed, what we are seeing, how are we cooperating, and what kind of results of our work do we still have. First thing that I wanted to mention is remember a bit of the information regarding the surgical component of our clinic. National Scientific Center of Pulmonology in Kyiv have 505 beds and 2 departments of thoracic surgery and 80 beds. Before war, we usually operated a patient with TB and lung cancer. In the beginning of war, the situation did change. And here, as you can see, in the beginning of 2026, we have treated 2,600 patients, military personnel, which was treated. And then 130. And then we have the experience. And then as every other health facility, we are participating to as much as possible and trying to help as well. So let's talk a bit about the structure of trauma of the chest. And I'd just like to, regarding the trauma of the chest, if you're trying to assess the dynamics, then even the time is going the last 50 years, the frequency of military trauma of the chest is still staying from 8 to 12%. And here you can see the compare with the Second World War and before today, the frequency of trauma of the chest has not really changed much. Right now, personal protective equipment, which is armed vest, allowing to preserve life. And there's much more surviving. But as a percentage, the frequency of chest injuries that are still staying high, around 12% from all trauma. If we are to mention about the type of trauma of the chest, penetrating, non-penetrating, blunt, that the modern realities, and then this change in comparison from the Second World War, the penetrating trauma has decreased. Right now, it's around 20% from all the chest trauma, 80% is non-penetrating chest trauma. The reasons are the same. Change in the over. I'll show there what we're seeing, that gunshot wounds are rare, and explosive trauma and use of personal protective equipment, and those are less changed things that allow us to preserve the chest from penetrating wound from they're not protecting from mine or explosive trauma. And if we are mentioning about the mechanisms of traumatizing factor, then what we're seeing is, comparing to the previous wars, the decrease in gunshot wound, usually this mine trauma. And there's the same reason, which is the wider use of the FPV drones, artillery, in comparison with the First and Second World War and previous conflict of the gunshot wounds. And so the mine trauma or shrapnels wounds are mostly increased. And the situation is not easier because of that. We can speak a bit about our place in the structure of care provision in military trauma. It is separated to 4 levels. The first level, this is self-care and peer-to-peer care on the place of an axe or where the incident had happened. Let's not go into the tactic medicine or anything like that. The self-care and peer-to-peer care is being done by the PCC protocol or technical combat casualty care. The main thing is to evacuate the patient, to stop the bleeding, evacuate them. This is just the self-care and combat medic support when it's possible. Bleeding control, occlusive bandage on the chest decompression in the tension pneumothorax, and then the evacuation and the following levels of care. For that, the protocol March is using massive bleeding, stop the bleeding, then airway management, open, and then the respiration, which is decompression, and the tension pneumothorax and circulation, and H, head injury, hypothermia, hypovolemia. Every military personnel, and they're supposed to have a chest decompression needle, and this needle is supposed to be used in case there is a tension pneumothorax. And from our experience, the people that are getting to us on the evacuation stage, we never seen the usage of this needle. And if they are really surviving, then the drainage is put in the stabilization point, or if they're being evacuated into a mobile hospital, then the drainage is put. Non-military personnel has shown that this procedure has actually been needed or performed. The second level, which is surgical care, medical care, essentially. As I mentioned before, military personnel can be evacuated to the stabilization point, or they can be evacuated right away into mobile hospital. Damage control surgery, stage 1. There is a doctor there, and then there is a surgery room, and anesthesiologist there. Emergency procedures are done so that the patient or the injured person to survive. Thoracentesis, drainage, and if probably needed, thoracotomy being conducted as well. And everything has to be conducted fast. And this stage, injured person spends under 24 hours, and then they're going to the one, then the triage, and then sending to the next stage. The main stage is third stage. Here's an initial antibiotic. Prevention is being done, and then evacuation to the certain level. If you see the slide on the right, this is a strong feeling. The chest drum of an intubation tube is being put into the defect of trachea and thoracentesis with a drainage to the stabilization point, because of hemothorax. I wanted, before I'm showing the slide, those slides have been presented by my colleagues, which is Alexander Mitchenko, who is a co-author of this presentation, who is right now serving in Armed Forces of Ukraine, who is working in a mobile hospital on a rotation, and periodically is in Kiev and periodically in the front line. This is what the military trauma of the chest looks like. In this reality, this is almost likely polytrauma with significant injuries, thoracoabdominal trauma. Isolated trauma is being seen rarely, quite rarely. eventuation of the organs, the disruptions of limb, traumatic amputation. Those are the real pictures to understand like how complex the situation is on the evacuation stages. Unfortunately, this is what polytrauma looks like. When you have such an injury, then there's going to be concussion of the lung, pneumothorax, or other injuries that require surgical action from the thoracic surgeon side. If here the thoracic surgeons are present, this is the real video presented by the colleagues, which is the emergency thoracotomy and the stabilization point in patients with the and then the emergency thoracotomy, and then there is an evacuation blanket. Surgeon is not dressed at all because this is the emergency procedure. Surgeons are also people and they require rest, but those procedures are emergency thoracotomy. They allow us to remove the tamponade, and in that case to preserve the life of this injured military personnel. This is what it looks like in reality on the level 2 of care. The third level of care, third level is the main level of care, which are hospitals in Dnipro, Kharkiv, big hospitals where they're taking the main specialist care. Damage control surgery is stage 3, which is re-thoracotomy. From the secondary level, they didn't put a drainage or made emergency thoracotomy. Vioaporotomy, the air movement, they will put the bronchus to use or put the vacuum suction, and then they'll provide the main types of care. Additionally, testing for the patient. They will conduct the prevention of early complications. Then they refer them to the next stage of care. And level 4, right now our hospital is working level 4 because we are really far away from the front lines, which is reconstructive surgery, complications surgery. If they don't have any complication, this is the continuation of treatment. This is the reconstructive surgery. And if the patient has complications, then this is treatment of enclosing defects from the wounds, conducting reconstructive things regarding the complications or anything of that sort. As I mentioned before, we are now working at level 4. When we had the occupants was near Kiev, for a time we worked on the second level and third level of care. And right now the easiest part of our work is the removal of bullets and shrapnel. For that we use magnets that allow us to evacuate thoracotomy parts and shrapnel from the chest of the patient. Right now, it's easier to do than before because in the beginning of the work, there has been a lot of fascinating factor that has, it's an expensive thing, but right now, heart beating factor, they have metal, they're usually easily magnetized, and then we can endoscopically remove them. This is the case from last week, the removal of the shrapnel in the patient. In this case, if you see this was used EOP because it was really deep. From the FPV drone, we weren't able to find it was the magnet, even though we removed it, there was magnetized. And therefore, still, because it was located deeply in parenchyma of the lungs, so this is the endoscopic magnet that we used to look for them. And then using videoscopy, we were using that. And then we were not able to do that using magnet, and therefore we used the usage of special equipment that allows us to see where the shrapnel is located. We are not removing all of the shrapnel. We are only removing the ones that are centrally located near major vessels or near the heart. Peripheral parts can stay. There's no need for that really. And the most complex work, which is treatment of complications, is we are hospital level 4. We have complications coming in, so the patient has been, once we have surgeries on the level 2, level 3, they have complications, they cannot take them because and we have a lot of patients with the brachial fistula was the detached wounds that we are trying to treat. This is why we developed our technology together with our bronchologists. When we are using a vector or video thoracoscopy, this is the MPM Alpora, then we are placing a valve, we're creating negative pressure, and we are inflating the lung. On this slide, the patient after tracheotomy and the stages of the few drainages, the wound is awful, and then the result of using this methodology, the lung is fully uncollapsed or inflated again. This is a different example. A volunteer in the army, you can see that there is mind trauma, and then a portion of his ribs has been put out, and then there's fistula, so it's a big one in the bottom part of this. So there's a diaphragm of this, and this one will never be inflated again. So the methodology has been used that we worked on before. So we are doing vac therapy and putting it in the brachial valve, removing the vessel, and then after that we're doing selective thoracoplastics by closing the defect, and that way by fully closing the defect of the patient. This method for endobrachial valve has been made for treatment of emphysema before, and for a time it was very much actively put forward for treatment of TB. You probably remember this time.
So again, this would be the golden standard for complication management, because the valve can make sure there's only one-way direction accessible, and there are different model designs available in the market. Here on the left would be the domestic manufacturing from a Ukrainian supplier, and also there are some examples of devices from international market. Ukrainian are more affordable, and again we're using them for the patients with different defects of the chest, including one of the patients today. But again, currently this is an off-label technology which is saving lives and has saved lots of lives, and the Ukrainian manufacturer devices are affordable and effective. And here you can see Viktor Buchkovsky installing the bronchial valve. This is done in an intra-operational manner, which means we are working jointly in the same surgical theater. We're installing the vac sponge while Viktor Buchkovsky is applying the valve, and then we do the negative pressure prior to sanitation. And once we have the negative pressure, we can provide for environment for granulation and closure of the opening. And this is what it looks like in real life. This would be the patient presenting with the tampon in the wound, and the vac therapy was installed, then the valve, and after conducting the selective thoracoplastics, remembering about the defect or seal type defect of the chest, the patient is discharged after the blast injury. Another example involving plial pneumothorax, and this was 1 month after the injury with collapsed lung. Again, endobrachial valve installed. We managed to perform the lung expansion gradually, post-surgically, but the patient finally was discharged with the wound fully sealed. Another part of our job would be working with the defects after the blast injury in collaboration with the colleagues from the Central Military Hospital using the VAC technology and plastic materials. Here you can see the bone fractures, rib fractures, and major superficial and interstitial defect, which was sealed. Another example, fracture of ribs from 4 to 8, concussion, pneumothorax. We are also cooperating with the colleagues to provide for the wound closure and sanitation, and then plastic surgery at the final stage. You can see that in different pictures in different stages with the final result. So again, as you can see, you can use patching following the sanitation to seal the affected zone. Quite frequently, we're using the VAC therapy, and speaking of some of the developments, we always start with culturing. When the VAC sponge is applied, we do the culture. We avoid frequent dressing. If the wound is stable 3, 4, up to 5 days, patient may be using one dressing only if there is no oxidation. The matter is that we are trying to minimize the wound area. Avoid stitching, avoid sutures, and respectively, only after the sanation of the wound has been achieved, we provide for the closure. And also, thoracoabdominal injuries are quite frequent, and diaphragm will be affected in most cases. That can be diagnosed and attended only via plastics of diaphragm using the endoscopic technology. Another collection of slides. As you remember, we exchanged some prisoners of war. One of them was presenting to our department. So again, this is the serviceman with bipneumothorax, body mass deficiency, no medical care provided for this prisoner of war by the Russian Federation. Again, capitalizing every word, not a single element of healthcare service was provided to this Ukrainian prisoner of war, remembering that he has TB and major body mass deficiency on top of that. Now he's been discharged, he's on a recovery plan, and this would be the replica of a well-known image which I used for the closing slide on my presentation, because here we have no choice rather than never giving up in whatever we are doing. Thank you so much, dear Alexander. After your presentation, I'm having difficulties of finding the right words to describe what I would like to be expressed and articulated. But the first thing which comes to my mind is the expression of gratitude. To thank you for your job, for your titanic efforts, and for the effect that you are doing when helping our servicemen, even in some of the seemingly hopeless situations, bringing these people back to life and recovering their health, recovering their functioning. Dear colleagues, we look forward to your questions, to your contributions. Maybe we have some colleagues from the regions who also have to deal with a similar kind of trauma, including our thoracic surgeons. So please make your contributions in the chat, provide your questions and comments. We'll be happy to discuss them. Meanwhile, taking us closer to the final presentation in our session, speaking about modern diagnostics of bronchoobstructive lung diseases, because this is the pathology which is a gentle killer, which is the unseen enemy that always is associated with almost any pulmonary disease. So the question is how to diagnose it appropriately in a timely manner, and following the trend of our conference, using innovative technology, digital technology, artificial intelligence when it comes to diagnostics of such obstructive diseases. So that would be the key subject raised as the hypothesis of such presentation, and whether or not we have some tools and techniques that stand helpful in that regard. I'm happy to invite Vitaly Poberezhets, who's a pulmonologist himself, working at the Pirgov's National University, official representative of Ukraine in the GINA and GOLD, member of ERS, and also British Society of Antimicrobial Chemotherapy. Thank you so much, and thank you for the kindest invitation to take part and speak at such esteemed event, and also the armed forces of Ukraine, thanks to which defense and function we have the opportunity of staying here at this esteemed conference. And indeed, we have no alternative right and duty, unless we are serving active duty, than to serve the best of our function and capacity we can in the positions that we assume. In my presentation, I'm making a particular focus on digital technologies in medicine. Following up on the discussions on today's agenda, we indeed can see there is some threat posed by the digital technologies because they'll be taking our jobs out of our hands. And again, we all remember the Terminator film. We can see what are the elements of threat can be posed by digital solutions and machines. And sometimes we believe that our function is negligible as compared to capacity of the digital technologies. But again, just like in the Star Wars, the episode 4 was about the new hope. Now we have the new hope of becoming better functioning humans and professionals as compared to those digital solutions. Recently enough, in the ERAS, there was a monograph. Yes, 2 years passed since then, and some of the innovations described here have become almost obsolete, because 2 years of time in the modern world, this is the entire age. But here we try to summarize those solutions regarding imaging, using digital solutions and technologies. And again, this monography is available free of charge at the official ERS site. Please refer, and you can feel free to download and use this material. But again, the focus of my presentation today will be on the diagnostics. Since I'm working at the Department of Propaedetics of Internal Medicine, then I grow confident and convinced over and over again that the good diagnosis at the good time and good place for the patient is the key. When we are speaking about broncho-obstructive diagnostics, we pay all of our attention to the lung health. And such technology as spirometrics is quite fundamental. Nothing fancy about that, but I do receive multiple requests from my colleagues asking for advice, either in its administration or interpretation of the results. And there is more and more confusion about it, and we are not alone in that. Back in 2021, working together with the Leidens Institute colleagues, we conducted quite an interesting research. They have designed a machine learning algorithm to help clinicians to interpret results of external breathing function of the patients based on the patient history taking and other facts and indicators. And the research team compared the efficacy and accuracy of this tool as applicable to diagnostics. And as you can see, 87% of correct and valid answers for diagnostics, that's quite high. And we could see that pulmonary care professionals, including myself as part of experimental team, we lost to the machine learning. But once this element of artificial intelligence was integrated into the assistant function for spirometry interpretation, when you could take into consideration or disregard the prompts suggested by this machine learning tool, then here we received the best possible results, which were superior to both man-made findings and machine-assisted results as well. And thus cumulative benefits could be the most promising and effective. And thus, having integrated this artificial intelligence element into the spirometric testing interpretation algorithm, we have designed a systemic element for clinical decision-making. So that would be an example of integrating digital solution into medicine, where you take some clinical data from the patient and then use a systemic assessment of your next steps and decisions. For quite a long time, this was functioning as a rule-based algorithm when you would be determining some red flags, some key phrases collected from the patient history and interview to provide you with the hypothesis of a diagnosis, and then navigating you to the final diagnosis and treatment plan. But then everything changed in 2022, when the generated version of artificial intelligence, in other words, the ChatGPT, became available. And here we could see the element of machine learning functioning in practice. Again, there's a lot of criticism there too, but we have to remember it's not the purpose that it was designed for. Nevertheless, it's quite helpful for clinical decision-making. And thus we had two options, either using the algorithm based on the rules and regulations with clear set criteria driven by the symptoms, taking you to such symptoms and such treatment plan, otherwise machine learning algorithm, which is the algorithm allowing a computer to learn from the data received in real life and then make independent decisions. Again, there is a lot of criticism. But last year, together with my students, we looked at the performance and efficiency of the step 2 machine-generated responses. So as you can see, in other words, this would be the machine that went to university and graduated with a diploma. And we compared that with the testing results of clinicians who went to postgraduate education courses, and they also had to pass some tests and examinations. So my idea was, what if we design a model of learning that would be designed for clinical case interpretation? Maybe it will be functioning better. And this is where I faced something terrible, which was programming. I heard there is a Python, I heard there's C++, so that was the extent of my programming capacity. But now there are opportunities and tools which are helping you to write the codes, to write the strings, or there are some applications which require zero coding capacity and knowledge. So again, the level of my skills would be here on the right. And again, this is not an advertisement of any sort of promotion. So I used the OpenAI Codex, which is kind of GPT for code string writing, which helped me to generate two things, RASA and TensorFlow. RASA is the dialog module, which is used for translation of the complaints, human language, into language accessible for the computer. In other words, he can understand your speech. And then TensorFlow is the special program designed by Google for which is open source information, open for public, which again is helping you to communicate with the machine learning interface. And in between, I link them with this logic based on the rules and regulations. So I'm taking this linguistic tool, making sure that we are using the same language, bringing this to the set of coordinates regarding the diagnosis, and then augmenting this with a machine learning algorithm. Initially, everything went with major difficulties, but the more material was processed, the longer algorithm was consuming information, the better and better it started digesting and processing it. So definitely it kept me busy overnights and over the evenings to create such chat box. It's not ideal. I don't want any credits and merits here, but it helps to analyze, to process the complaints of the patient, helping you as clinician to identify the reason for such manifestations like cough, for example, and then analyzing all of that with a machine learning interface and algorithm and providing you with diagnostic interpretation and recommendation if and when necessary. So in the final run, I decided to compare how effective was that in terms of performance as compared to ChatGPT result, both the trained and non-trained version. What is the non-trained version? Whenever you just start a new dialogue and you set some materials for the chat to learn from, the guidelines on cough symptoms, for example, some other materials to read and train, and then Gemini for analysis again. And as you can see, the chatbot accuracy in case of COPD, asthma, heterogeneal text, or gastroesophageal reflux was a lot higher as compared to conventional chatbots. And again, I do understand there are some limitations, and the quality of forecasting and prediction will depend on the quality of inputs that you are providing. And the model can and should be expanding because the number of reasons for chronic cough is immense, and distinguishing between them is also an art. And thus, system is also serving for supporting your decisions, but not for replacing your function.
There's a list of advantages like flexibility when there is specific logic based on some rules, and so the role of it imitates and can understand the unstandardized situations that are happening in our life, and it can adapt to different groups of patients. And the training is conducted fast, but there's different things that has to be done so that this model to be spread out and made bigger. Why am I mentioning this? Because even this person that has and have the minimal skills in coding, it's hard to say that this is coding. Modern technology allows us to create the clinical objectives and active tools, and I agree that they're not, but they have a trend to training and improvement. And who can implement and for an improvement in their work. But if you're doing that, we need to understand this general strategic objectives. The first objective that we have to receive, and then this is something as the interoperability. So this is interoperability of data for the data exchange, and then we're not supposed to be storing digital data just to store them, and then the data has to be interchangeable, and then the CT tomography, and then the data is supposed to be depending on the manufacturer from the type of tomographer and other data in the European Union, and then European Health Data Space, and then they're working for many years on that. And this initiative is on the data from the patient, and then was taken in Spain or somewhere else, and then into the clinic from Barcelona because of the disease. Then they can get in the clinic and receive the access independently on which country they're in. And then allocation of the data. This is strategic objective where the algorithms of the computer learning can actually learn. The more data you have, the better they're working. The less data you have, then the much worse their data is and working is and how they're processing. And the second thing that we need to remember is the acquisition of data. We have the issues with cybersecurity. And then because we are living when our enemy Russia is trying to attack us in many ways, apart from the internal enemies as well, and then other factors, and then acquisition on the big number of data, sensitive information about our patient, their conditions, diseases, and everything else. It's in terms of unsafety, but this has to push us away from the digitalization and then get back to the paper-based option that it's impossible to track, process, or work with. I don't think that, and I'm not sure. And for an example, there's a great story in 2017 from London. I was talking to my colleague that worked in one of those clinics, and if you remember, the business center in London was under the attack of killers, and then a few clinics have suffered from that cybersecurity threat. And among them, there was a clinic that was one of the leading on digitalization. They have been saying that they're fully no to paper in their clinic, everything's digitalized, digital patient records, and then in QR code, you know everything about the patient. And then can you imagine that in that situation, all the computers have been shut down? They said that they had a full chaos in the clinic. It's impossible to understand if the patient is unconscious and who is this person, what does they have. They barely understood like who do they have to deal with. And even though the results of the laboratory testing and the lab and then the QR codes has been lost and everything else, but when they fought the situation, what kind of conclusion did they get? They didn't get back to the paper form, then they didn't say no to digitalization. They started to treat much stronger and take care of the cybersecurity much stronger, because collecting the data from our patient by analyzing them, and before that, not after, but before that, need to take care of their safety and then to think strategically. Therefore, thank you so much for your attention. Hopefully our cooperation with digital technology would allow us to effectively and in better way to work in our area of work. Oh, thank you so much, dear Vitaly, for being so creative, being so modern. And then as far as I understand that you are a representative of our government on the world arena that are dealing with the implementation of AI in pulmonology. And then we are so grateful that you're positioning our country in such a high level of, and then to add into the international recommendations that are giving us in the international level, also Ukrainian portion of you for your practice, of your thoughts and ideas. And I think that because of that, our government will be, our country will also be getting closer to the European medical community. And then, yeah, thank you so much. And then our session is over. And before we move to questions and answers, we do have questions to the speakers in the chat. I would like to say to our participants of the conference to voice once again, because there's many issues about that there's a recording and then of our conferences. And then let me inform you once again that the conference is being broadcasted to the YouTube channel right now, National TB Hub. And also the access to the recording of the conferences as of today's and tomorrow's will be accessible on the YouTube channel. It's also the recordings of all the previous conferences, events. This is also can be viewed on our YouTube channel. There have been questions on the test kits. The test kits will be accessible, or beg your pardon, test questions for the conference tomorrow at the end of the day too. After the last session will be finished, you're going to have 15 test questions, and then for them, there's going to be half an hour. Therefore, please get ready to the tests, and then we are hopeful that everybody of our participants that will listen to your conference will go through to the possible results, and then for you to get the certificates with the points of continuous professional education, you need to give the response to 70 plus correct answers. And then we're moving to the discussion first, and then the first question to Anna was a very interested question in non-TB mycobacterial conditions and about this dissonance between the clinical and microbiological results. And then in participants, that there was a question that if we have a positive results for the cultures and for many times before, and then there's no clinical manifestation, how to assess this, who is wrong in this situation, microbiological equipment or the clinical, if it's clinicians. And here, nobody is mistaken. It's just that, as I mentioned before, the non-TB mycobacteria instead of 190. Therefore, if in the sample collection there is a non-TB mycobacteria, most likely they're not clinically significant. And then there's no clinical manifestation, and then the mycobacteria, and then loose circulating in the body. I would just like to say that even the mycobacteria urinae, mycobacteria gastri, and others, and then that are circulating well and none of the clinical causing disease or anything else that there is a need in treatment. That's it, because they're not separate microflora, and this is it. And so nobody is mistaken. And then based on our clinic, we are always speaking with the clinicians, and then we are going through that situation. Therefore, I recommend everybody, but this is the collective line of work. Thank you so much. Well, thank you so much as well, Hannah. And maybe a question more so to you than to Anna. And then there was last week we discharged a patient that has been open, and then bronchiectasis has been there in the surgical material, microbiologically non-TB mycobacteria. So what to do? We have a triad. So right now, international experts are telling us if before microbiological confirmation was sufficient to have mycobacterial things and to start the treatment. And then right now, the three factors has to get together, and then the clinics, and then microbiology, and then radiological signs and symptoms. And then this process, if we have, and then and the three components are there, then we can assess this as a condition. And then to look at the regimens for treatment, because it's really much individualized. And then if we do have one time use of the culture, and then what will give histology for us, and then if it will give us mycobacterial, but it's not going to give us, it can be TB, it can be non-TB mycobacteria, but if the overall is a positive culture histology, and also you need to understand like what kind of clinics there is, and then what is the radiological picture, and if everything that's we're putting a plus to everything, then this is the active ones. And then if this is just the cultural verification, this can be contamination, this can be saprophytic flora, and then this is just a dynamic, so just individualized approach. And I'm grateful to that. And you're doing not just the clinical line of work, but also organizational, and we are cooperating. And so I have the question, let's put ourselves at the space of the patient, and then where does the patient, and then and used in the TB medication. So I mean, macrolides, and then where do the patient take the anti-TB medication that right now we are receiving as the country from the Global Fund funding, and they're supposed to be widely available only for the patient with TB? How does the patient would approach this issue? our government has started this long and tedious process. Maybe it's a bit too late, but they're still stepping ahead. The first step was done on the level of Ministry of Health. They developed a working group, and because so that the National Health Service of Ukraine to form, for example, a separate package to do that, and they need to have another separate package or to include this in the package number 20, so that and the type of medication and this because of the monitoring and everything else, they're quite similar. You need to have a standard of care for that. And then me and Marina Pogrebna, we are part of the working group, and we are hopeful Anna Ivan will also be included into the working group. And then we'll be working on the standards, and as that I think it will be taking up in the attention, and then they will probably gonna be somehow how those people were supposed to provide with the medication. So right now you're supposed to say this honestly, this is a gray area, and so that to the person we can recommend do what within the 9th package to consult them, and then we can also therapeutical process, then you're getting the but there's no way. So this is getting back to this patient, and then this is an objective part, and then this is a great medication, and then there's going to be even more. The most things is just move forward, and we are on that path, and then it's great. And then I have a question to Oleg. It's a great presentation, and then I got so much out of it. Thank you so much. And then from your experience in the world, is there a working model that you can ask a question on differential diagnostics, for example, of TB and cancer, and then to receive an adequate response? So far, no. As I mentioned before, the models for there is an enormous overlap that it's not clear how to fight without morphology or morphological detection, and the models are set to early detection, and so I'm trying to do something with the nodes. So if you're mentioning about the and then the indexes and the graph index that allows you to and then the process that it can be a cancer. For that, you need the some patient history, so that if they've been smoking or not. And then sometimes they're using that, but as you're mentioning before, the decision from out of the box, unfortunately, it's not present at all. And your presentation has been profound. By the example that you show is the differential diagnosis of cancer. If we're speaking about the destructive forms of cancer in lungs, having my own experience, and I might be mistaken that here it's not just to a person and not just to an eye. It's even harder for a person. Those and everything else, and then slides. And this is what I mentioned before, that you're dealing again number intervention rate. It simplifies things, but I don't want to think a lot, and I'm just saying that there's no. So let's just do thoracic biopsy, and then moving on from where specifically something is coming from to get the most adequate results. And as I mentioned before in my presentation, that in the past months, what we're trying to do is having this two niche formalin and the histology lab, and if it's not cancer, then we're thinking. So we are thinking and we're putting that for ourselves into the differential diagnosis even before the verification happens. Critical question: where are you sending for the gene expert? Here. And this is a nicer thing, right? So then I would have, within this discussion, I would have a question to our bronchologists. How would you assess the sensitivity and specificity of needle biopsy? Which percentage of hits and getting answers to what was that thing? And so to which extent this method is better compared to the previous ones? Or is this, has this increased how informative something or improved in quality material? As I mentioned before, the needle biopsy was usually fulfilled without ultrasound support, and using CT, the points of punctures has been formed. So I think that we were also using this method before when the endoscopists were asking to draw a virtual bronchoscopy, and then they were drawing using 3D reconstruction and CT, and then their points were the puncture for the lymph nodes. That we had that before. So right now we are using ultrasound. Using ultrasound, we are seeing vessels, even though the vessels and arteries and veins on Doppler, they would look differently, right? And then also we're seeing the vascularization of the lymph node. And also when I've shown you the slides, they had like the small flow chart on the lymph nodes, and the typical placement for the collectors, we consider this as the new formation. We had a patient on one of the testing and there was really tightly packed. We thought it was a node. Even on CT, it was mentioned that this is the metastatically involved lymph node that displaces as a second collector, displaces the trachea and everything else. But in this endoscopy, we were ready to puncture it, and then we did the bronchoscopy. On bronchos, we haven't seen anything apart from compression. And in gastroscopy, we saw that there was invasive growth from all of the parts of the esophagus and the invasion of the tumor. This is why, in my humble opinion, since we are working for a bit of a long time, everything has to be done with the ultrasound control. This method has high sensitivity and everything else is minimal complication. On the slide, this has been presented that with 95% informative, under 95%.
And then modern navigation systems will be helpful. The matter is we don't have them. But we are aware that internationally such systems are available and they are broadly used by the leading clinics, which means that artificial intelligence has its place in the endoscopic studies. Without it, we won't be able to move further, but they won't be replacing human beings and professionals. Yes, we can see the vessels, we can see the areas which are affected, modified, any invasion, and we will be able to guide the point of puncture to hit the nice spot. So artificial intelligence is helping with navigation. There is future in it, but only in compliance and accord with the clinician. Thank you so much. Thank you for your opinion, dear Victor. And as I can understand, there is a lot of areas, ways, and possibilities for improvement. Absolutely. So definitely with the new accomplishments of the artificial intelligence, we definitely will be benefiting from the new accomplishments. And quite possibly in the conferences to come, we will be demonstrating such accomplishments in reality. With that, dear Alexander, I have another question to you from an organizational and administrative point of view. What would be your vision of the algorithm of assisting in case of combat injury to make sure that at the earliest possible stage, the patient, the serviceman would be benefiting from available care and support, not in the remote future once they've been relocated to the stage 3 or 4 of referencing their case, but making sure that logistics, organizations, and providers will be available there on site. Well, I believe this is not the right way to put this question, addressing myself, because the medical command, over the 4 years, we have the mechanisms and the respective staging logistics well established. But the military medical system is quite well, if not excessively well regulated. And thus, if there is a patient, as injured serviceman, could be referred using one of the logistical solutions to be referred immediately to the respective clinic available in Kyiv versus Vinnytsia or Lviv. So indeed, we need some new pathways to have them referred immediately to the clinic where local professionals can do this the best among the others. And I do strongly believe that in this particular sector, willingly or unwillingly, we have advanced and progressed substantially enough, namely thanks to having such technologies as VAC therapy, valve-based broncho interventions. And I don't remember a single case when we failed to provide support, including pulmonectomies. We did have some difficulties, but even there, relying on our non-support from our oncologist, we managed to do so, sometimes even without thoracoplastic interventions. So the system, from logistical organizational point of view, is well functioning. The operational burden is another thing, because sometimes we cannot manage the numbers. And also the matter of over-regulation. Sometimes there are vacancies, they have to be filled, and then based on additional communication, they are looking for additional opportunities to provide assistance to that particular patient, whether it's from neurological, pulmonary, or any other kind of approach which might be necessary in their particular case scenario. And I believe everybody has a directory of phone numbers that we exchange regularly. And today, we have one patient in the surgical theater and another one in the reception area. But again, this takes time, this takes effort. And the occupancy rate is also a number which is determined by the time factor. It takes time to help such patients. Thank you so much for being so open, and let us be hopeful that this element of time, including the timing of hospital admissions, will be the least significant factor in the process of helping our servicemen to recover their health whenever the combat injury is involved. And probably the closing question, it was quoted in the chat, and I also would like to raise it, addressing Vitaly. Now we have so many AI-based assistants to clinicians. They are available in other areas as well. So there are some applications, smartphone-based application, where a clinician, let's say a family doctor, who definitely might not be knowledgeable about every possible health implication, they collect some patient history, they interview patients, enter the data into application, which is generating the diagnosis, generating the recommendations. I believe you were designing something similar, but I do remember you mentioning that you failed that attempt, because the frequency of appropriate diagnosis statement among the AI options was higher than that compared to the clinicians involved in comparison. But what would be the place for such applications? At what level and for what purposes and specialists would that be applicable? For the primary care providers, as kind of an assistant for family clinicians, or specialized care? And also, both saying boldly enough, will there be time and place when such applications and software solutions will be replacing the health professionals? Well, there are supportive systems in clinical decision-making. That's something I was explaining, and they've been evolving over a recent decade. Interestingly enough, we also made a survey together with the students, interviewing residents of the local communities who stay in the frontline neighborhoods, when local people having no access to clinical support were asking questions to artificial intelligence, to ChatGPT and some other intelligent solutions, either asking for health advice or validating the health advice provided by the clinicians. So again, sometimes patients could not even understand the difference between the AI answers versus health providers' answers. And sometimes the quality and approachability of AI-generated answers were higher than those provided by healthcare professionals. So AI algorithms are quite skillful in communicating their appropriate information to the patients, sometimes doing that even better than healthcare providers can do. And again, the problem is that the market is not well populated with well-trained and relevant solutions. But at the same time, quite frequently, they find pathology in the place where it doesn't exist. Taking 100%, almost in any case, they can suggest having a node at the CT image. But whether this is within the acceptable norm or outside, i.e. becoming the pathology, that is yet the borderline where artificial intelligence cannot apply the appropriate discretion. The matter is that artificial intelligence is trying to please the people, to please the humans. If you as a human are searching for a health issue within your body, AI will be productive enough to find such problem and suggest that maybe here, even if it's not 100% disease, this might be a disease. So again, this is more pathology than norm. And in many cases, they would be misleading, finding the problems where the problem doesn't exist. All of that can be corrected. If you have a team of professionals working and collaborating with the same chatbot like we had with the spirometric examination, indeed, this was validated later on with our collaborative efforts with the Danish colleagues and German colleagues. But again, this difference in results in spirometric testing interpretation was very small, and definitely that was not definitive. And the final decision should in any case be made by the human being, by the health professional, who will be taking responsibility and be held accountable. Because again, any machine is nice. An automotive vehicle is nice as a vehicle for transportation. At the same time, this can be damaging human beings. Look at the statistics of road and traffic accidents. But using this equipment, using this machine in the appropriate manner is the responsibility and accountability of people. Thank you. And Olga, you can see you have some comments, and let me immediately suggest a follow-up question. In the recent Global TB Congress and the exhibition, there was a couple of manufacturers presenting the digital X-ray solutions And these designers of such equipment are positioning the place and role for artificial intelligence to integrate it into those machines that will be helping to find and see the norm and everything outside of the norm. And if that decides having any kind of pathology available on the X-ray image, that will be referred to the additional judgment and discretion by the expert. So the question is, are we prepared to believe? Instead of scrutinizing what is norm and beyond that, and again, in screening efforts, majority of cases will be within the standard of norm. So how do we make sure we are not missing any kind of anomalies? That's a challenging question. 3 weeks ago, our technical department manager consulted me regarding a letter. I don't remember the title, the name of that company which sent this letter, but they are offering a portable X-ray machine which is equipped with such AI generation module. And again, they were basically suggesting that portable X-ray device for screening purposes to be used for better population coverage. So again, this is the way that we are all moving into. And again, globally, we have a very strong HR deficit when it comes to radiologists. Take France, for instance. They have high salaries, they have lots of vacancies, particularly in Paris, and they understand they can't find HR candidates to fill in their vacancies. So definitely this is the vacuum which has to be filled by an alternative supply, and that can be matched by artificial intelligence availability. The same thing in Ukraine. So far, we're managing at the extent of our human capability, but yet the time will come when HR numbers will be growing short, and we'll have to make sure that we are managing the scope and scale of radiological examinations, making sure we are not buried in that avalanche. So definitely such systems should be designed, validated. We should be checking their performance because they are different in terms of performance, applicability, and we'll have to learn and use them. Also, we'll have to regulate them appropriately because there need some standards to be designed, some validation tools and indicators, because in the final run, there should be some accountability and responsibility. Will that accountability rest with the manufacturer or the applying party? That is yet a question, but one way or another, fortunately or unfortunately, we all will be arriving there. So understanding where and why and how does it work. As you remember, a couple of weeks ago, this was broadly advertised that AI is better in finding stroke among patients as compared to the HR professionals. China did this research and demonstrated that AI is more efficient. But the question is that this is kind of a laboratory setting. So again, we have a file for comparison, there are some inputs, and we have to find whether or not this indicates a stroke. We compared performance of health providers, we compared performance of artificial intelligence solutions, and again, the results were definitely in favor of AI solutions, but that would be analyzing only the set indicators and the limited number of inputs. And again, there would be the severity scoring, for example, and it was always exaggerated by the AI. And thus, looking at these well-defined aspects, we are leveling the scale, but the machine is inclined to excessive, aggravating, exaggerating results of their survey. And the reason for that is quite simple. If you have a nice machine, well-functioning, well-calibrated, so from technical point of view, everything works well. But what about the artifacts? For some objective reasons, we cannot remove the artifacts. That is one of the major challenges for AI models associated with radiology, because we cannot make the machine function well in the environment full of artifacts. We can screen that out based on our experience. And that explains that radiologists will have to stay and live and survive in clinical environment. And this is exactly why telemedicine is not quite helpful, because this is a matter of you being here and now in this multidisciplinary team, serving your role and duty. Of course, there are some trends, there are some opportunities, we continue discussing them. Well, this will be a very interesting question to be addressed 10 years from now, because I'm confident that artificial intelligence is a nice tool, dangerous tool. In our modern world, unfortunately, it's dangerous. We cannot predict its behavior in the future. But again, it's like internet, it's like electricity some years ago. And again, I cannot predict the future. I can make some estimates and focus. And again, I can see that, speaking of the stroke patients, yes, we can see how they're moving, are they moving, and what that is clinically suggesting to me, and make some assumptions and then validate it via my observations and testing. And I do strongly agree that the role of a professional care specialist, radiology, pulmonology, everything else, it will ever be existing and important. But which tools will be used in our profession, that is yet an open question. My dear colleagues, let's imagine that tomorrow you review our conference, the record of our conference, and you have a Da Vinci robot manufacturer offering you a free of charge machine with AI augmentation. Will you accept it? Well, the Da Vinci robots, they don't have any AI modules. Well, speaking in general about digitalization in health and medicine, well, in that case, they are doing that regularly. We have regular visits from company representatives offering digital solutions, and we would be quite happy and open to consider some of them, even procure with funding available from public sources. Well, centralized procurements and public funding, I believe, is not currently available. But in any case, this was quite an optimistic note to wrap up our session. And with that, I'd like to thank all of the speakers. And I strongly believe, and this is not just myself, I'm looking at the chat, which is full of thank you notes and expressions. We don't have too many questions, but we have lots of thank you notes to the speakers and panelists. So with that, dear colleagues, let me express my hopefulness that you find us helpful. And throughout these 3 sessions we covered today, you find a lot of interest and usefulness. Maybe there was some information that would encourage you to make relevant clinical decisions. And as Mr. Oleg said, quite rightly, namely multidisciplinary approach as part of multidisciplinary team, that will be the type and manner of performance which can never be replaced by any artificial intelligence, because your clinical judgment, your clinical reasoning as a professional in your area is critically important for making the right decisions, especially in challenging environment.
So much, and then it was very much needed for each and every one of us. We've heard something, and then our colleagues who probably heard something, and then our dearest participants of the conferences and the conference today will be people are asking about the tests and certificates as well. The testing will be available tomorrow after the conference will be over, after this 3rd or the sixth session. Every day we will have 3 clinical sessions will be conducted. This is why we are waiting for you tomorrow at 10 o'clock. Please join in before so that you can check the video. And we will be having, in the same way, I think that tomorrow will be as interesting as we had today. And I'm writing the test, and then 70% of the correct answer, you'll get the certificates, and certificate will give you 9.5 points of continuous professional education.
Ще раз всім дякую за увагу. Всього найкращого, тихого вечора і до зустрічі.
Have a wonderful evening and see you tomorrow. We will be continuing to move on. Thank you so much.